Systematic review is so fresh. It's from May this year, from Guy Martin, 38 papers, also 1,900 patients. You can see how many retrograde procedures, primary retrograde access in 45% of the cases, majority second line following failed antegrade access. Complication rate was total 11% and puncture related 9%. Why I show 7 and 4? Because popliteal puncture was used 25% of the cases, but observe with 50% of all the complications. When we remove the popliteal puncture, the total complication is 7% and the puncture-related complications are 4%. When to do a retrograde access, this is a game of words. If you cannot proceed antegradely, then you go retrograde. So in failed antegrade access, in the past I struggled a lot to go antegrade, but when I adopt the retrograde technique, I give myself 10 to 15 minutes and then go retrograde or switch to a re-entry device. But the re-entry devices are very not so cheap, so the cheapest re-entry device is the retrograde puncture, to my opinion. Retrograde access we use also in challenging antegrade access anatomy, morbid obesity, inability to lay flat, hostile groin anatomy, long CTOs, and so on. Where to do the distal puncture, the retrograde puncture? The most commonly used sites, this is a wonderful illustration from Schmidt, are the distal crural arteries, the dorsal pedal artery, the posterior tibial artery, and my favorite access point is the proximal ATA, and of course the peroneal artery. But from this meta-analysis of Silvestro, you can see here the anterolateral approach to the TPT, tibio-peroneal trunk, and the distal popliteal artery through the interocean membrane. This is the popliteal access. The patient is in supine position, and you can use, where we surgeons make our access below the knee. This is the place to puncture. Nowadays, it's more and more infrequent to use the patient in prone position to puncture the popliteal artery because there is so much complications. And of course, we have to mention the our Italian friends, Mariano Palena and Marco Manzi, and their extreme below the knee interventions, as you can see here, transmetatarsal or transplantar retrograde access to the crural arteries. Why to do that? We use, this is the C-top classification by Mustafa. We have 4 types of caps for the occlusion. Type 1 is the easiest to go antegrade. Type 2, you can go antegrade or retrograde. Type 3 is the meanest of them all. As you can see, you always maybe go into dissection and have to use different techniques, safari, cart, and so on. And type 4 is very suitable for retrograde access. But there are some procedures where distal access, retrograde access, is obligatory. This is a case of mine with using the Presto technique for implantation of Supera. As you well know, Supera is a very good stent, but you know where to start and you don't know where to finish. So the Presto techniques is giving this opportunity to implant the Supera from the ostium of the superficial artery, not to overlay the deep femoral artery, and the retrograde access is obligatory for this technique. As you can see here, I'm using this technique sheetlessly with the Supera, and this is the final result with the Supera implantation from the ostium of the SFA. How to do that? First of all, you have to plan your retrograde puncture site. You have to choose which crural artery or pedal artery to use. I strongly recommend ultrasound guidance for some of the cases. This is distal SFA. You can use the ultrasound guidance. You can use it for posterior tibial artery, for dorsal pedal artery. What are the advantages? No X-ray, no contrast, real-time visualization, and of course better accuracy. Under fluoroscopic guidance, you can retrogradely puncture, as I showed you, the TPT, the tibial peroneal trunk, proximal ATA, and peroneal artery. I always start with a workhorse wire. My favorite workhorse is O18 command wire, and sometimes V18. This is my preference, the sheetless approach. I use braided support mainly, CXI or Navicross by Terumo, but the Carnelian from Biotronic is a very good support catheter too. For the above the knee lesions, usually I finish with antegrade finish. For the BTK lesions, you can finish the case in a retrograde fashion. This is a typical setup, the antegrade puncture. This is a 5 French fortress, and the distal puncture, as you can see, the proximal ATA. This is only the guide wire. The braided catheter will follow afterwards. And this is typical posterior tibial artery access, just at the ankle level. I always use this 4 French sheet. It's in fact a slender sheet from Terumo. It can accommodate a 5 French device. And this is the angio for when I go in the posterior tibial artery, and this is the Navicross here. Some interesting cases, so-called assisted retrograde puncture. This is by Dr. Risa, first described. When you make the pedal whoop and you have no support to continue with the posterior tibial artery, he puts a small balloon and just puncture the balloon and continue in retrograde fashions with enough support. And this is a case from our friend Theo Business, so-called modified Schmidt technique. He uses, when he cannot puncture the pedal artery, he uses continuous injection of contrast. When he managed to puncture, as you can see, the contrast comes out of the needle, so he knows for sure that he is in the artery. I want to show you one case with a primary retrograde access. This is a 70-year-old female, Rutherford 5, arterial hypertension, diabetes mellitus, obesity, smoker, ABI 0.36 only on dorsal pedal artery. This is the CT. As you can see, a relatively short occlusion, easy to pass, and only one vessel runoff. But this is the other view. Impossible antegrade access. The retrograde access will be very challenging and maybe with the complication. So we choose to go retrograde primarily. This is a 4 French sheet from the dorsal pedal artery under ultrasound guidance. And this is the crossing with, of course, with the command 18, and this is Navicross 018. We crossed relatively easy this occlusion. We made a dilatation with 4 and 5 millimeter balloons, and this is the result. But as you remember, I used ultrasound, so I take a look with ultrasound at this segment, and it was very bad on ultrasound, so we have to stent that. I used, fortunately, the guys from Biotronic gave us Pulsar T3, which is a 4 French device, so we can go retrogradely with this. We implanted a stent, 5 by 80. After the dilatation, the post-dilatation, you can see the final result, very good, and the one vessel runoff. So the conclusions after the data we have: first of all, this is a safe and feasible procedure with low complication rate, very good primary technical success, as you can see from the meta-analysis. Technique has evolved over time. Bailout technique or primary access route in specific cases. A must-have technique for modern endovascular specialists. Success related to patient positioning, puncture site, lesion anatomy, of course, the device size. And finally, retrograde puncture is more than 30 years old of age, but unfortunately, many endovascular specialists are still afraid to embrace it. So thank you for your attention.
Next presentation will be Dr. Nikolov, below the ankle revascularization, why, when, and how.
Can I have my slides? So, thank you for the kind invitation, Professor Petrov. This is a topic which should tell us where the limits of our practice and why should we discuss where is the place of below the ankle interventions. You know that CLI is a multi-level disease, and there is a high incidence of amputation without revascularization. And because of the aging population and more diabetic and dialysis patients we have to meet nowadays we have more and more distal distribution of disease. So the enemy is changing. Ferraresi very well described the distribution of the disease, and he shows that more than 50% of the CLI patients have 2 or 3 big foot arteries diseased, and in 25% of CLI patients the pedal arch is engaged. So why should we do BTA revascularization? Kawagara very well shows that the status of the pedal arch predicts the wound healing of the CLI patients. And for example, the type 3 pedal arch is, these are the worst patients for wound healing. So another paper from Shiraki, also from Japan, shows that treating tibial vessels only when there is significant disease of the pedal arteries results in suboptimal wound healing. So this is good, but what we can do if we perform angioplasty distally? First, Manzi shows that pedal plantar loop technique is feasible with 85% technical success, and it is also safe and provides positive clinical results in at least in short and mid-term. Another big series of patients, over 300, published by Nakama and colleagues, evidence that the speed and extent of wound healing is improved with below the ankle angioplasty. The most current evidence include one systemic review and meta-analysis of 10 studies with over 500 legs with BTA disease, and it compares the BTK plus BTA angioplasty with BTK only. The limb salvage is very good, it's 92% for 12 months, and the important message is that BTK plus BTA is not worse than BTK angioplasty only for limb salvage and amputation-free survival. So why should we do it? Because we know this is CLI patients and they need revascularization, otherwise they will go to amputation, and because the results are promising. When? Or otherwise said, should every patient with BTA disease receive angioplasty below the ankle? My personal opinion is that the simple answer is no, because these are very small and fragile arteries prone to spasm, dissection, thrombosis. In diabetic and end-stage renal disease patients, especially calcium is a very big problem. And we don't have data on the restenosis rate and the long-term follow-up of these interventions. So what is my personal practice? I go below the ankle only if the patient is class 5 or 6 Rutherford classification. And first, I always try to treat as much as possible the proximal lesions. One of the scenarios is to go down if the outflow of the proximal reconstruction is poor. If we see slow flow or insufficient collaterals, I will try to demonstrate it with this case. This is a diabetic patient with third toe gangrene, occluded anterior tibial as well as peroneal and distal posterior tibial artery. The angio of the foot is poor. This is injection through the anterior tibial below the occlusion. We did angioplasty of anterior tibial artery, but the flow was so poor that we had to do again new injection at the ankle level. You can see there are no collaterals at this point and very, very short but calcific occlusion of the dorsalis pedis. It was impossible to cross it, so we punctured this very calcified and visible first metatarsal artery. We succeed to go up, and after that perform angioplasty of the dorsalis pedis artery with this final result, very good flow of the anterior tibial, which is there because of the good outflow of the dorsalis pedal artery. So I'm a little bit conservative, and I don't want to try every time to dilate below the ankle arteries. So in other cases, when the flow is good after intervention of the proximal lesions, I leave the patient and follow up the status of the wounds and the clinical status, and if the result is not satisfactory, then proceed below the ankle. This is a case of 75-year-old female with diabetes, hypertension, dyslipidemia, with necrosis of the fourth and fifth toe. You can see there is a popliteal artery stenosis and occlusion, also very diseased tibial vessels. This is angio after passing the occlusion and directing the posterior tibial artery. We performed angioplasty from the ankle above and achieved this result, which is much better than before. But still there is some disease at the level of the ankle. It was difficult to cross it antegrade, and we decided to stop and to follow the patient. The next morning she had palpable posterior tibial pulse, warm foot, good refill with ankle brachial index over 1. But unfortunately there was persistent local pain, the foot necrosis enlarged, possibly there was an infection. We decided to do another angio. The result is contained, but there is a problem at the ankle level. It was again difficult and impossible to overcome this tiny and tortuous posterior tibial artery. So we go for retrograde recanalization of anterior tibial artery, and after that ballooning the whole anterior tibial. More aggressively in this case, cross the pedal arch and perform angioplasty of posterior tibial, the arch, and the dorsal pedis artery. So this is the final result, much better than the first one. The other cases in which we had to go below the ankle are in situations where there is nothing to be done above the ankle, so the primary problem is below the ankle. This is a case of the diabetic patient with apical necrosis of the first toe, very good patent anterior tibial, occluded posterior tibial, which was attempted 3 months earlier unsuccessfully. You can see that at the ankle level there is only collaterals, no vessels at all. It's very important to have the ability to perform different projections like is shown. So we are able to cross the dorsalis pedis and engage this small metatarsal artery distally, and after ballooning with 1.5 and 2 millimeters balloon, achieve this result, which is not so perfect, but the clinical effect is okay. So in conclusion, pedal artery revascularization is safe and feasible procedure. There is no significant difference in limb salvage and amputation-free survival when BTI intervention is added to BTK angioplasty. The literature says that wound healing rates are higher and time is shorter when additional pedal artery revascularization is performed. And BTI intervention should be a part of the armamentarium to treat COTI patients. In my opinion, less aggressive approach is advisable, at least in the beginning. Thank you.
Next presentation will be by Dr. Zoran Stajkov, pedal approach for CLI patients.
Good morning, dear colleagues. Thank you for the pleasure to be part of this big meeting. Thank you, Professor Petrov. The critical limb ischemia. My retrograde approach for the peripheral artery disease in the patient with critical limb ischemia started with patient with critical limb ischemia, and this is it's for when we can tell why patient is the critical limb ischemia, ankle pressure above 50 millimeter, and I don't want to talk about the critical limb ischemia because we know everybody what is what is the solution for this patient. The first solution is surgical during bypass and endovascular treatment. Now, in the data from the clinical practice and trials, no difference about bypass and endovascular therapy from the multi-center randomized trial and some single-center experience. This is the proposed how we can do in this patient. We see the endovascular and open surgical technique. It's alternative with the same result. For the patient with great limb ischemia, it's the recommended percutaneous catheter direct thrombolysis and type 1A. This is other meta-analysis. Let's go to the truth. When I take the tibial approach, I always use the angiographic method because it's not necessary more technique on the cath lab, and it's faster for me. When I puncture the artery, I use 5 French sheet always. I'm not working sheetless. I implanted only stent sheetless. This is the first case, 68-year-old male, peripheral artery disease, ischemic heart disease, with the previous stent implantation of the both femoral artery. After SARS-CoV infection 3 months ago, with critical limb ischemia from the last hours. This is the angio. We can see thrombosis of the both stent in the femoral artery and very low flow distal. I tried to cross from the proximal, but I can do, and for that I'm going from tibial approach, using the posterior tibial artery. After that, I crossing from the distal stent thrombosis, crossing for the 2 stent, balloon dilatation from the distal on the occluded posterior popliteal artery. And this is the final result for the femoral artery, final result for distal and popliteal artery, and the tibial artery. The next case is the 65-year-old male, peripheral artery disease, again stent implantation. This is the angio. We see so much collaterals from the proximal zone of the occlusion. And for that, I'm going from the distal, again from the tibial artery, posterior, balloon dilation in the popliteal zone and distal femoral artery. And after I am recanalization the popliteal artery, I see the tibial anterior artery. It's with short occlusion in the osteoproximal part. From the tibial approach, I'm crossing with the wire in the anterior artery and inflate the balloon from the anterior to the posterior tibial artery with very good result and recanalization of the both of them. This is the next case, patient again with peripheral artery disease after reconstruction and of femoral artery, common femoral artery, and superficial femoral artery on the left side. After bypass and with stent, I think that this patient is with 6 or 7 procedure for revascularization and reconstruction. With critical limb ischemia, we can see the angio. Can you please play the... yes, thank you. We see occluded long stent in the femoral artery and occluded femorodistal bypass. We see only little contrast in the tibial artery, but the posterior tibial artery is with a very calcified zone and with subtotal occlusion in the distal part. after the puncture the artery, because the subtotal stenosis, I put the 0.14 wire, and after that with coronary balloon 1.5 and 2.5 of 25 millimeter, I predilatate all of the zone for the put the sheet, and after that I'm going with the recanalization of the occluded femoral-tibial bypass. After series of the predilatation of the all occluded zone of the bypass, and because I see the thrombus of the one of zone of the bypass, I take from the tibial approach 5 French Judkins Wright catheter and do it mechanical thrombus aspiration of the bypass. This is the final result with very good flow. It's still, we see the ostial stenosis of the peroneal artery, but for this step of the procedure, it's enough because the patient is not in critical ischemia. In the conclusion, the pedal approach is safe and effective treatment option. Alternative endovascular option in complex peripheral pathology, and CHAPUS every day on the self-equipment. Thank you.
Okay. Thank you, Dr. Stankov. Do you have, colleagues, do you have some questions regarding the recent presentations? I have one question for both my colleagues about the retrograde access for pedal access. Do you use some vasodilation, some drugs?
No. It's the same to the radial artery, but I don't take because when the patient is with peripheral artery disease, the artery is very calcified, and I have only one spasm of the artery in my practice.
Okay.
I don't take.
For good angio, which is very important in every procedure, I usually use nitro in antegrade first angio. And it depends. Some of arteries are calcified and they will not really respond to vasodilators, and other need vasodilators. Okay. So it depends.
Okay. Actually, I have a question to 3 of you. So I have seen a method which is very interesting with the continuous contrast flow. Did any one of you use that method? Because it seems very practical. When you do the retrograde puncture, it doesn't matter. You go with the tibialis anterior, posterior, or below the ankle. So it is very difficult if you don't use an ultrasound. Okay. So sometimes you have to do it with distal subsection angiography, which is my method. And with the movement of the patient, it's very difficult to puncture the artery. So I think a continuous contrast injection could be a good solution. I just wanted to know if any one of you have done this method with continuous contrast injection. It seems here very, very wise and a solution for the problem with doing retrograde puncture.
Personally, I don't use this technique. It's a technique described by the colleague that should do the live case now, the business. But yes, it's very, very effective technique.
As a cardiologist, I don't, personally myself, I don't like to use ultrasound because we always want to finish everything in the cath lab. So we depend on the fluoroscopic images and the fluoroscopy. So sometimes it takes time, and you get annoyed when you cannot get into the artery. So it could be a good solution with that one.
So for the wife case,
if you allow me, in fact, Şevket, we are using both calcium roadmap and contrast roadmap. So both are very helpful. In most of the cases, I would say more than 90% of the cases, we wouldn't need ultrasound guidance. Because, like Dr. Stankov mentioned, in more than 90% of the cases, the tibial arteries are really very calcified. And with high resolution angio, they are relatively easily visible. And probably there are different individual practices, but this is our practice, and the success rate is, the puncture success rate is more than 90%.
Yeah, there is nothing about the success. We somehow succeed to puncture the artery. That's not the problem. But to make the procedure easier, to have a better and more practical approach for the puncture, I just wanted to make a quote and a remark regarding this method, and I just wanted to know whether of you have used it. So you're right. If the artery is calcified, then there is no problem. You can get in somehow. But if the artery is not calcified and the patient is always moving, and if you do it under the subsection angiography, then there is a problem. And you always inject a lot of contrast. That's my concern. If the patient has renal insufficiency, we somehow get in 5 minutes, in 3 minutes, even in 10 minutes. But you have to always inject contrast. That's the problem. And you increase the contrast load of the patient. That's my concern just.
Can I ask one question, Dr. Stankov?
Yes.
What about the complications of the tibial axis with 5 French sheet? Do you have some?
No, we not have.
Do you check always the site?
On the Doppler. With the ultrasound, we check every patient after remove the bandage, compressive bandage. 3 hours.
You are using external compression for hemostasis or intraluminal balloon? Or
No, compressive.
Only external compression?
Yes.
If you allow me, in fact, in the beginning, we were inflating as a final step of the procedure. We were performing long
balloon
inflation of a balloon, and more than obvious, it's a good idea. For the last time, we didn't see a problem with simple manual compression over the puncture site without occlusion events. And Dr. Stankov didn't mention, but probably one of the biggest advantages of the, let's say, distal approach is the possibility of thrombus aspiration. He showed one of the cases that the bypass was full of thrombi, but not only in this situation, because the distal access is the most distal one. So this is the site where all the debris is going. So it's a good idea finishing the procedure, and even more like for the AAA endovascular intervention, we are creating flow with slow aspiration. For the completion angiogram, sometimes we are slowly aspirating from the access sheet in order to create flow. And this is also played the role of extracting the debris.
So then you use micropuncture sets for the access always, or just the radial needle?
Radial needle.
Radial needle. Micropuncture sets are very efficient, and they would also make the procedure easier than the radial. Sometimes the radial needle is even a bit bigger for the artery, so you need micropuncture sets. I always use micropuncture sets. And do you also use coronary wires for doing the procedures, coronary CTO wires? For example, when I go with the first access, I always go with a Filter FC because it's a polymeric wire and you can go right into the artery retrogradely. And sometimes the another thing is, it's a tricky one, you get into the vein sometimes, and you have to be very careful where you are. You have to always confirm that you are in the right place and not in the vein. So it's very easy to get into the vein retrogradely sometimes.
Okay. For the last case?
I see. The live case, they are ready.
Theo, can you hear us?
Can you hear us?
Yes, we hear you.
Perfect. Please, Nikolai.
Okay.
Dear colleagues, we have the pleasure to work here with Professor Bizes today on a very challenging case of below-the-knee occlusion. I've made a short presentation, maybe you can put it on, but we have a 72-year-old male who is complaining of short claudication. 6 months ago, he underwent open surgery for acute occlusion. So this is done by below the knee incision and the separate incisions for the anterior and the posterior tibial artery. Yesterday, when I spoke with the patient, he shared that his anterior wound was not healing properly several months after the operation. So this puts the patient in another category. So now, Professor Business will tell you some more about our strategy.
So hi everybody, thank you for the kind invitation and thank you also for the hospitality here in this cath lab. This case is a challenging case because we have the endarterectomy of the popliteal artery. So we have the stent has no stenosis, we will see now the angio. And the point is, we don't know what happens with the PETs. Not with the PETs, with the reconstruction of the artery. If we have thrombus incisors, the outflow is really very poor. We have only a patent tibial artery, and the posterior tibial artery has contrast agent at the distal part through collaterals from the fibular artery, and we cannot really assess what happened with the distal part of the, let's say, with the pedal artery, with the dorsal pedal artery. Can we see the angios just to show? Here is the situation. You see the occlusion at the level of the T2 segment. There are some few collaterals. Then we have a patent tibiofibular trunk with a patent also origin for the anterior tibial artery, the next one. Then we have some collaterals. Can we go one back? Here you are. Okay. So you see some good collaterals that provides blood into the fibular artery. The fibular artery has a high-grade stenosis. This needs to be treated, and then a slow flow, probably due to the fact that we have the sheath inside the SFA up to the stent. And go next one. The anterior tibial artery seems to be diseased, and then through the fibular artery, you can appreciate some collaterals to the posterior tibial artery. The patient moved at that time the forefoot, but you can appreciate that the posterior tibial artery probably is the vessel that at the moment saves the foot. So what we have done here is that we have already inserted a 6F Fortress sheath, the sheath from Biotronic. You can select whatever you want. The point is you have to go as distally as possible in order to have enough pushability. So we are now up to the end of the sheath, so we cannot go further distally. And then we decided to go for a support catheter. We are using the Cornelian catheter from Biotronic, which is an 018 platform, and through this a Command 18 wire. So the strategy now is to try to penetrate and to advance to penetrate the proximal cap of this occlusion to assess how smoothly the wire will get through the lesion. This is the so-called traversal wire test. If it goes very smoothly, we have high suspicion of thrombus. And then to support everything with a cornelian catheter. After this, we will do a small angioplasty with a small balloon, 3 millimeter. We want just to make a small channel, and we will decide how we will go further after the angio. You can go further. Okay. Now Nikolai will go further. Perfect. And here you see it goes relatively smoothly. Let's see here what happened.
Okay. Do you want to make an angio here to see?
Yeah, let's go further a little bit.
Okay.
Okay, you are probably in the anterior. Try to.
Yes.
So you see he rotates very nicely the wire. I'm going further.
I'll try to rotate it down.
Let's make a small angio here to see what happens.
See where we are. Okay.
So it was very smooth. We have no backflow. Let's see. I will do first an angio from the sixth, just to see how closely we are to the. Okay, we need a little bit more. Okay, let's try further. So if you don't have any backflow, don't try to do any kind of angio from the support catheter, because the contrast is staying inside the lesion. It causes only problems, and maybe if you are on a dissection membrane, you may make it really more difficult. You see how it looks like. We have to further work on this. Let's go back and go further. Okay, here you are. It looks. Let me go. Let me come. Stay. Keep the wire.
Okay.
Okay, here you are.
Again, going.
Go back. So we have to. Can you show me the angio that we have done, just to make a marker? Here you are. So the beginning is the part of the fibula.
Can we work on roadmap here?
Yeah, let's do the roadmap just to be sure that we are probably going into this collateral. Yes. We will see now. Tell us when we are ready with the roadmap.
Can we use the roadmap?
Okay.
Okay.
It doesn't here. Okay, it's good.
Regarding the wire you are using?
Command. Yeah.
Command.
This one.
Try something.
Okay, of course.
So. Here, this loop is not really the best thing that you have to do. Let me go a little bit with a loop. This is probably the cap that you have to penetrate. And then you are probably right in the fibular artery. That is what we want to go. Go a little bit distally. Okay. Let's see here. Here's the collateral. Probably you can go back. Okay, let's remove the wire just to see where we are.
Okay, we're removing the wire.
So here there is now backflow. That is a very good sign. And this is what we need to have. Give me a little bit contrast.
There you are.
Okay. Always aspirate. Okay, this is the posterior tibial. That's fine as well. Okay, perfect. Great. Okay, let's put again the 018. And let's open the first balloon, the 3 millimeter balloon, just to do a vessel prep.
Are we going into the perineum, or we can stay in the posterior?
I will say let's take the posterior.
Okay.
Because at the moment it matters to open.
Okay.
Let's go down further. It's okay. Here is enough. Let's go a little bit further. Doctor?
Yes.
This is an 018 wire. It's not the best thing. Let's go here. Here's probably collateral.
Yes, going to a side branch.
Yep. Let's go back. That is better.
No.
Okay, let's go up to that level. No. I'm trying to go very controlled. Probably we will see where we are.
It looks promising.
Yep.
I'll go further down. Okay, that's the pistol.
Probably we will see. Okay, let's do an angio.
Okay.
Because this is a 90 millimeter balloon, and it's okay. Okay. We cannot see anything, it's closing. Can we change for a longer support catheter? Yes, please. Yes, yes. 100, the next long. You can remove one. Okay, forgive me. Okay. Okay. The wire is long enough? The command is the long? Okay.
Absolutely, yes.
Let's see where we are. So it is good that we are down to this part. We will see if we are inside the artery, but it seems that we are in a right position because you see here the artery, it goes directly to the posterior. We will stop here. Okay, that's nice. Good. We will check just to be sure that we are inside, even we will see that everything is fine, because the command 18 is an aggressive one, but I'm pretty sure that we are in the right position. The posterior tibial artery was also the most important runoff. So do you have any question until we have the catheter, the support catheter?
Are you planning to change the wire? With which one?
At the moment, not yet. So we can do this to change the wire, but I'm also starting using more frequent in O18 wires for below the knee, especially if we have patients like the one here with relatively big vessels. So, we will see. We're going to use a 3 millimeter balloon, and we will see. But do we have a command 14?
Yes, we do.
Okay, we will see. Do you have 2 millimeter balloon catheters or? Okay. Due to the fact that we have 2 millimeter balloon catheters and they cannot go through the. Let's see where we are now.
Yeah, I believe
Here?
we're down here. No. That's what.
That's
on
right.
the tibia.
Okay. Now it's going to be a little bit.
Then you feel safe ballooning over this wire.
Go inside. Okay. Sorry, I couldn't hear.
You feel safe ballooning over this wire then?
Yeah.
Because you are now in the distal part of the posterior tibial artery, so it seems a bit. I have some safety concerns. Maybe it's better to go with the microcatheter till the end and then change the wire.
This is a support catheter. The support catheter is one of the safest, let's say, ways to check this everything here. Yes, yes, please. And now I will change for an O14. Let's see, however, if we are in the right position. Important is always to see in different. Okay.
Do you want to make an angio?
Yes, please, an angio.
Okay.
It was a nice crossing, though.
Yep.
Nice demonstration.
Don't move.
Не мърдай, стой спокойно.
Okay.
Okay. Okay.
Yeah, it looks good.
You're definitely in.
So, command 14.
We have small.
Perfect. Here you are. What is your workhorse wires? I mean, I really like the command wires 18 and 14.
Okay. Моля те, не мърдай. Моля те, стой спокойно.
Is this a support catheter O35 or O18 or 14?
It's O18.
I can't.
O18.
O18.
O18. Okay, go ahead. Loop is fine. Okay, you can remove it.
Okay.
And then we will start. You can open the tube. Perfect. Perfect. So we're going to use, which one? The Paseo 14 to 140, just to go to do first dilatation to check what happens. The point is, it could be a very good reason why this reconstruction was occluded, that the outflow was not the best one. Only with a fibular artery with an occluded posterior tibial, it will be the reason.
I'm only worried that the O14 guide wire won't give us enough support because we have difficulty passing through the thrombus with the supporting catheter.
It's time to assess the efficacy of Paseo 14.
Exactly.
Yeah. So let's see what Biotronic says, if this really has good trackability. So I think that it is crucial here to open one of the three vessels, because the fibular artery gives some branches, but I don't think that would be enough. And even if we have to stent further the popliteal segment, then we may need we put at risk the new stent. So I think we need at least one good patent vessel up to the forefoot. And due to the fact that the wound is on the inner part of the foot, I think we need some kind of more blood at that level, just to have also a healing there. So, do you have the wire? Okay, it's fixed. Yes, of course. Perfect. I think the vessel was patent up to it was closed up to the ankle. We go as distally as possible. Here we have some difficulties. Let's see. Okay. Here you are. Just keep the wire.
Okay, it stopped here the last time.
I'm trying to do this.
Do you want to make a small inflation here just to open?
Yes, let me try to go as distally as possible.
The guide wire is going a little bit out.
Okay, put the guide wire inside.
Okay.
And now let's do the first. Okay, let's see.
Well, it's kind of difficult.
Okay, go back. Here you are.
Was that an ipsilateral approach, access, or contralateral? I missed it.
It's under great access, ipsilateral. Okay, let's do the first balloon.
Okay. Starting slow.
Yes.
We are on 6 now.
Go further, 8, just to open.
Okay, it's safe. That's some air inside.
An ipsilateral approach is wise because if you want to go around the arc, sometimes if you go contralateral, so you don't have enough space with your microcatheter, with your balloons, and then you have trouble if the patient is a long one. So when you have the intention to go below the knee or below the arc, so ipsilateral approach would be always more appropriate than the contralateral one.
The nice trick of Nikolai that he opened first. That means it makes a channel. Okay, let's open again.
Okay.
Try to straighten the balloon.
Okay.
Perfect.
Down.
The balloon is 2 point what?
Sorry?
The balloon is 2 point what? The length?
2.150.
Okay.
Well, 140, sorry. Let's go further.
Okay.
It gets better. And go
Can you give us during working a bit information about your wires, because these wires are not familiar to me, so I use always the wires from the Asahi and CTO wires for the coronary. So the command wires, the 018, 014.
There is a command wires from Abbott. There is a platform for there is a platform for 018 and 014. I cannot recall how much is a gram. I mean, what is the weight of the wire?
It's about 4 grams, I think.
I think as well. So, and in our opinion, this is one of the best wires to really advance through this kind of lesions. If we are not able to go with a command, because it has very good steerability, and if you cannot go with the command, then we are changing for a Asahi wire like a Stato, where we need more grams to penetrate really calcified lesions. But for this fibrotic or highly stenotic calcified lesions, is one of the best wire at the moment at the market, according to, of course, to my opinion. Let's put out a zoom out.
Yeah, in my armamentarium, I have over 10 wires, so I can use them and change them. But when I see operators doing this with command wires, they rely on just 1 or 2 wires. The command wires, they like it so much. So I wanted to know what the features of this wire is.
Yeah.
So we can use Regalia, we can use Gladius, we can use Gaia PV, and sometimes if you have a calcified lesion, we can use Albert. So we have a lot of options with the Asahi wires.
Even if it's an 18.
Even
So we will now
Filmer XT.
Sorry, go forward, I'm sorry.
No, I'm just making some talk and filling the gap, so I'm just talking.
What do you think about the tendency to undersize the balloons below the knee?
Yeah, sometimes it's a concern, but if you have underfilling, you don't know the actual vessel diameter. So ballooning with the smaller one and then going up further, I think it's the wise action, because if you have a dissection and the flow limiting dissection, that's not what we want below the knee. So I think 2 millimeter is okay. Maybe with nitrate injection and then doing an angiography, you can further decide what kind of balloon you want to use for further ballooning. So I think beginning with the two.
Would you use ISEVS to size precisely the balloon?
You say ISEVS?
Yes.
No, I don't use any ISEVS below the knee, but it's wise, it can be done, and it will give you an actual information about the vessel diameter, and so you can go up safely with your balloon. It's safe, because this is a total occlusion. The artery is underfilled, and so you need the proper size of the balloon to have the best result. So ISEVS, it could be good. Do you have an ISEVS option? Would you do it? It would be very interesting if you have ISEVS.
Well, I'm not pretty sure, but we can always ask.
It would be very interesting.
If you allow me, I'm Ivo Petrov. I'd like to suggest to inflate a little longer. So short inflation in such a diffuse calcific and atheromatous pathology is not a good idea. So you are working like just for predilation. In case you want to have a definitive result, it's better to inflate a little longer, at least 30 seconds.
Yes, you're right, but at the moment we don't need to make any vessel prep. We need to open the channel. So for these reasons, we don't need to do for 30 seconds, because this balloon is even not touching the wall.
Okay, so this is predilation.
Yeah, this is a 3 millimeter. The other one was 2
channel
millimeter.
opening. Channel opening.
Yeah,
okay.
Channel opening, exactly. For the vessel prep, you are absolutely right, and you will see. We go now for a 4 millimeter. You can open. We can go for a 4 millimeter. Because at the moment, our big concern is that if we have any thrombus inside this reconstruction. So when we are doing this, we are going now for a 4 millimeter balloon. And then after the 4 millimeter balloon, we're going to stay a little bit longer.
Do you plan to use a scoring balloon or chocolate balloon?
Yeah, probably chocolate balloon, but we will see now how it looks like. Do you have the chocolate?
Yes, we have chocolate 580.
That's good.
The proximal part seems a bit calcified, but you can also do calcification in the total occlusion part, but your wire was so easy to go. I think there was also some kind of thrombus involved in that total occlusion.
We will see now. Okay. It's not bad. Okay.
Okay. This is after 3 millimeter balloon.
Yeah. I would say let's go for a 4 millimeter, and then let's go for a 4 millimeter.
What Ivo says is essential.
In my opinion, I will go now for a 4 millimeter to open a little bit more the proximal part of the lesion, and then afterward we will decide if we're going to go for a chocolate balloon. At the moment, I don't see really any suspicion of thrombus, but who knows?
I think you have to protect also the anterior tibial. It's going smaller and smaller.
Okay.
So what Ivo said is essential with long inflations. So my choice is always do it at least for 1 minute for the preparation. But as the operator said, if you want just to see the flow, that's the reason why he had so short balloons. I think he will go with the longer ones after this.
So let's put the 4 millimeter and let's
But
see what happens.
the perineal trunk is very important. You don't want any dissection there. So you have to be very careful there, because if you have a flow limit in dissection, no one wants to stent that area. It's an awful area. If you go with a stent there, you have a lot of trouble.
The
We have,
tibial
when we have to do it, then we do it, but
surprisingly large.
that part.
We've measured it before the operation more than 4 millimeters. So,
However, I would disagree with you regarding the stenting of the tibiofibular trunk, because the current evidence shows that if you're using drug-eluting stents, balloon expandable drug-eluting stents at that level, actually they have amazing patency. So, in contrast,
Your occlusion begins in the popliteal area. With the perineal trunk, you are right, yeah.
Yeah, tibioperoneal trunk.
You are right there. But the occlusion begins on the popliteal area, so
Yes.
you are ballooning now that area. I mean, at that point, it's not what we want.
Okay, good thing.
Is
So
it
now
cho-
we will
is it
say
chocolate balloon?
No, not yet. This is a 4 millimeter, just a 4 millimeter balloon. In case that you are in trouble and you have concerns about if you have thrombus, the best strategy, if you don't have distal protection devices, if you don't have any thrombectomy devices, the best protection would be to go slowly and to starting dilating for 3 to 4 to 5 millimeter, just to try to not to really fragmenting the whole clotting side. And we will see how it looks like after each angioplasty, and then at the end we will decide if we go for a stenting or if we have any other trouble here. An alternative could be to give some RTPA inside the thrombus. There is a nice trick that we have now discussed before, to take a pigtail catheter, to use the 018 wire, to use a side port through a T-burst, and then we are using the side holes of the pigtail. You are providing contrast agent just to see how it looks like the lesion. This is very nice if you have really big vessels. If you have thrombus, you will see the contrast stain inside the lesion, and you have a very classical picture of the thrombus. And at the same time, you can really inject, without losing the wire, you can inject some RTPA from the side holes of the pigtail. This is what we're doing, for example, in vein thrombectomies, where we want to go through the iliac veins. We are using the pigtail, we're injecting RTPA until we prepare the thrombectomy catheter. Is this penumbra or Rotarex or whatever you want? Then we are leaving enough time for RTPA to make the job. So, okay, let's open it a little bit to see what happened. I'll go a little bit down.
okay,
Because here was the biggest problem. Okay.
slow again.
Yep. So we have done a very interesting paper we have written together with Jihad Mustafa from the US. We have done some nice ISEVS measurements. And I have to say, in all the times, the ISEVS showed bigger diameter than the angiography. So especially if you're using drug-coating balloons below the knee, there is a nice, let's say, a nice quote from US, no touch, no drag. That means if you don't have really good diameter, then you will not have drag on the vessel wall. And this is one of the arguments why impact deep trial didn't work in CLI patients, because the mean diameter of the drug-coated balloons that were used there was 2.5 millimeter. And this is actually too small for the below the knee arteries. Okay. If you had the opportunity to do this, would you use drug-coated balloons for below the knee arteries?
So I used it in the past a lot, but when the data come, the evidence come with no benefit of drug-coated balloons below the knee, I use it more less. So,
Okay.
and in my personal experience, if I have some kind of thrombotic lesions below the knee, I experienced some kind of flow slowing after drug-coated balloons. And I wonder why that happened. If I have, after normal ballooning with the same size, actual size, no problem. After you balloon with a drug-coated balloon, and the flow comes worse. And my personal experience was in accordance with the evidence that comes from randomized trials. So I am more cautious now using drug-coated balloons below the knee, but that's my personal experience.
You want to try the chocolate?
Now is a very good point. Let's discuss about this because this is. Can we stop the picture here? If it's perfect. So you see here we have already dissection, or who knows whatever it is. This thing there inside. So the chocolate balloon will not give us now an additional benefit because we cannot really fix this kind of material that is inside. This is thrombus, is a dissection. We see a dissection against the flow at the P3 segment, just 1 centimeter above the anterior tibial artery. So this may be gonna cause problems in the near future. And at the same time, in the middle, the P2 segment, this area, in my opinion, is not the best to work. There has been an endarterectomy at that level. That means actually we don't have media there because it has been removed due to the endarterectomy. So we can put, let's say, a DCB just to, let's say, reduce a little bit the inflammation and all this stuff that has been through the endarterectomy. But in my opinion, we have to stent it.
Yes, you're definitely right. But what do you think? Should we use the drug-eluting technology before or after stenting?
Due to the fact that you don't know if it is a thrombus inside, I would use here first the stent and then the DCB.
Okay.
I don't know if the people agree in the audience and in the panel.
I think we
It is
could
a
go.
very
I think we can go with the chocolate balloon if you have that for a more balloon inflation. At least give a chance for that region, because if we stent that region, the P2 segment, I think we will have not good results in the short and the midterm. So I think we have to give that a chance with the long balloon inflation, maybe with a more scaffolded balloon, like a chocolate balloon.
Okay, let's try the
or
chocolate.
a scoring balloon. That's my opinion.
Scoring balloon is not a good idea. Give me the 5 and 120. Scoring
But
balloon is not a good idea.
you have always the chance to stent it after that. Already you wanted to stent it. So with the scoring balloon and longer inflation, there is calcium involved. At that part, especially, it's a very calcified one. So
you have to keep in mind this is a lesion that has undergone an endarterectomy. That means there is no calcification at that level.
Oh, okay.
That's the point.
Okay.
So I will use the chocolate. I will take
that region had undergone an endarterectomy?
Exactly.
Oh, okay. I missed that. Okay.
So that means there is no calcification at that level. However, we will try to open a little bit to do a vessel prep. I will not use scoring balloon because the scoring balloon has the wires outside the balloon, and this can really cause further fragmentation of the clot. The chocolate balloon, which has the cage inside, it's a very, very controlled angioplasty with the pillows.
Yeah,
so,
I mean the chocolate balloon. Yeah, okay. When I meant scoring, I meant with the chocolate balloon. Yeah, okay.
Theo, short question. If you have to stent, what kind would you use?
Well, actually, everyone would say here Supera, but I would not agree with this. In my opinion, there are very good stents, and due to the fact that the Supera has problems with opening due to the fibrotic lesion from the endarterectomy, I will use a classical bare metal stent here. But we will see. Look at this. This is the stenosis at that level.
Yeah.
That might be some error.
Hold some air.
I don't know.
Let's try.
It's possible. Let me get the air out.
Okay.
Let's try again.
But we can put a Supera as you wish. But I mean, I will even a pulsar stent will be nice here, or even a live stent from Bar. All of these stents are actually, from all the stents that we have in the market for P3 segment, the only one that has approval is the live stent from BD. Let's open it, go back, and we will go back inside. Just a moment. In the middle,
I have another
something.
question for you.
Yes, please.
You said the first stent, then DCB. For how long do you keep the DCB inflated after you have stented?
2 minutes.
2 minutes.
Here, okay. Put it here. Okay, and let's go back with the proceed.
Okay, yes.
Good. So we will leave it here a little bit. So something is wrong with the balloon in the middle, but it's not bad. Okay, leave it here a little bit. So chocolate balloon is actually a new good device in the market. Okay, that's fine. We have good results from the trial regarding dissection. This is actually the point. However, in my opinion, it doesn't work very well in calcified lesions. In calcified lesions, you need either debulking, or you need, and I'm talking about severely calcified lesions. Either you need debulking, or you need, let's say, a stent graft and a supera, so the so-called pave and crack. At the moment, in my personal experience, I have not seen any other method that work good in really calcified lesions. The scoring balloon, it's a good idea if you don't have, let's say, atherectomies devices or the ability to use covered stents. However, in really calcified long CTOs, I still believe as a vascular surgeon that a good vein is the best solution. However, I would like to hear your opinion about this.
Theo, can we leave you for now, just to take several
Okay.
one presentation and
As
to
you
come
wish,
back?
as you wish, as you wish.
Okay, okay.
Okay, let's open it. Maybe.
I would like to invite
calcified lesion.
a coffee break.
That's a good idea.
Just continue, Professor
You have
Petrov.
to ask the because otherwise, if we
Okay.
did they hear us? Did you hear us?
I guess not. No,
Okay.
Okay. If we are not talking here, it will be a very silent movie here. Okay, let's. Give us 15 seconds.
Ники, чуваш ли ме?
Да, да.
Докъде сте?
Ами, имаме нужда от 5 минути още. Раздуваме вече постериора. Оправихме много добре, стана поплитеята, сложихме стенд. Поплитеята е много добре, само трябва да оправим постериор с балон сме в момента.
Добре.
5 минути.
Разбрах, благодаря много.
I'm using the end of the coffee break in order to announce the result of the competition, poster competition from yesterday. It was quite difficult to choose which are the winners, because definitely the cases presented were very, very interesting. And like is the motto of our conference, there were head-to-toe interventions presented on the poster session.
Okay.
Hopefully, next edition, there are going to be even more participants, because I see that the level of the posters presented were definitely, absolutely very, very high. And thank you for all our colleagues who participated. So now, in order to remove the tension in the participants, I'm starting with the announcement of the winners. The third place is given to the poster named Endovascular Treatment in a Patient with Acute T Occlusion of the Right Internal Carotid Artery, presented by Dr. Polomsky.
Very good.
Dr. Polomsky, please come.
Yeah, that's what I thought. Yeah.
Thank you, guys.
We have some of these. We have some of these. This is the flush.
Congratulations.
Okay.
This is normal with the names.
Okay, yeah. Perfect.
Okay, you can go.
Okay, we'll give you a new.
Thank you once again.
Пак да се nice.
Continue in this direction.
Okay.
And we announced in advance that it's not only an award, ethical award, but there is also financial value. I'll keep in a secret the financial value, because you are going to be jealous. Okay, on the second place, anonymously, we have elected the poster named Acute Posterior Circulation Stroke Treated Successfully by Selective Arterial Fibrinolysis, presented by Dr. Vanya Deneva. Dr. Deneva. And now, what is your opinion? It's again brain. So the name of the poster that won the first award is Use of Coronary Stent Grafts, it's hybrid, for the treatment of high-flow carotid cavernous fistula, presented by Dr. Damian Boychev. Congratulations. Thank you. Thank you so much. So, Professor Chervenkov, Dr. Nikolov.
Theo? Yes, please. Hello. What is the situation?
Can we see the live case? We can.
This is the result after stenting DCB. So we have, in my opinion, an excellent outcome.
Absolutely.
Yeah.
What we have seen before the operation. The tibial trunk we have touched it with the chocolate balloon. So we went up to 5 millimeters there, and also it is very nice. It is really a patent now. The anterior tibial artery, we don't care a lot because it is completely occluded. Our focus was the posterior tibial and the fibular artery. It has not any gangrene in the foot, so at the moment, in my opinion, we don't need to open it. And now we have used a 3 millimeter balloon catheter to open the posterior tibial artery. Show the next, please. Go. So this is the posterior tibial artery, is nicely patent. Go for the next, please. Next, please. And this is the posterior tibial artery that goes now up to the level of the forefoot and gives very nice branches up to the pedal arch. So we gave some papaverine, and now we want a little bit to touch the fibular artery at the very proximal part due to a high-grade stenosis in order to provide two-vessel run over him. Do you agree with everything?
We can vote if you want.
Yes.
Who is to open? As a cardiologist, I would do a short, non-compliant balloon at the ostium of the anterior tibial artery, and that's it, to keep it open. For
Yes,
me,
we will do
it's on the tips of your fingers, so it's not fair for this anterior tibial artery to be left behind. This is my personal opinion.
Theo, I agree with Ivo. So I think you should do something with the tibial anterior proximal part. You have done a great job. I know you are satisfied, and we are also satisfied with this result. But as you know, 2 is better than 1, 3 is better than 2. So I think you have time, and as you have succeeded so far, you should give it a try for the tibialis anterior artery.
Dear friends,
yes.
the comment wire is not a good idea in this situation.
Yeah.
So I would choose something much more gentle, like even a whisper or probably whisper, some kind of hydrophilic wire with a good curve in order to get immediately there without any risk of dissection.
We will use a Bernstein catheter to go there. This is the classical technique for these cases. Now we want to take care about the fibular artery because this is an important vessel for us. Give me a contrast. Just a moment.
While you are working, can you give us also some information about the popliteal artery? I see a stent there. What kind of stent is this? And what was the result? I couldn't see the result after the balloon dilations. So I think it was necessary to put a stent there.
Go back to the angio. Yes, of course.
But your first intention was you planned to do it before see the result. So I think we should see the result after the ballooning.
Go back. Go back. Go back. Go back. Okay, show me there. So this is the result after the stenting.
Before the stenting.
Before the stenting. So you see a recoil there. You see some kind of material inside, and I think this was also the problem for the occlusion. So this is the reason why we have stented. Then it was, and the next one, please show the next one. We used the Pulsar 18, a very flexible but with good radial force. This is the DCB. You see there are some places where we have to further increase the lumen because there was a stenosis. Now it's really nicely open. And next one. And then we had a not good P3 to tibiofibular trunk. This vessel was more or less had some kind of stenosis there.
So this is a self-expandable stent? Can you?
This is a self-expandable, of course, self-expandable.
Okay. Is this Supera?
No.
No, it's not Supera. It's a Pulsar 018. And this is after the balloon, the P3 segment. And now the next one was what I showed you with the posterior tibial artery.
Okay, so far so good. Congratulations. Yes. But I think you needed double lumen catheter or something to engage the the tibialis anterior artery because it's a 90-degree proximal the takeoff, so it's very difficult to get in
You
there.
will see. We will try another solution, and you will see if we cannot. Yes, we're gonna do this. This is a cardiological. Okay, open it.
So you
This is
go
a
first with the
cardiological
perineal.
technique.
Okay.
Do you have a Bernstein?
Yes, we do.
Give us a Bernstein.
Theo, do you intend to use DCB in the crural arteries?
No.
No. Okay.
I'm getting it out.
Go a little bit here.
Okay.
Open it as well. So this is the fibular artery where we had some kind of stenosis. We wanted to be sure. Okay, there was no problem. It's okay.
So the other colleagues from the panel, what do you think? 2 or 3 arteries?
Go back.
Dr. Nikolov?
Well, the procedure is too long now, and I think 2 is good enough.
Contrast. Zoom out.
I would rather give it a try for the anterior because the patient has an unhealing wound in the distribution of the anterior tibial artery. And I believe it's doable.
We'll get the Bernstein.
Okay, good. Give me this one, just a moment.
Okay. You want to try without the
Yes, I will try.
Continue with the presentation.
It's straight. Wow, it would be very difficult.
Theo, we will leave you for
Yes.
now. We'll perform another presentation, then go back.
Yes.
Okay.
Yes, sir. I will come back when we are ready. When we are ready.
Yes, thank you.
Oh, no?
The next presentation will be presented by Dr. Alexandrov. Please.
Just to keep the wire in
Yes.
a little bit.
I thought due to the curve we can go,
Yes.
but we are not really so lucky.
Yes.
Okay.
Sometimes I go contralateral and without.
Dear colleagues, hello.
Without the thing, the guide wire
It's
is
my
going
pleasure to
contralateral.
present
No.
two methods of dealing with patients with critical limb ischemia.
It's coming.
No conflict of interest. A small but significant minority of patients with vascular disease have no reasonable target distally, so they're pretty much very difficult to treat. And in those patients, if we don't do anything, the only option for them for relieving the pain is the amputation. Of course, those are very sick patients with a lot of comorbidities. They are diabetes, they are with end-stage renal disease, and very old. For those kind of patients, we kind of seek any solution that could help us save the foot. One of the options in this kind of patients is the venous arterialization, which can fill this need. Actually, the concept of the venous arterialization isn't new. It's very, very old. The first publication is by Haustedt in a long time ago, last century, but this procedure kind of has a renaissance in the past few years. And actually, it has a very reasonable percentage of limb salvage rate, around 70 to 80%, according to different studies and different trials. There are a few ways to do that. An open surgery, which creates the arterial venous connection surgically, and then surgical disruption of the vein valves. Only percutaneous, when you create the connection percutaneously, and a hybrid method in which you create the bypass surgically, and then you destroy the valves endovascular, or you embolize endovascular the vein collaterals. And the results are not bad. Regarding that, those patients don't have much other options. In the open surgery group, you see the limb salvage rate is around 75%, almost the same percent of limb salvage we see with the total endovascular procedure of venous arterialization, ranging from 60 to 85% in different trials. And of course, there are some dedicated devices, like the LymphFlow device, which consists of few things, two sheets, and one of the sheet has a side port in which you can puncture the artery from the vein, and in that way to create the connection between the vein and the artery. Because the whole concept of this method is to deliver arterial blood to the vein system in the capillary bed of the critical ischemic limb. And the trial that gives the results from the lympho design, the PROMISE-1 trial, now we expect the results from the PROMISE-2 trial maybe next year. But the results from the PROMISE-1 trial are also very good. You see wound healing around, complete wound healing around 75%. And in 90% of patients, we see a partial wound healing, and almost 75% of limb salvage in a very, very long period. And as you can appreciate, the rate of amputation is in the first 19 days, and then it's almost a flat line. So this procedure, it's kind of a very reasonable alternative in patients with critical limb ischemia and no distal target and no revascularization option. I want you to present one case. It's a 73-year-old male with diabetes, with hypertension, with ischemic heart disease, a few coronary interventions. He knows that he had some vasculitis a long time ago. We don't have any documents about that. And he presented with a critical limb ischemia of the foot. This is the angiogram below the knee. As you can see, there are almost nothing left distally. So our strategy was we decided to perform the DVA. We put a wire as distal as we could in the posterior tibial artery, and then inflated a balloon just to gain some lumen. Under an echo, we punctured the posterior tibial vein, inserted the sheath, and through the sheath, we inserted a snare at the level of the tibial artery. Also antegrade, we inserted another snare in the artery, and percutaneously, we punctured throughout the ears of both snares. And in the soft tissue, we advanced a wire that we captured proximal and distal, I mean, from the vein and from the artery, with the two snares. In that way, we could create a connection between the artery and the vein. After predilation, we implanted a stent graft to secure this, to create the anastomosis. And of course, one of the key things to the procedure is to get a big long balloon and to destroy all the valves in the vein in order to secure antegrade flow throughout the vein. So that was the final result. Actually, the patient had a really nice pain relief, but 6 months later, he returned again with a pain, and we saw that the stent graft and the vein anastomosis was occluded. So we have to do recanalization and balloon dilatation, and that was again the final result. The another key thing, as you can see on the previous slide, those patients have so heavy calcification that, as they say, if he breaks his leg, he can walk on his arteries. So one of the other main issues in critical limb ischemia is dealing with the calcium, which we can find in all arteries throughout the body. Of course, they cause, the calcium causes a lot of problems in the procedure. You can have dissections, perforations, embolization. You don't really get a good result after balloon dilation. You can have a stent crash and stent recoil. And of course, we all know this slide from Finelli that the more calcium you have, the less absorption of the drug from the DCB you can get. So the DCBs don't do that well when you have that much calcium. So the vessel preparation before we can use either DCB or a balloon is crucial in these heavy calcification arteries. Of course, one of the solution is the intravascular lithotripsy. You know very well the device. It has the shockwave device. It has emitters that transform they have an impulses and they transform the electric energy into kinetic, and they create bubbles that have apply a sonic pressure to the calcium in the media and in the vessel wall, and they have this device actually applies a very high sonic pressure to the wall, and it's really useful, very nice results also from the trials, from the Disrupt 1 and 2 trials. You can see it's a very safe procedure, almost no complications, and the follow-up isn't really bad, almost 80% freedom of clinically driven revascularization. So that's the same guy. He's really poor guy. He returned with a pain in the other leg, not that one with the DVA, but on the other leg you can appreciate that it's really heavy calcified lesion with a very tight critical stenosis on the common femoral artery, and that he has a very tortuous iliacs and femoral arteries. So we decided to try the shockwave in these settings. We didn't, although surgery is a gold standard in this case, we decided not to perform surgery, but to try with the shockwave. This is the positioning of the shockwave. You can see the emitters here. Actually, in this tortuous, very calcified vessel, we delivered it pretty much easy. The first inflation at 4 atmospheres and the first set of pulses, you can see that there is still not fully expanded. But on the second inflation, it was absolutely fully expanded. We finished classically with the DCB, and that was the final result. I think it was a pretty good result regarding this terrifying vessel. Thank you very much for your attention.
So, because the time is running, I suppose we have to go directly to the satellite symposium of Abbott. Dr. Mane from Belgium will share some thoughts about the superstent application in peripheral arterial disease.
Okay. Good morning.
Good morning.
Okay, good morning, Mr. Chairman. Good morning, everybody. Thanks for joining this very interesting session. Well, I would like to share some ideas about my latest treatments with the Abbott Supera stent. So I think everybody has a treatment strategy in his head, and for easy, simple lesions, that's quite obvious. Like you see, this patient that I treated before, it was a patient that was treated for CLI, the below the knee, but has also very limited inflow lesion. We treated with DCB, no doubt about that. Simple lesions, I think we all agree, leave nothing behind. But that same patient, a couple of months later, presented with an ugly lesion at the common femoral. And then, of course, complex lesions, well, the strategy, it's changing. And in our department, almost 10 years ago, we started using Supera on a common basis for the common femoral artery. So then, of course, in our head, strategy has to be discussed. Simple lesions leave nothing behind. Even sometimes in simple lesions, leave the right thing behind. And complex lesions, what is best? Well, and it's not always straightforward, as this patient showed, because she had to come back for persistent ulcerations at the foot. And then so we could check our treatment in the groin. And we were quite astonished because we expected the DCP treatment to be very easy and simple and have good results on 1 year. On the other hand, you see here, the complex lesion treated with the Supera remained very nice and patent, and the DCP remained with problems. So there is questions in a FEMPOP treatment algorithm, and definitely if we go to complex lesions. And that's why we changed a little bit our practice. We changed it in a way that we want to check the vessel first. And how do we check this? Well, we do it with a very gentle, undersized, low inflation balloon. So we know how the calcium, the length of the lesion, the fibrosis, well, how it will react on our vessel check. And then, as we did before, we mostly go for DCB. And of course, we know that the long-term patency in DCB is dependent on the drugs and the type of balloons. But in our daily practice, we have a lot of patients with extensive calcification, long lesions, and then there is a need for a scaffold because there's a mechanical problem. And then we switch from a very gentle approach to a very aggressive approach with oversized ballooning and atherectomy and even shockwave, as was presented before. And then, of course, the big question comes, what is finally defining the long-term patency of a scaffold? Because a lot of scaffolds are on the market, stents are on the market, presenting with good long-term results. How to choose in our daily practice? Because we all know we're confronted with self-expanding stents. Well, we put them in highly calcified vessels which were well prepared, and nevertheless, we've got recoil on the stents. We got parts that are not fully deployed. So there is a scaffold vessel interaction in a very short term, but also on the long term. And this will definitely have an influence on the patency. So what about biomechanics? What about sizing? What about the location of the vessels? Does that influence the final choice in the scaffold? Because when I was in training, and even these days, very few people are looking into these details. And that's why I went a little bit into the literature of engineering. And I got a look on all these tests that are performed on the stents and scaffolds. Torsion tests, compression tests, all this. And I'm not going to bother you with a lot of information and technical details, but I just took some examples from that literature. And here you see these pictures, and I think a lot of them speak for themselves. Extension compression tests, well, okay, you can see this is still acceptable, but I was quite astonished. If you look to the images of certain devices when they're on the test bench and you start rotating them and you start creating torsion, which we all know is present in the SFA. If you look, for example, at the lower line, on the right side, you've got the Supera, which is quite capable of coping with these extreme torsions to more than 90 degrees. But some other devices, they just start to infold and create some bad images, as you can see. So with this in mind, almost 10 years ago, we started treating on a common basis very difficult and challenging lesions. This one doesn't look really challenging because it's a very ugly calcified plaque in the right common femoral. Not so challenging on itself, but very challenging for the devices, because we all know these cauliflower, bulky, calcified lesions, they exert extreme pressure on the scaffolds if we implant them. So at the beginning, there were definitely question marks there. But nowadays, well, we are definitely reassured. As you can see, the same patient underwent 3 or 4 years later a CT scan for bowel disease, and look at the supera that is in the common femoral. Very nice sitting there, yeah, extremely pushing away that chunk of calcium, nice and round, and even after several years has a very nice patency. So there is definitely interaction between the scaffold and the vessel, and we know these forces. We've got the chronic outward force. Chronic outward force, yeah, there's inherent at the stent design itself. But since we scale on a one-on-one with certain devices, we can control chronic outward force. On the other hand, you've got the radial resistive force. The devices need enough strength to keep up with the recoil forces, with the calcium, and definitely when there's local crush, as in these common femorals. So too much chronic outward force is negative, but we need the resistive force. So the biomechanics need to have like a balance between these forces. And that's why it's important, in my opinion, to take a closer look to all the current devices on the market. And if you look then to a supera stent, well, you see that if you implant it on a one-on-one size in the vessels, whether it's a common femoral or an SFA, the chronic outward force is very low. But on the other hand, the resistive force remains very high because it's inherent in the design of the supera that is built up with the wires. So if you start treating common femorals, whether it's a focal lesion or a longer lesion, you need that force and also the flexibility. Because definitely when you are treating in the groin, yeah, these lesions undergo constantly extreme forces, but also need the flexibility of the hip movements. So you need a modern generation, and you need modern biomechanics, otherwise you end up with problems that we can foresee. And that's why we changed our algorithm in treatment of the popliteal artery. At the end of complex lesions, we nowadays always do flex angios. So we take the patient, we bend the knee, and we look how the modern generation devices are behaving in these difficult conditions. And this is an example where we see that you need flexibility in your devices, otherwise you create kinking by just moving the knee. So we need low chronic outward force, extreme radial force, but also flexibility and crush resistancy. I will not go over details in the studies, but as you know, a lot of these devices present with very nice results. But I believe if you start treating the common femoral or complex lesions or calcified lesions, it's not only the study results that matter, but also the biomechanics. So I believe it's important to look at these details, especially in our population where we see that most people present with very long lesions. And these patencies, they remain even in very long calcified lesions. But it's not always without a down. Not everything has positive news. Just sometimes a downside. And also with the supera, there's something that we need to keep in mind. The supera has extreme radial resistance. That means that you can really pinch on it without compressing, and you can flex it, turn it without being compressed. But this, in the optimal position, that means in the optimal delivery of the device in the vessel. Because if you elongate the device or you compress it too much, you change these forces within the wires in the wall of the stent. And when a supera is badly deployed, well, this leads to worse results. And this was also proven in the clinical trials, in the SUPERB trials, where we know that if you elongate the supera, it's no longer coping with the recoil of the vessel, so the radial resistive force is dramatically dropping. And so we definitely need to pay attention to a very good deployment. But nevertheless, the supera is capable of coping with extreme calcium, has its inherent flexibility, so it has a very broad range of clinical cases that can be treated with this device. And this was a patient that presented with extreme CLI, but multi-level disease. So he has calcified groins, but also calcified femoral axis and below the knee vessels. So since we started a program of treating the common femoral, we hardly do any endarterectomies anymore, although we're a vascular surgical department. And so this patient presented with multi-level disease, occlusion of the common femoral, occlusion of the popliteal with extensive calcifications, and extreme calcifications of the below the knee. For us, some major remarks: if we cross the common femoral, we want to do it in an intraluminal way. I think that's very important, because if you can treat the calcium and the occlusion from the inside, and you can definitely make room by pushing all the parts to the side, this has a better end result. SFA, well, there's a different story, especially when it's extremely calcified. We go often also for the subintimal plane. So action plan in these patients. Well, first of all, we do the vessel check. Yeah? We do a slow progressive inflation and just see how the calcium is coping. And now and then, in extreme rare cases, we are not able to pushing away the calcium, but in the majority, even with extreme calcified lesions in occlusions, is perfectly possible. And then we evaluate the recoil. And the next step is we go for a very aggressive treatment. Even in a vessel that is only 7 millimeters or 6 or 7 millimeters diameter with extreme calcium, yeah, we go for a vessel prep with an 8 millimeter balloon. We found out in the past, yeah, that it's better to over-dilate the common femoral to create the room to put in the superior stent and to end up with a very nice expansion, because that's the key element. You need the full expansion of the superior in order to have this very strong radial forces. In this case, we implanted a 7.5 millimeter. You see that's very big compared to the vessel, but this leads to very good long-term results. Same story in the SFA. For first the vessel check, very slow, progressive, little bit undersized balloon, 5 millimeter balloon. Sometimes we do a repeated PTA, especially when there's extreme calcium, focal calcium that is sometimes difficult to push away, because we know that if we implant the superior in a second stage, we need this room to be able to expand the superior. So we go for a bigger balloon. We oversize the balloon so that we definitely create room to implant a 5.5 millimeter superior stent. So how do we do this? Well, for us, I work under magnification because I definitely want to see the behavior of the superior, of the wires of the superior. So I locate on the bony landmarks together with the roadmap, and then I go for a big magnification, because I want to see how the wires are definitely developing and taking their position. So first of all, definitely we anchor on a distal healthy path. We anchor because from that moment on, when you reach the zones where there's extreme focal calcium, you know that you will have to push very hard on the delivery system to get this superior fully deployed in these difficult areas. And when you have these areas, it's important to choose the right wire. Take a wire with a high support in the body of the wire. Take a very long and strong sheet that you have a good stable position. And when the superior starts wiggling, yeah, when it starts moving, when the delivery system is wiggling because you have to push so hard, it's no problem. Yeah, it's no problem at all. We know that the wires in the end will take their position. It's absolutely mandatory that you don't elongate the superior. So you have to push, and if there's some infolding, you just pull it out again and start moving forward. Finally, you recapture. I always post-dilate, always 100%, to give the wires room to move, and we do the final angio. In this patient, yeah, we've got the extreme calcifications also in the below the knee, as you can see here. So for these typical lesions, I like the latest device, the latest type of wires, which have a very good penetration force, that have a little bended tip so that you can navigate through the calcium. But nevertheless, this remains very challenging patients. So I've said it before, you need to prep the vessel, you need to make room. So I use oversized balloons even in a common femoral, where a lot of my colleagues said in the past, my God, an 8 mm balloon in a common femoral, how do you do it? Well, just take your time, leave it open, leave it to expansion, and you will see that the supera nice and slowly deploys in that way. And look for the cell geometry. I think it's important. If you look for the geometry, you know that the placement is right. But in the end, sometimes we end up with these parts that are a little bit stacked or a little bit elongated. Well, we know from colleagues that have images in the past and also from CT scan that we see a reorganization. Yeah, we see a reorganization of these wires in the end, but the most important is that you have space to put the supera in place. And if you take account all these numbers, well, you will see that the clinical results and the patencies on the long term are very successful. So just to conclude very short, we treat common femorals, we treat extreme calcified lesions, but also longer lesions. The longer lesions, well, especially longer lesions, I try to stay intraluminal as long as possible. We used to do a lot with 035 wires, nowadays more and more with the 018 wires, but we definitely use the drilling technique. I always use a torque device and I spin it very fast back and forward without pushing too much. Yeah, so I let the wire find its way downstream. But in these long lesions, yeah, sometimes you encounter really blocks of calcium that are blocking the way. As was in this case. So at a certain point, I was no longer able to advance the wire or the catheter intraluminally. So we had to change the strategy, especially when you see that the wire is buckling up, you know, you're in the subintimal space, but no problem. We move to a different strategy. We take the wire into a loop. In that case, when I decide to go for a subintimal plane, I often pre-dilate already my access path so that I have a little bit more room. So I take a smaller balloon just to pre-dilate and then to find the distal path. But you can see the calcium sitting there. Yeah? And although I pre-dilated and I tried to find an access, I couldn't. Yeah, I always ended up at the popliteal in the subintimal plane with a big space between the true lumen and the subintimal path. So different wires, different catheters. I didn't want to go more distal because that's my surgical landing zone. And so I don't want to spoil that one. So what we changed in the latest years is our technique for retrograde approaches. So before we also went to the very distal end. So the very distal end, so the tibial vessels. Now, what we do now is we change and we puncture the popliteal artery, but in an antegrade way. In an anterior way. So we take the window between the tibia and the fibula, we change the fluoro, and under roadmap or under just focusing on the calcium that is sitting there, well, we found out that's the easiest way to do retrograde punctures from the moment that let's say the femoral axis is no longer reachable. So in the end, we fully dilated the whole tract. It was extremely calcified, so we needed to implant a scaffold to maintain the patency. So we implanted 2 superior stents. We post-dilated, and we finally got a very nice result. So that was my opinion about superior stents. I think we need definitely to take into account the biomechanics of the scaffolds that we implant. And by doing that, I believe a vessel check is important. But then once you decide that you want to implant, I think we need to go very aggressive to create room to put any implant. Thank you very much.
Thank you. Thank you, Dr. Mane. It was very interesting and useful to see how the decisions are taken depending on the behavior of the vessels with the balloon dilatation. Is there a place, in your opinion, for nitinol stents when we have supera nowadays? What do you think? Do we use them in some situations?
Well,
for SFA, for common femoral popliteal?
Let's say for common femoral and popliteal, my number one is definitely the VMI supera. But sometimes, in few cases, when they have these extreme calcium that are not coping with the vessel check and even the vessel prep, you see that there's so much recoil, then I am reluctant to put the supera in, because if there is a risk, you have to estimate yourself that the supera will not fully deploy, then I'd rather not put a supera in place. But on the other hand, when you have lesions that are very nicely prepped, that you have a good understanding when you do your vessel check, yeah, I think you can put the supera stent from the common femoral down to the distal popliteal with no doubts. Some lesions may be in redo cases. While there you need not only a mechanical scaffold, but also some drugs to overcome restenosis. So there might be a place for drug-eluting devices, yeah, definitely. But if you compare the first primary patencies in the first lesions, in the first treatment stage, I believe the flexibility and the biomechanics of the supera have a very strong place.
Thank you. Thank you very much. Okay, we have to proceed with the program now.
Yeah.
Thank you.
Okay, thank you very much. Yeah.
Thank you. Do we have Mariano Palena? Okay. And the wife case, how is it?
There is something I would like to say about the supera. So, in the common femoral region, I am also advising and recommending devices like stents there. But sometimes you have to go also into the profunda. So that's going to be a problem if you have a supera, because this is an interwoven stent. If you do a popliteal angioplasty and you are not satisfied, and if you have to put a stent there, then supera is a good choice. And the problem with the supera is that you have to know how to deal with the stent. I have seen a lot of superas floating in the SFA, and this is a big problem. You have to exactly know. I think there is a learning curve how to implant the supera, and this is one of the main difficulties of supera. And because the stent is an interwoven stent, and you have very, very, very small space between the stent cells. That's the problem if you cross a profunda. If the profunda is vital for the patient, for the distal part of the extremity, then it's very difficult to go to the stent cells and make a balloon and put another stent there, because the stent is very resilient, and as you see, you can't unkick it. And if you do a balloon, the stent cells always recoils. So you can't. It's very difficult to go into this cell and go to the profunda. But if you do it at the popliteal level, then it's okay. But if you have to also deal with the profunda, then it's a bit tricky and difficult with the supera. That's what I wanted to say about it.
Okay. Mariano, good day.
Hello.
Okay.
Good morning to everyone.
We are ready for your presentation.
Okay, can you hear me well?
Yes, absolutely.
Okay, fantastic. So let me start saying thank you so much for this kind invitation, and thank you to everyone to be here, taking your time to hear me. Well, the topic of the day is to optimizing stenting approach for better outcomes in lower limb CLI patients. When, why, and what? And I think this presentation will perfectly match the previous one and will continue inside of this very interesting discussion. The challenge about SFA and popliteal artery or the complex lower limb lesions, as the previous colleague said, what we found in most of the cases is calcified lesions that after pre-dilatation will finish in a dissection, subintimal outcomes. If we start to think about to oversize it, we can finally obtain a perforation with a high risk of embolization. In the other hand, if we don't manage in the proper way the vessel preparation, what we can obtain is an incomplete stent expansion after stenting. So vessel recoiling, dissection, and finally bad result. So the question is how we can manage it, improve the acute game, limit the flow limit in dissection, make acute success easier and quicker, improve the long-term outcomes, because when the acute result is not good, the long-term outcomes are not good, and conserve stable lumen over a long period of time. For sure, we have available multiple treatments and multiple devices, but let me say my personal opinion, not every device adapt or has indication for any type of lesions. What we can do is pliable balloon angioplasty, drug-coated balloons, bare metal stent, drug-eluting stent, atherectomy, some special stent like mimetic technology, and we can also combine some special balloons. But what is the standard of care? As Dr. Mai said, the good vessel preparation is, in my mind, the first key factor to obtain an acceptable and a long-term good result. So prepare the vessel with less overstretch. It is very, very difficult when we have long calcified occlusions because it's very difficult to don't overstretch the arterial wall. But for sure, going step by step, increasing the diameter of the balloon step by step, allow us to do not overstretch too much the arterial wall. Preserve the native vessel with less metal burden if shortened stent segment is achieved. For sure, nobody wants to cover the collaterals, or nobody wants, when we discuss specifically about the common femoral, we don't want to jail the profunda, even if in many cases it's necessary, but we always try to preserve the native arteries. And good key factor talking about the vessel prep is the time of angioplasty. Prolonged inflation, at least 3 minutes, but in some cases we arrive even at 5 minutes, may assist the dissection healing and for sure may contribute to better lumen gain. As the previous speaker showed, we must have in mind an algorithm because it's clear that we have multiple options and we have multiple lesions and multiple devices. So for easy lesions, leave nothing behind can be a solution. In most of the cases, it can be possible. Do a pliable angioplasty, check if the result is acceptable, move forward with the DCB. As well, in the opposite side, the complex lesion in most of the cases could need some a combination of devices, some more interesting or more complex treatment. It means atherectomy in some cases in which the indication can be done. For sure, if we cross subintimally, it's many difficult, it's not sense, more than difficult, it's not sense to do an atherectomy. As well, if we have a long CTO with the calcium and high risk of embolization, maybe it's better to avoid atherectomy, but we can combine special balloons like scoring balloon, cutting balloons, chocolate balloon, and finally obtain the best lumen gain and move forward for stenting. And it could change between spot stenting if we have a focal dissections or focal lesions, or a full metal jacket in a long CTO. For sure, stent proved a good result as a standalone therapy. We know from more than 20 years ago that occlusive lesions, CTOs, perform better or give us better result in the long term after stenting compared to do not stent. But we have multiple data in the literature about the performance of the stent. For sure, today, discussing about the combination therapy in the complex lesions, we can also think about atherectomy or DCB or both. But finally, we realized that even in those cases, we could need, in some of those cases, we could need a stent because, for example, bailout stenting after atherectomy, even if it's not in a high percentage, there are a percentage around 5% that could need a bailout stenting or a provisional stenting after DCB use, because what happened is that we do a good pre-dilatation, we move forward with the DCB, and after DCB we realize we finally have a stenosis, a residual stenosis, a residual dissection. So at that moment, we will need a provisional stenting. So being back to the discussion, today we have Supera, we don't need another stent? Oh yeah, we absolutely need another stent. As the previous colleague said, for example, the case of vessel prep, use of DCB at 5 millimeters or 6 millimeter, you don't have enough chance to post-dilate again for a Supera. So this could be a perfect case in which we will need a standard nitrogen stent like Pulsar T3 from Biotronic. For sure, use adjunctive therapy to DCB or alternative drug-eluting stent. Calcified plaque resist the balloon dilatation, and this is one of the reasons why we start to think about stent to avoid an acute recoiling dissection because hold back the intimal flap, cases with again calcified or complex lesions that we finally dilate, but the result is bad related to a residual dissection, and the recoiling resistant after prolonging PTI or DCB. So in this type of complex lesion, as I said before, in most of the cases we will finally need stent and an scaffold. But stent can be another interesting combination with the DCB because, yeah, we have a DES, but we cannot implant DES in every patient or in every case, or we could just starting to think about to avoid stent, to leave nothing behind, and after, as I said before, after DCB, we could realize that we finally need the stent and scaffold, and in that cases, we will for sure use a not drug-eluting stent, but a standard nitrogen stent. So dedicated stent to tackle the SFA lesion, for sure, this is what we need today. And in most of the cases, what I can say is that we already have it, a combination of multiple devices. But properly, what we need is an accurate deployment stent. As everyone said, in some cases, Supera can be very tricky and complex if we do not realize, if we do not achieve a good vessel preparation. For sure, flexibility, multidirectional flexibility. The previous speaker had been talking about the cuff, the radial resistant force, and the crash resistant. And another interesting topic or a thing is that the low profile of stent. So low profile and accuracy start to be something very interesting and necessary today. Elongation and compression can impact the patency. It was clearly explained during the previous presentation, and for sure everyone realized that if you finally do not achieve enough space, the stent remains compressed and it's elongate, and all the force, the resistant crash and the external radial resistant compression can be for sure modified. The multidirectional flexibility, it's something very, very interesting and necessary because everyone knows the multiple torsion, flexion, extension, and compression, external compression that SFA and POP receive in every movement. So the thinner struts may provide significant advantages in that multidirectional flexibility. The cuff, as the previous speaker said, is essential to have a good balance between not too much and not too low cuff. So it's important to use the proper stent that manage the cuff or obtain the proper cuff to do not improve the result without create too much intimal hyperplasia. And finally, the less invasive, the low profile and the full French compatibility devices, because we can use this device for an alternative site, lower compression time if we have a full French access in the common femoral. When we work in most of the cases in an antegrade fashion, it allows us to compress less time or to have a lower risk of complications, access complication, can reduce the contrast load, cost saving, because we can think about to do an office-based treatment, and it is safe and effective as the 6 French device. In fact, the full French compatibility allow us to obtain a almost 50% smaller access compared to the 6 French compatible devices. The efficacy of the 4 French pulsar proven in a wide range of lesions, because we know that this stent performs pretty well in short and medial lesions, as well in long lesions, in popliteal artery, in dissections, in occlusion, in calcified lesions, and it performed pretty well in a combination with the DCB. In fact, we have a good match for DCB, and we have some interesting data that we can see here now at the combination of Paseo Lux and the Pulsar 18 T3, with a very nice result at 1 year in terms of primary patency and freedom from TLR. But let me pass to the practice experience. This is a case. This is a 65 years old man with diabetes, dyslipidemia, hypertension, carotid artery disease, and previous stroke, bilateral peripheral arterial disease, previous target limb revascularization 2 months before. Not good result because the patient is back still in a Rutherford 6 class. The Y5 class is very complex, 332. Second, fourth, and fifth toe gangrene of the last foot. So the previous treatment was not so useful for the patient. What I did was an antegrade access in the common femoral and deploy a short sheath. This is a CO2 enzo, this is my standard of practice, that allowed me to see a diffuse disease SFA with a proximal stenosis, so almost close to the bifurcation, acceptable flow distally in the popliteal artery, very nice flow, still stenosis or diseased artery in the distal SFA, and below the knee compromisation with occlusion of anterior tibial and very thin posterior tibial, calcified posterior tibial and peroneal artery. The flow in the foot was not so poor, but not the best, because we were able to identify the median plantar artery, the dorsalis pedis, and the lateral plantar artery with a couple of stenoses. So the crossing in the SFA was very easy because it was a simple lesion. With a full French Bernstein type 2 and a V18 guide wire, I approached the anterior tibial. As you can see, some difficulties, but finally managed between the luminal and subintimal to reach the distal lumen, but never re-enter. So I leave the wire in place, I shift for a pedal plantar loop technique, cross the posterior tibial, the lateral plantar artery, and finally reach the arch. And I realized that even the arch was diseased. So it was a clear case of SAD, small artery disease. The difficulties to engage the arch with the O14 guide wire and to cross the arch, and finally reach the dorsalis pedis and was able to do a retrograde revascularization of the distal dorsalis pedis and the distal anterior tibial. I needed to predilate a bit to remove resistance and finally be able to push up the retrograde guide wire and to re-enter in the anterior tibial. At that time, everything started to be more easy because I was able to predilate the distal anterior tibial, and finally changing the guide wire, I was able to re-enter in the dorsalis pedis. Final dilatation of the dorsalis pedis, the arch, and finally fully dilatation of the anterior tibial, as well lateral plantar that was fully diseased and posterior tibial that was also fully diseased. And still need to treat the SFA and the POP. multiple lesions in the distal SFA as well in the P1, P2 segment. So long dilatation, long inflation at 5 and at 6 millimeter. And this was the result. Some residual plaques that even if it were not limiting the flow, for sure were reducing the lumen. So the first pulsar T3, look, the video is for sure accelerated, but no any problem to deploy the stent. Very easy, very fast. The precision of this stent is quite incredible. You put the stent in the place you want, and you are very ready to deploy the stent in that place. There is no any jumping, no any movement, and even in the popliteal artery. And as the previous speaker said, always check in the flexion knee. Well, this is the flexion knee. Look how the pulsar perform in the flexion knee. Perfect, no any compromisation, no any entrapment, no any kink, and this was the below the knee result with complete tibials with direct blood flow from anterior and posterior tibial artery and with a complete below the ankle revascularization. Look, the final check with CO2, direct blood flow in the anterior and posterior with direct blood flow for dorsalis pedis and for the lateral plantar and to the arch. So it was a complete SFA, popliteal artery, and below the knee, below the ankle revascularization. But let's move forward for a quite different case. This is not so young. It's an 82 years old female with diabetes, dyslipidemia, hypertension, Rutherford 5, Wi-Fi class 131, TCPO2 low, and the use in the heel and the first and fourth toe of the right foot. Again, antegrade access in the common femoral, flash occlusion of the SFA, and look, you can pretty well see the calcium. So big amount of calcium, calcified wall of the artery, and long occlusion of the SFA. So a little bit more complex lesion compared to the previous case. Popliteal artery with flow, below the knee compromisation with flow from what we can understand with CO2 in the peroneal and the posterior tibial, but a little bit poor flow in the foot because seems to have only the median plantar artery. So very poor the images at that level. So look, flash occlusion, antegrade fashion, CTO guide wire, full French catheter, and even though trying to stay in the lumen, it was impossible. It is clear a subintimal progression of the proximal part of the SFA because the guide wire was going around the arterial wall. But finally, in some way, I was able to re-enter in this occluded vessel because look, now the guide wire is going straight and is in the middle of the calcium. So that was fantastic because for itself, the guide wire found again the lumen, the through lumen, and I was able with this full French Bernstein type 2 super catheter and this CTO guide wire, I was able to finally continue in the lumen and re-enter. So probably the proximal cap was so hard, but finally in the distal part of the SFA, the cap or the chronic occlusion was a little bit more soft, and I was able to penetrate to arrive till the popliteal artery, pre-dilate with 4 millimeter balloon, engage the anterior tibial to leave the guide wire in a no complex place, and finally retrieving the antegrade sheath, I was able to open properly the SFA with the 4 and with the 5 millimeter balloon. And look what happened. The place in which I was in the lumen, the result was acceptable. The place I was subintimal, there was a dissection, very bad dissection. But again, guys, I invite you to think about antegrade fashion in the common femoral in a flash occlusion. So dilate at 6 millimeter at the proximal part of the SFA, but when we think about to deploy stent there, we have a lot of risk, not only to cover the profunda, but to go inside the sheath or out of the axis. So let me say that the only one stent I use in that cases is the pulsar, because look, the stent is less than 5 millimeters close to the axis, and the time you present the stent there, you are able to put the stent there. In fact, the stent was precisely open, covering the ostium of the SFA and not going out of the axis. It was impressive. It was perfectly precise. After this, I post-dilate a bit to be sure to be able to engage the stent with the sheath without damage the proximal edge of the stent, post-dilate all the stent in the way to obtain a good apposition, do the final angioplasty of anterior tibial and dorsalis pedis, because at this time the anterior tibial and dorsalis pedis was completely recanalized, and I was able to also re-enter in the arch. So did the final dilatation in the foot and in the anterior tibial in the way to improve as much as possible the perfusion of this foot and the toes. Remember, there was a lesion in the first, fourth, and in the heel. And finally, with an O14 guide wire, reach also the arch, as usually trying to improve as much as possible. Also, the plantar flow, taking in consideration that the lateral plantar was occluded, but the posterior tibial artery was patent. So doing this type of retrograde recanalization can help a bit. And this was the result, with direct blood flow for anterior, peroneal, and posterior, some short stenosis in the TP trunk that was finally treated, and the result for the foot with direct blood flow in the dorsal circulation for the toes and in the plantar circulation from the median plantar artery, improving the flow for the calcaneal area. But another important thing to discuss is how or when we need stream or complex access. So again, very diseased patient, let me move forward very fast. Don't want to consume too much time. Iliac lesion, so I decided to go retrogradely and a crossover fashion. This is something that I don't like too much when I need to arrive in the foot, but the problem starts here. Very bad angle, very bad aorta bifurcation, complex, very complex crossover. So I finally was able to do this crossover, changing a couple of catheters and using soft Terumo wire that finally allowed me to arrive there. Previous groin surgery, so leave the catheter there, do the angio, and well, the SFA was again fully occluded. Not clear if it was occluded from the surgical point of view or if it was previously occluded, but so difficult to engage it. Good popliteal artery, occlusion of the anterior tibial, but seems to have two distal runoff vessels with posterior tibial and peroneal. Quite poor flow from the foot. Look, after I was back to try to engage and to use the crossover, I lose everything. And for me, it was quite impossible to pass there with the sheath, even with the full French sheath, because I was never able to deploy in a proper way the guide wire again. Probably the previously used devices were not more functioning pretty well. So I decided to leave this axis and to do everything from a distal axis. So what I did was to, under ultrasound, puncture the anterior tibial artery that was occluded. So I punctured an occluded vessel, put a full French sheath, went up with a V18 guide wire, changed the V18 for another guide wire, and was able to re-enter in the common femoral, dilate at 4 and at 5, and finally at 6, all the SFA. You will see that multiple times I will be going up with the catheter. This is a Navicross to check the result. No problem with profunda. Profunda was there. Acceptable flow in the SFA, but still some recoilings, not the proper vessel open. So what I did was decide to again stent it using pulsar, but using pulsar from the anterior tibial. This is something that is pretty well to do, very easy. Precise retrograde reverse stent deployment, starting from the ostium and going down in the proximal part of the SFA till the median and the distal part of the SFA. This is very interesting because having a full French profile compatible devices is very nice and very easy to manage a CLI patient from the distal axis without any problem, without any risk to have access complication. I finished with the second pulsar T3, 1 centimeter, a little bit less of 1 centimeter overlap, and finally going down from the SFA into the proximal popliteal artery. I did the last check after this, and I realized that there was still recoiling in the P1, P2 segment. So I decided to finally put the third pulsar stent. You will see now, this was the first check with a very good result in the proximal SFA, good result in the median part of the SFA, but still recoiling in the popliteal artery. So put the last pulsar and did the check from the 4 French sheath in anterior tibial that allowed me to understand that everything was functioning well. So I stopped the case at that point and managed this 4 French access with external compression. So the take-home message, the 4 French access is feasible, safe, and effective, and allow us to do it even from some extreme places or extreme access like this anterior tibial. So have a 4 French compatible devices is something interesting and allow us to think about treatment algorithms compatible with the 4 French, select the right materials, as we have been discussing right now, the sheath, the guide wires, catheter, balloons, and stent, offer a tailored approach to every individual patient, because even if you have a plan, but you need to change it during the procedure with the 4 French compatible devices, you can go clearly fast without many problems. And well, about the pulsar T3, very precise, no kinking, easy to use, compatible 4 French. Let me say that I really like this multiple flexion stent with the thinner struts that allow us to be very precise in the ostium of the SFA, even working in an antegrade fashion. And for sure, well, thinking about vessel prep before stent, I think that we are in the proper way, in the correct way, thinking to rethink vessel preparation and be more aggressive and progressive, and still continues working in the proper way to obtain a better lumen gain. For sure, post-dilatation in most of the cases is essential, but still some doubts about that. I think in the future, we will need to manage more and more the vessel prep to, in some way, even allow, it will allow us to even avoid the stent post-dilatation. And with this, I finish. Thank you so much for your attention.
It's at 2 o'clock. At 2 o'clock. This is.
Thank you, Dr. Polena. Some questions? What do you think about, I have a question, what do you think about drug-coated balloons for below the knee?
I think these are a very nice option. I think in most of the cases, this is the only one option we have, because atherectomy is quite complex. We today have a good device for atherectomy, that is the orbital atherectomy, but for the others atherectomy devices, we have some difficulties to arrive in below the knee and distal, more distal. The same with the stent. When we are going to treat long tibial lesions, it's difficult to think about to treat all of this long occlusion with the stent. So I think DCB below the knee are a very good tool. I believe in that. I use it in most of the cases.
Thank you.
Can I ask something else? Do you always perform balloon angioplasty of the arch, even if it is patent and you use it as a collateral pathway? And what are the sizes of the balloons you use usually?
Well, the first thing, never touch what is healthy. So in many cases, I use the arch like a crossing strategy, crossing from anterior to posterior or vice versa. But in cases in which the arch is healthy, I never dilate the arch. When I need to dilate the arch, the diameter I use for the arch is between 2 and 2.5 millimeters.
Thank you.
Okay. Thank you. Thank you for the wonderful presentation.
Thank you, guys. Have a nice congress.
We move forward. Next presentation will be complications in FEMPOP interventions and how to deal with them. Are we ready? Oh, okay. Sorry.
As a matter of fact, we are ready and I'm ready to show you the final results. With the help of a Bernstein catheter, we were able to go into the anterior tibial artery and go all the way down to the level of the ankle. And we inflated the whole segment with 3/0 long balloon. And after a couple of inflations, we had a very nice result, as you can see. Can you see the image?
Yes.
Okay, next. You can see the posterior tibial is open, the peroneal artery, and the last one. Next. This will be our final image.
Okay, congratulations, absolutely.
Did you try the anterior?
Beautiful. Yes, they fixed it.
Yes, we managed to go down, and when you perform a selective angiogram in the anterior tibial, it goes all the way down to the ankle level, where it disappears and there is no constitution after that. But we tried for a couple of minutes to go past the occlusion at the distal level, but we decided it's not worth the risk. We have open posterior and peroneal, and in a claudicant, that seems enough.
Okay, thank you.
Okay, thank you.
You're welcome.
So the complications, okay. Да, продължавам. Почивка или?
Не, няма да правим почивка.
Продължавам.
Да, продължавам.
Okay.
Докато те се нагласят с... Кого е изпратил?
Okay, dear colleagues, I want to talk with you for some complication in FEMPOP interventions and how I deal with them. My disclosures, nothing about this. So I'll show you just one trial, and this is Liberty 360. It's American trial with lots of patients, 1,200. But what is interesting, it's called Liberty because they gave a full liberty to their operators. One of the inclusion criteria was experience in and use of multiple endovascular technologies to treat lower extremity PAD. The other thing is that their arteries of interest is distal from superficial femoral artery, and the Liberty 360 includes all food and drug administration approved technology to treat claudication and CLI. Look at that, that's the devices they can use. As you can see, it's like heaven. Everything new, they can use that to treat such patients, PAD patients, but nevertheless, they have some complications. As you can see, significant angiographic complications, 8 for 8.5% and nearly 12% in the CLTI patients. So complications are inevitable. As Thanos said, they are inevitable. So the first complication, I will show some of the most popular one, the hematoma or the pseudoaneurysm. You see here beautiful growing hematoma, and this is a pseudoaneurysm after distal puncture. How to deal with that? You can do open surgery, but there are some disadvantages like infection or lymphocyte, but the main advantage is that you can do decompression of the hematoma. You can do ultrasound guided compression, you can do thrombin injection. There are two different types of thrombin injections. You can do it ultrasound guided directly in the aneurysmal sac, in the hematoma, and you can do it endovascularly towards from inside the artery. You can put a microcatheter in the aneurysm or in the hematoma, and when you inflate a balloon inside the artery, you can very safely inject the thrombin in the pseudoaneurysm or the hematoma. The other option is embolization, and the final option is, of course, the stent graft. I want to show you a case with from a colleague, Lafont, who is do it with a closure device with angial seal. What is the point here? You puncture the hematoma. You put a guide wire in the true lumen in the artery, and then you put the angial seal and close the hole with the angial seal. I've done it several times, and I think it's a very good method to close the puncture site when you have such hematomas. The next complication, the most popular one, is the AV fistula. It's usually when you do retrograde puncture, as you can see here, and plain balloon angioplasty, long inflation, is enough to solve this problem. Another case of mine, we chose here directly retrograde approach, popliteal. A patient was in one of my first cases, in prone position, but as you can see, several months ago, we found this AV fistula. Unfortunately, this has to be done surgically. You can put a stent graft, but it's an implant, it's no good. This is operation for 20 minutes, so no problem with closing this AV fistula. Another popular site for AV fistula, as you can see, it's the brachial artery. This is a typical case. Look at the artery and the two veins, and here is the AV fistula. This kind of fistulas are good to be managed surgically. Usually, AV fistulas are self-limited. The other option is prolonged inflation, as I showed you. The other option is using a stent graft, and the final option is surgery, like in this case. Prevention, I strongly recommend usage of ultrasound-guided puncture. Another complication is a vessel rupture. Another patient, hybrid dilatation of the external iliac artery. You can see the retroperitoneal hematoma. Mainly, these complications are from atherectomy devices, from excessive balloon dilatation, when you have extreme calcification, and some of them are guide wire related. This is the definitive AOE study, where the study is about the silver hawk, turbo hawk, now it's called hawk 1, and the atherectomy devices, as you can see, the rupture, the perforation is 6.5%. This is another case of ours. You should always know where the tip of your wire is. This is the case. Unfortunately, we didn't see the end of the wire, and we've made a perforation of the side branch. It's the first thing you should do is prolong the inflation, and hopefully this was closed. Again, for vessel ruptures and perforations, the solutions are once more, some of them is self-limited. You can do prolonged inflation, you can do embolization with coils mainly, stent grafts, pave and crack technique when you expect such complication, surgery, and maybe usage of image-guided atherectomy like Avenger family, like Pantheris, Ocelot, Tiger Eye, and so on. Dissections is the next complication. As you can see, it's always wise to give some time for careful vessel prep, atherectomy or balloons in increasing diameter, chocolate PTA, serenator auto, or flex vessel prep system, prolonged inflation, of course, and some kind of scaffolds. Distal embolization, this is a case of ours. This is the patient. We're treating the right leg. As you can see, a relatively short occlusion of mid-SFA, but heavily calcified. When we try the recanalization, at the end of it was not successful, but at the end of the procedure, you see that there is distal embolization of the deep femoral artery, and look at the outflow after such embolization. What to do? Surgery, thromboaspiration, manual or WISES, mechanical thrombectomy, different devices, Indigo, Rotarex, angiojet, and so on, PTA, stent graft, or mainly for the prevention is filters and primary stenting. What we did, thrombectomy, mechanical thrombectomy, the deep femoral is okay, but we decided to go on with the recanalization. As you can see, it was impossible to re-enter in true lumen. So I'm a little bit of Scrooge, but sometimes it's wise to use a re-entry device. This is the go-back catheter. With this catheter, you can easily re-enter in the true lumen. As you can see here, this is the command wire. We re-enter, but look at that popliteal artery. We recognize that with 014 wire, but no, nothing can follow this wire. Not a balloon, not a catheter. So I saw this, and what to do? Then we use the same catheter, the go-back catheter, as a crossing device. The needle of the device can create a space for the balloon to come, and it was then easy to put this balloon and make the final arrangements. This is purely PTA, and at the end we put a supera for this calcified lesion. Acute thrombosis, as you can see in this case, 3 stents, but they thrombosed at the end of the procedure, and we have occlusion of the posterior tibial artery, anterior tibial artery, peroneal artery. What to do? It's the wisest thing to do is WISES or thromboaspiration. I prefer WISES, and after 24 hours of WISES, you can see this result. The result is okay with 3 vessel run off. So much complications. These are the main one, but you can make complication from every device you use. There are some device-related complications and so on, but the take-home message, never mind how experienced the operator is, there will be always some kind of complications. So when performing PVIs, you should be prepared. You have to have a toolbox of devices to deal with, mainly RTPA, different catheters, coils, stent grafts, thrombectomy devices, etc. And if you can't figure it out, don't be afraid to call for help. An extra pair of hands or eyes and a different point of view is always good to have. And my final comment is that proper planning, the rule of 5 P's, proper planning prevents poor performance. Thank you for your attention.
Thank you very much. Because of change of the program, there will be change in presentations. Floor is yours.
Okay, I'm Dr. Samarjiev from Heart and Brain Hospital Pleven, from Vascular Department. our presentation is for endovascular treatment of task 2 type D lesions of the superficial femoral artery. First, what is TASC? TASC is Transatlantic Inter-Society Consensus document of management of peripheral arterial disease. This consensus recommendation for the diagnosis of treatment of peripheral arterial disease, and they separate for the first task to they separate from the aortoiliac segment and the femoropopliteal segment. After the update of the 2015, they added the infrapopliteal disease. The lesions patterns into A and D lesion. This is the type A for the femoropopliteal lesion. Type A is a small lesion with less than 10 centimeter length. Type B is such little small lesions. These recommendations for these types are for endovascular treatment. For the type C and type D, TASC recommended us that there is not a good option for endovascular treatment, and for type D, this is a chronic total occlusion of common femoral artery and SFA, more than 20 centimeters, and total occlusion of popliteal artery and proximal trifurcation. This is the recommendation 37 for femoropopliteal arteries, and the surgery is the treatment of choice for type D lesions. But it is enough. The recommendation of TASC, the last update is from 2015. That's why we need new changes, and the global vascular guideline of the management of chronic limb treating ischemia. They talk about the new system, GLASS, the Global Limb Anatomics Staging System. GLASS was developed to aid the objective assessment of the atherosclerotic occlusive disease and focusing on the anatomic details of the limb as a whole. Is it needed to update the old task 2 classification system? This is similar to the task classification, but the difference, this is the grade for like type D lesions, but the difference is that compare the femoropopliteal segment and infrapopliteal segment, and they put these grades on the different stages, like 1 to 3, which correlate with the technical complexity of the revascularization. For the type grade 4, the stage is third stage that is not recommended for any endovascular treatment. The another classification is for wound and tissue uses classification system. They have been developed to try to improve clinical decisions. The Wi-Fi system is based on 3 key factors: wound, ischemia, and foot infection. There is another stages from based on the Wi-Fi system, and they show us stage 1 with minimum ischemia, stage 4 to 2 to 4 increase the stage of the ischemia wound infection, and stage 5 that didn't show in the diagram. This is for unsalvageable foot. And all of this is to compare the GLASS and the Wi-Fi stages, and they show us the recommendation for the strategy for the revascularization. And the third stage of the GLASS, we don't have a recommendation for the endovascular treatment in the yellow. They recommend us open surgery at all. Even that, our experience in practice, we present you at 39 patients who received endovascular treatment for the task 2 type D lesions and GUAS stage 3 femoral popliteal disease, 41 affected limbs for September 2020 to September 2021. The lesion length was from 21 to 53 centimeters. The mean AB values increased 1 month after treatment was based 0.35 to 0.89. The follow-up time was from 1 to 12 months. The cumulative primary patency rates at the first, third, 6th, and 12 months were like on the presentation. Factors with high hazard ratio included male sex, smoking, arterial hypertension, and diabetes. This is the percent of the patient with this hazard therapy included heparin 3000 to 5000 was performed intraoperative. The subcutaneous injection of the low molecule heparin for 4,000 units for twice a day, 5 days after the procedure. Dual antiplatelet therapy of ASA and clopidogrel after the procedure, and clopidogrel was continuous for 6 months at 75 milligrams per day, and ASA was continued indefinitely. We show 2 cases with this type of lesions. The first one was 64 years old man, rest pain, dry gangrena and first and second finger on the left leg, previous claudication in the 50 meters for both legs, with arterial hypertension, kidney failure first stage, and hip replacement on the right leg. Angiological status says that the available pulsation on the common femoral artery and limited movement and sensitive on the foot. The AB on the left leg was 0.24 and the right 0.89. From the CT angiography, we looked at, we don't have SFA from the whole SFA to the popliteal artery. Based on GUAS and Wi-Fi stages, we decided to perform open surgery femoral popliteal bypass. But after the CT, the patient broke down his leg in the clinic. We transferred him to the trauma department and was performed the hip replacement on the left leg. After that, we changed our strategy to endovascular treatment because of the need of rehabilitation. This is because the kidney failure, we put a low contrast. This is the sorry. Okay, this shows the that we don't have SFA, and after we recognize it with the guide wire and ballooning and dilating with 6 millimeters balloon, we don't have, I don't know why didn't whooping, we don't have recognize it FSA, but of the previous CT angiography, we know that we have a popliteal and tibial posterior artery, and that's why we put the and we are in the true woman. That's why we put the superior stent 6.5 millimeters and late 200 millimeters. This is the whole FSA to the popliteal artery. After that, this is the recanalizate. This is bad imaging because we put a little contrast, but in the distal part we see the posterior tibial artery. After endovascular treatment, patient was with pulse on the left posterior tibial artery without complicate after procedure and discharged on the next day with double antiplatelet therapy. The second case was 76 years old man, rest pain in the right leg, previous claudication of 15 meters in the right leg, with arterial hypertension and diabetes. For the AB for the left leg was 0.58, at the right leg 0.25. But in this case we have FSA in the beginning, and now we see the vessels below the knee. After that, we try to recanalizate the FSA, but in the first imaging we see the AV fistula. AV fistula, and after that we put the guide wire down to the popliteal artery, but we can't put the catheter down here. That's why we perform the ballooning dilating with 3 millimeters balloon. After that, we go to the tibial arteries, and we see the anterior tibial arteries subtotal occlusion in this part, and the distal was good. We dilatate with 2 and 3 millimeters balloon the anterior tibial artery, and 6 millimeters balloon for the whole FSA. After that, this is the recanalized FSA, but we have a little thrombus here, and we start to cover the FSA with superior stent 6.5 and 120 late, and this is the result. And this imaging we see the embolization of the peroneal artery. We perform the ballooning dilating 3 millimeter balloon, and this is the final result. After intervention, the patient was with pulse on the tibial artery without complication, discharged on the next day with dual antiplatelet therapy. A little discussion. Open surgery revascularization has been recommended of the treatment of choice for the task 2 CND, type CND, and GUA stage 3 femoral lesion. However, in clinical practice, many patients with long segment occlusion are at risk greater surgical trauma and have limited outward venous tissues available for the bypasses. Additionally, these patients often showing significantly contraindications such as coronary heart disease, cerebral infarction, that increase the risk of associated surgical revascularization. Numerous clinical studies have shown the endovascular treatment is efficient of treating the long segments occlusion of lesions, and endovascular treatment successfully restore blood flow and improve clinical symptoms. Thank you for attention.
Thank you, Dr. Samarjiev. So now, Dr. Şevket Gurgulu, the floor is yours. Please.
Yeah, first of all, I'm very happy to be here again, and this is my second time here in Bulgaria, and I thank the organizing committee for having me in front of such a distinguished audience, and I especially thank Ivo also for inviting me here. So my topic is an update on drug-coated balloon and FEMPOP interventions. Our aim in FEMPOP intervention is to revascularize the limb with the most efficient techniques and stabilize the region with durable, long-lasting solutions. This is our case example, diabetic patient with a critical limb ischemia Rutherford 6. The angiogram shows us only a profunda SFA proximal cap is ambiguous. Indication for intervention is clear. And here is my scientific evidence for this intervention. This recent paper confirms that DCP angioplasty is associated with high procedural success comparable to that of bypass surgery. This review states also an endovascular first strategy should be recommended. Here is our case again. With an educated guess, we tried a contralateral antegrade approach, and this is a band catheter, Gaia PV 018. 018 wire went into the true lumen, and tip injection, we are in the true lumen. Why isn't this moving? This should be moving. The second picture. Can someone help me, please? There is a below the knee injection there. So this is the one, okay. It should be moving, okay. Then changing with a treasury floppy wire, we in the true lumen, and here first balloon dilation, okay, with a plain balloon. And then comes the question, should we further ballooning with a drug-coated balloon? The scientific evidence says yes. You see here a lot of randomized studies and their forest plots for DCB versus plain balloon. Both target vessel revascularization and 1-year patency rates are in favor of drug-coated balloon. Even the 2-year results are better with drug-coated balloon, contradicts the idea of a catch-up phenomenon, which we can see about 12 and 44 months. Here are some data from the famous impact studies. Superior outcomes with drug-coated balloons compared to plain balloon in 3 and 5 years follow-up. DCB is also very effective in CTOs. So our patient had diabetes, this patient, and the subgroup analysis of diabetic patients in the ECHO-ART study showed significantly lower 6-month late lumen loss in the DCB group versus plain balloon, suggesting an efficacy of drug-coated balloons even in diabetic patients. This data was also confirmed in a recent meta-analysis led by Karadu et al. If there is a state-of-the-art therapy, then I would suggest this result here, leaving nothing behind, no stent, profunda is intact, no flow-limiting dissection, an optimal SFA treatment result for this patient. And DCB, okay, but which one? There is no head-to-head comparisons between DCBs. All currently use dry state paclitaxel, but differences in drug concentration. Importantly, the Karadu meta-analysis reported that the dose of paclitaxel is related to the magnitude of the treatment effect. Predilation is considered an integral part of the procedure to avoid drug loss during crossing and to ensure an equal distribution of the drug across the vessel surface. A cautious approach with a balloon 1 millimeter diameter smaller than the size of the target artery is generally recommended. Only registries from Mikari demanded a predilation time over 120 seconds. In my practice, it is 1 minute to prevent any beforehand dissection. So the inflation time recommended for optimal drug release is between 30 and 60 seconds, and it was mostly over 100 in randomized controlled trials and in global registries. Few data are available regarding transit time, and only Levant 1 and Levant 2 studies recommended a transit time below 180 seconds. And the pressure in the Levant 2 was 9.5 millimeter. Here's another example. We have an aortic dissection in the distal part of the aorta and an iliac aneurysm on the right and a total occlusion on the left SFA. We didn't want to complicate the procedure, so we have chosen the ipsilateral antegrade approach. A long floppy wire from the radial artery acted as a roadmap, and an ipsilateral antegrade puncture was done. We see here a total occlusion of the mid-distal SFA after inserting a short sheetless catheter and 35 microcatheter. This short calcified lesion was crossed with an Gaia PV or 18 intraplaque, and I don't have this fluoro storage, so I couldn't show you how we crossed the lesion, but predilation with a 5 by 150 millimeter balloon, which was 1 millimeter less than the actual vessel diameter. There is a dissection and a cracked lesion with a residual calcium here. It is not moving again. This should be moving. Okay. No, not this one. I am waiting. You can't see the cracked calcium. Okay. Okay. Never mind. And after 5 minutes of DCB inflation, here is the end result. One should always check below the arteries after a SFA intervention. I left nothing behind and kept the artery open. And I would love to end my presentation with this nice result, however I can't, because a lot of operators in my country refrain from using drug-coated balloons since 2018, despite multiple randomized trials. And here comes the reason, why not? Because in 2018, Katsanos published a meta-analysis indicating a higher incidence of mortality with paclitaxel usage. Prior to these studies, this publication, the body of evidence suggested that DCBs are safe and maintain a positive clinical benefit in the treatment of FEMPOP disease, as reported in the SKY consensus guideline and in the ACC AHA report. Two main conclusions were drawn from this meta-analysis. First, a higher mortality incidence with paclitaxel DCB, which was ascribed directly to paclitaxel. Second, the risk of death beyond 1 year is significantly higher with higher dose of paclitaxel devices. So, however, since then, a lot of studies indicating the shortcomings of this meta-analysis and pointing to the opposite direction. The objections can be summarized as authors had no access to patient-level data and provide no explanation for paclitaxel-associated mortality. Time to event analysis was criticized along with the fact that in one arm of the study, 40% of the patients needed a silver PTX stent. 1 year after this paper from Katsanos, more robust data come into light from Peter Schneider, indicating no association between paclitaxel and mortality up to 5 years. There was no correlation between overall survival and mean paclitaxel exposure. More importantly, paclitaxel was not one of the mortality predictors. Here's an analysis coming from JAMA with over 16,000 patients treated across various US centers, shows no evidence of increased all-cause mortality following FEMPOP DCB intervention through 600 days post-procedure. Here's another cohort study. Okay, I had a laser, and I find out now. Okay, and here's another cohort study published in the ECG paclitaxel. Coating was not associated with long-term mortality for up to 11 years post-DCB application. This is another paper. In this propensity score matched analysis, retrospective analysis, it has been clearly pointed out that no mortality increase with DCBs. And here comes the last, but the most important one. And in this VDPAT randomized trial, no mortality was associated with paclitaxel up to 4 years. In summary, an endovascular first approach is usually recommended in FEMPOP occlusive disease, and by doing that, we should stick to our DCB policy as it was before 2018. And we have abundance of positive scientific evidence regarding the benefit and safety of DCB usage. Thank you for your attention.
Thank you, Şevket. It was really very, very interesting and evidence-based presentation. I would say that for all of us, our community, it was very important to make the exact revival of the drug-eluting balloon technology after, you know, the signal of about increased mortality. But fortunately, like often in the medicine, after looking back on the real data, we saw that in fact the devil is not so bad. Yeah. And fortunately, again, we have on the shelf the drug-eluting balloon, and we are using properly in all the cases, especially in diabetics, like you showed the first case. It's very important in order to prevent restenosis. We know that restenosis is not a neglectable rate in peripheral vascular interventions. So this is crucial. This is crucial for us.
Yeah.
Thank you.
Yeah. Okay. Yeah. Doing a lot of SFA cases, the motto is leave nothing behind, because if you leave something behind, you will end up with some kind of restenosis and with reintervention, and sometimes you will not manage to going to the stent and salvage the vessel as you want to have. So I think we have still a way to go with the SFAs. Maybe they will invent some scaffolding with drug eluting scaffolds, and I think that would be the solution for this problem, because with stents we have restenosis, but if you have a scaffold there, that would be gone after 1 or 2 months with drug coating. So I think that will be the solution, I think.
Thank you.
Yeah.
Dear colleagues, we have the Satellite Symposium of Medtronic, and Professor Petrov, the stage is yours.
Dear colleagues, it's like continuation of the previous topic, and we are going still to speak about the balloons in above and below the knee. So, like we have just commented the 3 options, simple balloon or stent, or to add the drug coating balloon. These are the most popular strategies nowadays, and but the guidelines still favor the ballooning. What about? Fortunately, the simple balloon is not the ideal way to treat above and below the knee lesions. The main problem of ballooning, we know that, for example, SFA, in most of the cases, they are long calcific lesions, and we need really or one very long balloon inflation or several inflations with shorter balloons. But nevertheless, because of the nature of the pathology, the local dissection is probably the main problem of plain balloon intervention, like shown here in with different devices, Lutonix, Stellarex, and Impact Admiral. We can reach the rate of dissection occurring in more than 60%, and especially it's concerning to have flow limiting dissection, not A, B, and C type of dissections, but D, E, and F, in which in most of the cases all over the world the bailout procedure is to implant stent. And the stent is carrying the risk of restenosis, more than obvious, because of the stimulation of the proliferation. Like shown here, in more than 80% of the cases, the bailout is stenting. So you see the rate of dissection occurring. You see that unfortunately in 60% of the cases the dissection is severe. So the so-called non-flow limited dissection is only in 40%. So as you can see, in almost half of the patients with elective ballooning, we have to implant stent in order to improve the immediate result, because there is a direct relationship between the immediate result and late result. Regarding new technology, so the normal balloon inflation, the regular balloon inflation, like shown here, there are several non-beneficial mechanisms. This is the unfolding expansion, and the shear stress is uneven all along the balloon itself. So there is a radial and longitudinal expansion, and the longitudinal expansion is causing the so-called shoulder effect. So on the two tips of the balloon, there is a significant risk of tissue and vessel wall damage and dissection. And because of that, during the time, there were strategies of non-compliant balloon, scoring balloons to redistribute the tension of the balloon over the vessel wall more evenly in order to avoid local shear stress and local dissection. One of the next strategy is shown here. This is the so-called chocolate balloon. Many things about the chocolate balloon as a scoring balloon. In fact, it's not. Why not? Because the nitinol wire is not outside. It's not on the surface of the balloon, but it's inside. It's in fact containing the pressure. So it's becoming, because it's the structure of the balloon is multi-segmental, this is in fact containing the pressure over the vessel wall, not only radially but also longitudinally. And this is the way in which we have much better distribution of the tension of the balloon over the vessel wall. Okay, several words about the indication and how to inflate. So we have to inflate after calculating 1-to-1 ratio in comparison to the reference diameter, not more. So oversizing is not a good idea. And 1-to-1 is a very good choice, because the even inflation of the balloon is absolutely enough to open the artery, the stenotic artery, properly. Second, it has to be inflated very slowly, and it has to be inflated for a long time, so at least for 1 minute, in order to overcome the natural resistance and the trend for recoil of the vessel. So these are the principles of inflating the chocolate balloon. That is the new technology. So several examples of tissue damage from the simple regular balloon. You see the dissection, the circular dissection on several pictures, and especially when we have oversizing. So oversizing is not a good idea, but even with oversizing, you see that the oversizing is the biggest on the third column, where is the chocolate balloon inflation tissue shown, and you see how smaller compared to the other two is the local dissection of the vessel wall. Okay, I told you already that at least 1 minute, better 1 minute and a half to inflate the chocolate balloon in order to have the perfect result. This is the chocolate bar study, both above the knee, superficial femoral, and below the knee cohort. They are evenly 50 to 50% distributed, and from here it's very nice to see that multiple risk factors patients, and with more than 20% total occlusions and with a significant calcification. What we have spoken, the calcification is the enemy of even and predictable inflation. So this is quite a complex cohort of patients that was studied. What about the flow limiting dissection, freedom from flow limited dissection, and hence the freedom from bailout stenting? Excellent results. adjudicated results, it's 100% flow limited dissection freedom, and freedom from bailout stenting, it's 98 and 99 respectively. So it's for us it seems unbelievable. So because all we know that at least in our daily practice, at least in 30 to 50% of the ballooned SFAs, we have to implant a stent. And of course, the clinical result is also, this is the most important, this is the hard endpoint. And the hard endpoint is speaking have freedom from major implant amputation more than 95%. Taking a look by historical point of view on the data behind, we see that in these trials, compared to other trials, the probability of flow limited dissections and bail out stent placed is much lower, dramatically lower, compared to the data from Marc Bouzier from Belgium, compared to the absolute PTA and the resilient PTA arm. You see that really the difference into the numbers is unbelievable. So, as a summary, I would say that optimal balloon angioplasty can lead to very good acute result, and we need slow and prolonged inflation to have a good result. Finally, we can predilate, but not always. It's not always so necessary. And the results from the chocolate bar registry show freedom from flow-limited dissection very close to 100%. I will show you several cases from our practice. All of them were with very symptomatic patients with multiple risk factors and multiple vascular pathology. The first one is a patient with distal lesions, posterior tibial artery with several critical stenosis. And this patient here was a diabetic one. Diabetic patient with distal stenosis on the above and below the ankle, with several critical stenosis. In this situation, this in fact was our first case to use the chocolate balloon. This is the Trailblazer supportive catheter in order to cross the lesions. And after crossing the lesions, in order to avoid bailout stenting with coronary balloon in most of the cases in this situation, we inflated the chocolate balloon on different levels of the posterior tibial artery, prolonged inflation with very slow inflation in order to overcome the resistance of the lesion on all levels of the pathology, and we were happy to see a really perfect result with excellent flow and absolutely acceptable residual stenosis. The second patient is a male, 76-year-old, with multiple risk factors, with a low ankle brachial index on the right leg, with quite a long SFA occlusion starting from the ostium. And for this very calcific lesion, you see also the critical stenosis of the profunda. So it's a patient that we crossed, in fact, firstly the wire into the profunda, and we tried several times to cross also the proximal cap. Finally, we succeeded with the Super J, the Terumo wire, that we like very much, the Super J wire, because it's there is quite a big probability to stay into the lumen or to go back into the lumen even after performing a dissection. So it's really a very, very good wire. So after the crossing of the lesion, we interchanged with 014 wire, that is the chocolate balloon compatible. And we performed several long inflations of the chocolate balloon. This is the balloon coming.
I'm showing by purpose this picture in order to see that even without predilation it's possible to cross even total occlusion lesions directly with the chocolate balloon. But of course, it's probably better to have some vessel preparation first, and after that to finish the inflation with the prolonged inflation of the chocolate balloon. This is the final result. And you see that it's unbelievable, in such a huge calcific lesion, practically no dissection. So it was even for us a surprise, because this was the first femoral case that we have done. And we had performed also a kissing balloon on the level of the profunda and the osteo SFA in order to keep open also the profunda as a future bailout. So this is the final result. You see really excellent result without the need of stenting in this situation. It's more than obvious. So this is the final case with a critical limb ischemia on the right side, 68-year-old gentleman with a total occlusion, not within the stent, but also starting from the ostium of the SFA. It was not very easy. I had to use, in fact, this is the third in-stent occlusion, and we had to use the Confianza Pro 014 wire in order to go back within the lumen of the stent, because the wire has the tendency to go aside, so to make a dissection and even to go around the stent. So this is the crossing within the lumen of the stent with the Confianza Pro. That is one of the most aggressive coronary wires, and this is crossing the distal popliteal occlusion. So it was staged occlusions on the level of the SFA and on the level of the popliteal artery. It was was the first inflation with 6 millimeter by 220 millimeters long simple balloon. You see not very even and absolutely insufficient expansion at 16 atmospheres. So next step was the chocolate balloon, both on popliteal level. You see how to overcoming the critical stenosis, in fact the occlusion of the popliteal artery, and also how even is the inflation on the level of the stent. And this is the final result after this repetitive restenosis and reocclusion of the SFA. Okay, and this is a case from yesterday. This is a case from yesterday with a critical stenosis of the short critical stenosis of the SFA. This is extremely suitable for chocolate balloon in order to predictably avoid stenting. This was after the 5 millimeter balloon. We checked by high definition assist device, and we saw very interesting that there is a still significant residual stenosis and some dissection and residual stenosis, you see. So we inflated on a second step a 6 millimeters, so 1 millimeter higher compared to the previous by 80 with a very prolonged low pressure inflation. The surprise was twofold. First, the dissections was less, so we had less dissected segment. This was the contrast injection that you saw within the lumen. And the second was that the residual stenosis is practically zero. So it was definitely proven by two methods, angio and TIVUS, that we had, and this is the final touch in order to improve the long result, the long-term result in this lady, and this is the final result I saw below the knee. As a conclusion, I would say that the chocolate balloon is a next-generation peripheral balloon reducing flow-limiting dissection, bailout stenting need, and improving the late patency rate in challenging above and below the knee peripheral vascular pathology. And thank you very much for your attention.
Yeah, the in-stent restenosis is very nasty. So if you go in with a balloon, you cannot expand the stent. You have some residual dog boning in the stent. That's the nasty one. And we don't have a good solution for that. Sometimes it is good going with a chocolate balloon there, but sometimes it's not enough. And then it is off-label. Sometimes you can do it with an atherectomy from the Medtronic. I think this is off-label. It's also contraindicated. You shouldn't do that. The firm says that, but the only indication is you have to remove that material that is in the stent. So that's the only way doing that. But with a chocolate balloon and in-stent restenosis, it was a good result.
Yeah, absolutely right. We have different other technologies like shockwave balloon, like atherectomy and other devices in order to overcome the resistance of the material there. And but I think that the chocolate balloon is a very elegant option, and especially in the long in-stent thrombosis. After the first ballooning, I was absolutely disappointed, and we were thinking about even to place stent in stent. But after making the chocolate balloon inflation, it was some kind of wow effect. It was really the effect of the scoring balloon without damaging the tissue. It was really very interesting.
This is a plain balloon. We have also chocolate touch with drug coated on it.
Yeah.
Are you using it also?
Yes, exactly.
Okay.
Okay. I see a picture from the angio already. In case our colleagues are ready in the angio,
we are ready.
Are you here us? Are you ready to show us something?
Oh, good. Yes. Can you present the case?
Okay.
Yes. Go ahead.
We have a very interesting patient here with multi-level atherosclerosis. He's a claudicant now, very short distance. And his ABI index is 0.36 now. So he's pretty critical. 2 years ago, almost the same procedure was performed successfully. He has a chronic total occlusion of the superficial femoral artery, almost a flush occlusion. And our colleagues managed to perform the successful recanalization, not successful from antegrade, so they had to puncture the distal SFA and go retrograde because they were unable to go into true lumen from above. And this reconstruction was working for a year and a half, and since 6 months, he started experiencing this claudication again. So we are now going contralateral from right to left. Let's see the pictures.
So probably during the last intervention, because we show the figures, actually the colleagues have done a great job there. But it seems that despite the use of DCB, it was a subintimal recanalization, and probably we have some kinds of recoil. There is some calcification, let's say moderate calcification. Here is the occluded SFA. There is very small stump there. Let's go to the next picture. And then, no, go to the angio, please. Go back. Go back. Here
could
you are.
Could you explain for the audience? Sorry. Could you explain for the audience how do you engage within the stem, and what kind of materials do you use in this case?
With stent. We don't have any stent here.
There is no stent.
So there is no
No,
stent
I mean
here.
the stamp, the nose,
okay,
the stamp.
Sorry, I didn't hear it. Let's see, first of all, the outflow. We have a patent P1, distal SFA P1 segment. There is a good trifurcation there. We know it also from the previous diagnostic angiography. And now the idea was to try to go from the stem. Let's go back now to the previous. So the stem here, you see, it is difficult. So what we are doing in this case is either you can use a Berenstein catheter, or you can use a catheter like a RIM one to cut it in such an angle that it is more or less a Bernstein catheter in order to direct the catheter and to have enough pushability. We need more, let's say, we need catheters that are relatively stiff. I like always the Cordis catheter in this indication. And by this way, we have used the Bernstein catheter and then command the 18 wire to penetrate the proximal stump. Let's see how it was done. Next, please.
For our colleagues, I will tell that it's possible also to use the internal mammary catheter, because
yes.
Not everywhere Bernstein is on the shelf, but the internal mammary play the same role in order to engage the proximal part of the cup.
Yes,
and of course, angulation, ipsilateral angulation of the X-ray machine is necessary in order to see the ostium of the profunda and the stump itself.
Exactly. So we are almost 24 LAO now, left oblique view, in order to be very sure where we're getting inside. It was almost 100% predictable that, we lost this. It was almost 100% predictable. I think we were outside.
Theo, I have a question for you. You stick with the 018 platform for SFA?
Yes, I'm trying to avoid 035 for the SFA. I'm starting using more and more 018 wires. Now we lost the wire here, but I try to get it like this. Probably yes, but let me try.
Do you use a support catheter when you engage, or you use a balloon catheter for support?
I'm using a support catheter. This is the Cornelian.
Cornelian, okay.
Okay. So we were able now to the small channel. You see here, I have the wire, the D18. It is only the proximal tip that it is outside the Cornelian, and I'm just pushing the Cornelia. Give me a dry gauge.
Theo, what
and
wire?
Then I'm just pushing further down. Here, you are pretty sure that you are in something.
Theo, you are in a good position. What would you prefer if this wire didn't work? What would you prefer? Would you step up? Which kind of wire?
No, I will go for an Astato.
Directly Astato. Okay.
Yes, I need a wire that has enough power to penetrate the cap. Now I'm just going a little bit. I'm rotating the catheters just to go.
Another good CTO wire is the Connect 250.
Yeah. Sometimes I have to stick the back of the Terumo. I don't recommend it. I do not recommend it, but sometimes it is so calcified. You cannot work with all 35 wires. You cannot work with the conger wire. You cannot with the hydrophilic stiff body. And then even Astato doesn't work. So then just to stick.
Like they say, this is the penetrating device of the pore.
Yeah.
Absolutely.
Totally right.
But the go-back catheter has such option.
Go-back catheter is the indicated one, yeah. In fact, that is indicated both for penetrating the cup and also to go back. It's really very, very good device. It's Israeli, I think. It's, yeah.
If you penetrate the cap, then you have done the procedure 30%. So it's important.
So try to push
Theo,
it.
Do you think you're intraluminally or supintimal?
No, it's
of course not. Of course not.
Okay.
Go back and try to penetrate. Go further.
Do you use all 35 wires in SFA intervention? All 35 wires.
Okay.
Yes. In 90% of the cases, we are coursing with Super J, 035. And I like very much the Gladius. Gladius, peripheral Gladius, and also the peripheral Gaia. The PV Gaia is really very good one.
Keep the wire
with Gaia peripheral, you are most of the time managed to be intraplaque rather than go outside the vessel.
Exactly.
And we have also the Halbert 12 gram. It's also very useful. It's also an Asahi wire. So you can also manage to go with a long distance in intraplaque.
Absolutely. Theo, it's probably...
So now
we are discussing about go-back maneuvers. And I don't know what you think, but for example, the go-back catheter is one of the options. And
yes, it is the best
yeah.
option if you want to avoid an retrograde puncture. Here,
Yes.
however, we will try a little bit more just to be sure that we have no possibility to go inside.
Yeah, we can appreciate the huge calcification there.
Yes, and it is not only the calcification,
Not
it is
very
also the
easy
stepping
to go
course.
back in such a calcium.
Do you use the go-back catheter a lot?
Yes, yes.
Yeah?
Yeah.
I think it would be good here because you are
Absolutely.
now on the vessel surface.
And because they crossed, always they have some channel.
Yeah, yeah, yeah.
And the 4 French go back, it's very suitable in this situation.
Because
we're pretty
the
close.
wire is totally
still.
It's totally on the vessel architecture, so this catheter could really work here.
Sorry, guys.
Or you have to do
So now we have to work a little bit more. Do you have a command?
Yes. Or he has to do a distal SFA or a peroneal puncture retrogradely because this is all calcified. I hope it's not going to go to a reverse cart procedure or a cart procedure. Because it's very calcified there. And of course, not losing the landing zone is also important. You cannot go beyond the landing zone, dissecting all up the vessel. So I think we should keep up above the landing zone.
Theo, are you still with the command 018?
Yes.
Yes. Okay.
I'm trying to be always cost effective. Because otherwise we have so many devices, but we have always to think a little bit on costs in these cases. I don't like
you are probably born in Bulgaria.
But
So
look
can
at the
you
distal
show me
cup,
the previous video?
it's type 4. It will
Can
be
you show
easy
me?
for
So,
distal puncture.
if you see here, I will also explain you
Look at
later
that,
on
yes.
on my presentation. You see a concave distal cup. So it will be nice if we can go on the left side of the vessel. We have higher probability to get inside the true lumen. But I will try to do this. However, I'm not promising that we will achieve this because the wire has its own god.
But you will succeed in the end. I'm sure.
You probably can take at least new command wire without changing the type, but to change the wire.
Give me now the command.
Yeah, because the tip is already
it's already
damaged.
done, so it doesn't serve for anything.
So give me a little bit
It's
of contrast.
absolutely unpredictable now with this wire.
Yeah.
So
I admire what you are doing just with one wire. It's excellent.
Okay, great.
Not bad. You have 1
I will
centimeter.
try now for a 014 wire. It has a higher probability to get inside any kind of dissection. Otherwise, we're going to use the re-entry catheter here.
Again, command 014?
Yes, command 14. You see, I'm really fixed on these two wires, command 14 and
it seems so.
018. I do not have any conflicts of interest, but I have a really good experience with both of them.
Yeah, it's obvious also.
Let's see. Here you are. Okay. Give me a torture.
Everybody has his favorite wires.
Yeah,
command,
but this is good.
Yes.
Yeah. Because in skillful hands, different wires are working perfectly. So it depends on the familiarity.
Yeah.
Absolutely.
So I'm trying to rotate a little bit. Do you have a new command?
Yeah, exactly.
Yes, we can. Yeah, give me one. Okay. So.
It's shifting lateral.
So here probably we are subintimally, but we will see. Yeah, just a moment.
I think you need a retrograde puncture, but
I think it's
still
subintimally. Stay deeply wide. Okay, stay there.
Yeah.
So I am now below the.
Oh, you're in.
Oh, great.
You're in, great.
Let's see.
Very good.
Yeah.
Okay.
You
So now
convinced.
we're going to start. Oh, no, let's do something else.
So you can do everything with command. Command 014, command 018. You
Yeah,
can do
command
everything
014.
with these two
love me
wires.
today. Let's go to change for an 018 just to have more. Okay, here you are.
Theo, is this the carnelian?
You are done.
This is the carnelian, yeah. You
How
see
is it
how
past
it's
the
doing a great
occlusion?
job actually, but you have to work with cornelian. You have to work two people because when you are pressing or you are pushing, let's say, the wire, you are always having the cornelian coming back. So someone is pushing and the other one is keeping the cornelian at place. So it looks good.
Excellent.
Yeah, good.
Yes.
Good
Always check
confirmation.
this, even if you are pretty sure that you are inside, always check where you are.
And what is your strategy now?
Now I will start with a 4 millimeter balloon catheter. I will open it, and then we will see how it looks like.
Okay.
You change now for a new command. Is it right? Command 014.
Now we are changing for a new command 8.
18.
The old
Okay.
one.
The old one.
So still we are cost effective.
We've already crossed.
Yeah, so we don't need to have a new one. So I will go down that just to be sure. Oh, here is the, here is.
Yeah. From the
This is the biggest
administration of
mistake.
Tukuda, they will appreciate that.
Okay, let's keep it here. So let's keep it
The
here
industry
and
will not like you, just with two
Here you go.
wires, with such a complicated SFA.
So the loop is my favorite loop because here you cannot really have any injury.
Damage, anything, yeah.
Yeah. So, and then give me the balloon. You can do it, sure. Okay. Let's lift it. Okay, perfect. We have the wire in place. I have the wire now. Okay, and now let's start to see what happens here.
Can you hold the wire?
Yes, I have it. Okay. And give us the balloon. 100, not 6. 4 millimeter. Yeah, this one. Yeah, good.
120.
So the point is, we had a previous, let's say, some pity-malware canalization, a previous use of DCB, but still, again, a reocclusion. Even if we have a good angiographic result, my question to you, would you stent it in any case or not?
I think it's very difficult here going without a stent because you have a long calcification, what we will see after ballooning. And is there a reason you chose a 4 millimeter balloon because the SFA is always greater than 4, first, and second, you are above the Hunter channel. So I think beginning with a 5 millimeter balloon would be not a bad option. But is there a reason you chose a 4? In the popliteal region, you are right. Okay, you can begin with the 4. It's also good.
I want to be very smooth always with the balloon. So I believe on vessel prep. I believe on DCBs, but at the same time, I believe that we have to be very gentle with such as CTOs in order to reduce the length of stenting. There is a big discussion. Sorry.
Yeah. Thank you, Theo. Sorry, you did, in fact, the most challenging part of the job on an excellent way. And because since a long time it's a lunchtime, if you allow me, we are going to have some break for a short lunch, and after that you are going to show us your stepwise approach and what you have done. Do you agree?
Okay. Keep a plate for us, just because we are hungry as well, and then go, please.
Okay. Yeah. Okay. We believe in you.
Okay. Yeah. Thank you. Bye. See you later.
Thank you. Let's go.
Keep the wire to go.
Why don't we, like the previous one, stepwise?
Yeah, you can do it. The best
Theo, do you hear me?
Да.
Hi, guys. Hello, guys. Do you hear us? Hello, hello. Did you finish? I can guess you finished the case already. Тео не го виждам, най-вероятно е тръгнал насам. Не. Явно са приключили, защото са стентирали, да. То се очакваше при така дълга оклузия, какво да е. Да. Hi, guys. Do you hear us?
Само секунд. Да. Всъщност те всеки момент ще се включат. Само ще ни пуснат колегите.
Shevket, obviously they finish because there are several stents more there, so more than obvious they finish the case, and we are expecting the connection to be established. Yeah, we continue with the case, and after that we continue with the program. Разменихме, извиняй. Hello? Hello, guys? Do you hear us?
Вие ли ще ни ги пуснете?
Hello?
Само секунда. Дайте едно назад. Да, но предната.
Чакай малко.
Ето това е добре. Това го оставете.
Not bad. Yeah, absolutely. Hello? Do you hear us?
Yes, I hear you perfectly well.
Okay. We hear you as well. So we see on the screen that you are done. You finished the case. Could you explain us step by step what you have done and how did you achieve this good result?
Okay. When you left us, we were at the point where we had a guide wire into the popliteal artery. Then we changed the guide wire for V18 because it offered more support. And then we started the inflation of two long 5mm balloons, plain old balloons, no packet Excel. Okay. Then we performed dilatation with 6mm by 200 drug-eluting balloon, followed by another 6 by 100 drug-eluting balloon. So we treated the whole SFA with packet Excel. We were sure at the very beginning of the case that we need to use stents because the results after the balloon was very, let's say, not satisfying enough. So we decided to put two self-expandable stents, and we covered the whole area. The proximal stents ends at the very beginning of the SFA, not covering the profunda. It's clear by this run. Yeah. Can we see the next one?
Very precise. Very precise implantation. Okay. Congratulations. Really very good result. What kind of drug-eluting balloon did you use? Quite long one?
It was 6 by 200. It's a Biotronic.
Biotronic. Yeah, great. Great, really
I must say
very good.
the stand was positioned really precisely, and that was very important.
It's a 6mm stand?
Yes, it's 6mm.
6mm. Yeah, there is some residual stenosis, but it's not dramatic, so
believe me, we performed post-dilatation several times by 12 atmospheres, and this was all we could achieve. I think it's reasonable result. Let's see the next one.
Absolutely. Without a shock wave, yeah, it's a quite good result.
Yes, the tibial vessels are patent. We have no signs of distal.
Could you show us? Could you show us below the knee result?
Yes, my colleagues will change this in a second. Can we? Okay, perfect.
Fantastic popliteal, very good.
And you see the
this is, in fact, here is the exit. Our colleagues, could you go back? The exit of the dissection is very well seen. You see the distal, and it's very well covered by the new stent. So definitely this is a good result. And let's see the below the knee result as well.
This is as far as we can go due to technical reasons, but by the speed the contrast is cleaning, we can say that
most probably, the outflow is good one. Could you tell us what is the plan? How are you going to close the access, right femoral access site? Manual compression or a closure device?
Here we are huge fans of manual compression, so that's the way to go.
Yeah, okay, you probably have enough residents to compress, so it's it's a good option.
Good point. Good point.
Okay, thank you very much. Great case, very instructive. Thank you.
Good point. If you're working alone, so if you have to do the whole thing by yourself, then you jump up to closing devices. But if you have residents,
it's workforce. Okay, good. We can continue. In fact, during the live cases, we have skipped one presentation from Dr. Stankov and from Theodosius. So I hope Zoran, yeah, okay, let's go, Dr. Stankov. You are the first. In the meantime, Theodosius will come, fortunately.
Hello, colleagues. Let us change presentation, please.
This is the wrong one.
I will talking about the femoral artery revascularization with combination of brachial radial and pedal approach. The radial approach is one of the safety approach and better comfort for the patient and for the team. From the date of the interventional cardiology clinical trials, the radial approach is very safety from the femoral or brachial with very low complication rate. What happened with, we know what happened in interventional cardiology. The radial approach is the approach for the first step for the intervention, diagnostic. For the peripheral artery disease, for the diagnostic, it's a very good choice. What happened with intervention? In the last year, the more endovascular specialists take the radial approach for the peripheral vascular intervention, but the very long distance from the radial to the distal stenosis, it's still a problem. But we not have the bleeding complication, and I tell again, the comfort for the patient is very big. And for that, most of the specialists want to use this approach for the intervention, but we still have obstruction. Brachial approach. It's the comfort for the patient, more from the femoral approach, effective option with the patient with femoral bypass, and with previous intervention, endovascular, on distal aorta and iliac artery. For the crossing from the femoral, it's not easy when we have implanted the stent in the distal aorta or in the ostium of the common iliac artery. But in some patient limitation of the light of the device, it's still is the problem. This is our publication for the safety of the transbrachial access. We used more transbrachial from the last year, and for that we want to see the safety of the brachial access, and we do retrospective analysis. In this analysis, we see the brachial approach, it's more safety than the femoral approach, with the low MACE in the group, in the patient with brachial approach. The brachial approach is in the safety approach, but it must be careful for the hemostasis. This is the date from the one study for the peripheral intervention with brachial artery access. It's the safety and efficacy. Pedal approach, one more very safety and comfort approach for the peripheral intervention we see in the session this morning, and can be one of the solution for the peripheral intervention, because now the device is with very low French, and it's one of the solution. What happens when we can combine the tibial pedal approach for the endovascular therapy and radial or brachial approach? It's a very good solution. We take two very safety and comfort for the team and for the patient approach. And it's very important because we see the successful open with the new device of the femoral occlusion. It's very high. Now we can do something for the comfort of the patient, for the comfort of the team. And combination of this approach, femoral brachial with tibial, it's a very good solution. I say this morning I take the angiographic methods for the pedal approach. We see here, after injected of the contrast, puncture of the artery, and contrast, we can see, go out from the needle. This is our experience with peripheral intervention. We can see before 5 years, we have only 2 dowel approach, and every year the number of the dowel approach go up, and successful of the procedure, it's the same, go up. We have only little number of the combined brachial or radial approach with compared with femoral and tibial approach, because why do I take the radial brachial approach and tibial only in the patient with previous aortofemoral bypass, stenting on the this zone, and only with patients with very indicate for this situation. In other patients, I take a tibial approach only for the finish the case, the opened artery. This is the first case with general atherosclerosis, with stent and femoral artery on the both sides, instant thrombosis of the femoral superficial artery in the left. This is the angio. We see the total stent thrombosis. I tried to going from the brachial axis for the open, but after the stent, I'm going on the false lumen. We can see on the second movie. And for that, one other reason for going the tibial approach is that this is very huge collateral, and it's not possible to go down with the wire and catheter. For that, I take the femoral tibial approach, do the true false lumen. After that, with tips wire from the distal catheter to the proximal catheter. We can see here, I'm going from the pedal approach from the microcatheter to the proximal microcatheter and do through and through. Predilatation, and this is final result for the artery. Next case, again with the general arteriosclerosis, with occlusion of the femoral artery. We have here step on the proximal femoral artery, but we not can cross from this occlusion. For that, we think that it's better to going from the tibial approach for the crossing from the occlusion. But in the distal occlusion, it's not possibility to crossing with wire. I take the go-back catheter. The go-back catheter, when you open 45%, the needle is straight, and you can use for the crossing from the distal cape. After the crossing, we crossing from the all of occlusion in the false lumen. False lumen coming, going to the common femoral artery, and now it's very easy to the crossing from the proximal cape to the same false lumen. And we again, after kissing balloon cutting of the intima, connect the through wire, and after dilatation, this is the end stent implantation, sheetless from the pedal approach, supera stent. And the next case, because I see that I not have time, again patient with generalized atherosclerosis. This is the angio. We not see this the ostium of the femoral artery, but we crossing from the proximal cap of the occlusion. After that, we going with tibial approach, and I want to back to see one huge collateral. We use this collateral because it's with only true lumen. We put the wire on from the proximal and distal part, and after the dilatate from the distal from the distal part, we place the lasso for the take the wire from the proximal and to do through and through. Can you please only last?
Панел на този екран.
Само последното. We can see here the wire crossing from the lasso, and here we going through and through. After stent implantation and balloon dilatation, this is the final result. Take-home message: transradial, transbrachial approach for peripheral intervention is safe and effective alternative of femoral one. Pedal approach is safe, effective, and associated with less contrast and radiation exposure. Retrograde pedal approach offer alternative endovascular option. Dowel approach with radial, brachial, and pedal approach offer multiple endovascular strategy in complex peripheral pathology. Thank you.
Okay, thank you, Dr. Stankov. Some comments and
of course.
questions?
Yeah, of course. When it comes to radial, I am very fascinated by the radial. I do this approach also very often. So the problem with the radial artery is if you treat the aortoiliac lesions, you can do that, even complex aortoiliac lesions. But when it comes to SFA, you need a second puncture site. And the pedal is a very good one for that because the length of the balloon is not enough to treat the SFA when you come from the radial approach. There are some devices in the market, but they are too expensive to use. So with this one, with one radial and one pedal approach, this is, we can say, how you can solve an SFA problem minimalistically. We can also call this a minimalistic approach in endovascular treatment. So I congratulate Zoran for this presentation, and I am also a fan of doing this kind of procedures.
Yeah, in fact, our friend Zoltan Ruja, he was the author of this overview of this analysis from Hungary, and he was one of the pioneers, one of the promoter of using a radial and pedal approach. Definitely, like you mentioned, it's really minimalistic. The problem is sometimes the radial artery puncture is quite long distance from the target zone. So in case the target zone is around the popliteal, the distance is quite long, and because of that reason, we are puncturing the brachial. So we are, let's say, gaining 40 centimeters more. And in our experience, like we published, the complication rate is very low. There are several reasons for that. One of the reasons is that the French size of the devices went down from the past, from this past in which the brachial approach was considered very dangerous, but for 9 and 8 French. Now with 6 French approach, the complication rate is extremely low. We have at least 500 brachial punctures per year, so the complication rate is not big, and we have a very good judge, and the judges are our vascular surgeons. So because is there a complication, the vascular surgeon is receiving the complication for correction. So definitely it's not very often. And because of that, we can combine radial or brachial depending on the distance. The good news is that the long sheet is nowadays, there are 110 centimeter long sheet from Terumo, from Cook, from different companies, I think from Merit. So there are many producers of long sheets. And this, in fact, is making closer the target to the tip of the sheet. That is with a very good support. And because of that, our threshold to switch from simple crossover to pedal, it's absolutely very lower now, because we have quite good results with the combination of brachial pedal or crossover pedal. So, and like you have seen, sometimes we are meeting the wires, and we are snaring the wires even in collaterals in order to be sure that both wires are in the same lumen. In case they are not, we are making the rupture of the membrane with a kissing balloon maneuver. And yeah, there are different tips and tricks that are helpful. Okay, good. I think in the program we have a complex case to be presented by Dr. Pavel Atanasov of two popliteal aneurysms complicated by a massive hematoma and a large pseudoaneurysm. Yeah, floor is yours.
Hello to everyone. I'm Dr. Atanasov. I'm a vascular surgeon, and for me, great honor to be here. I will present a clinical case for our practice, and I hope that you find it interesting. We're talking about endovascular popliteal aneurysm repair of two popliteal aneurysm complicated by a huge hematoma and a large aneurysm. The popliteal arterial aneurysm is the most common after abdominal aortic aneurysm. They are representing about 70–80% for all peripheral arterial aneurysm, and they are associated with a high rate of limb loss, around 23%. The main symptoms are acute vascular thrombosis of the main blood flow in the artery. The low extremity ischemia is the most common presenting symptom, occurring the secondary thrombosis and peripheral embolization. Another clinical is the claudication. Less frequently, secondary may be a compression of the vein near to the artery, cause the deep vein thrombosis and compression the nerve. The rupture and the formation of the arteriovenous fistula is relatively rare. Our case, patients hospitalized urgently in the Department of Vascular Surgery and Vascular Surgery after a clinical examination, of course, with color-coded Doppler sonography and angio. The presence of two popliteal aneurysm with elongation and multiple deviation on the vessel with thrombosis was established. Presence of a large pseudoaneurysm and hematoma of the old side too. This is a picture showing our patient during the examination. We see the huge hematoma on the right side. Patient is a 60-year-old male, cardiovascular burnout, suffer with arterial hypertension, ischemic heart disease, active rheumatoid arthritis, and chronic obstructive pulmonary disease. There is no history of embolic events until now, no history of anticoagulant and antiplatelet therapy to date, and he has history of multiple knee punctures in the last 1 month with sudden pain, swelling, and bruising of the limb. The critical ischemia of the limb is over 72 hours, and with treating the revitalization of the limb. During the examination, we find the missing pulse distal of right common femoral artery. This slide shows the lower constellation. We see the severe anemia, cause of bleeding after retrograde lesion of the aneurysm during the punction. No abnormalities in the term of ECG or chest radiography. During the ultrasound Doppler sonography, we found a severe atherosclerosis with vascular calcification, two popliteal aneurysm, pseudoaneurysm with large hematoma. We found a weak collateral signal distally, ankle brachial index around 0.4, and we found a normal function of the venous system without compression of the aneurysm. The first picture showed the first aneurysm. It's located in the P1 segment, 32 millimeters long and 34 millimeters wide up to lesion. The second picture on the right, there's a large pseudoaneurysm, about 200 millimeters cranial, wide up to 73 millimeters. Density, 61 Hensel units. we're talking about hematoma. The picture on the left shows the second aneurysm in the mild third of the popliteal artery, length around 46 millimeters, wide up to 27. We also see that there is a wall thrombosis with elongation in numerous vascular deviation. Before surgical intervention, I have to say that the planning is the most important thing before the procedure. The anatomy of the target vessel must be evaluated carefully. We use the typical femoral access with mini punction and antegrade angioplasty with DCB Paseo 18 lux. Then, step by step, we deployed in each stent. Verifying angiographic landing zone or without data for endoleaks. This image for our procedure. This is the initial angio. We see the elevation, the tortuosity of the vessel, the aneurysm. The second one, we show the inflated balloon DCB Paseo 18 lux. Another picture shows deployed the first superior stent, 6.5, 150. We call it external. The next picture on the left, we see the second internal superior stent, 6.5, 120 millimeters. You see the next picture in the middle, the third stent. Here 7.5, 60. Same the internal, and you see the final angio. This first angio and the final angio with knee flexion, of course. There's no fracture, there's no kinking, there's no data for endoleaks until now. After procedure, we got the pulse of the popliteal artery and the posterior tibial artery. Good Doppler sonograph signal of tibial arteries. We see the first picture on the left, the proximal aneurysm, show the blood flow through the reconstruction. In the first aneurysm, the distal aneurysm, and you see the instant arterial flow in the longitudinal slide without dated endoleaks. Postoperative, we got a gradual reduction of complaints with restoration of sensory and motor volume to significant extent, restoration of laboratory reference value, and without the development of reperfusion syndrome due to adequate postoperative treatment. That is really important too. The patient was discharged on the fifth postoperative day with warm limb, without residual paresthesias, still have pulse on the popliteal artery, the posterior tibial artery, pulsation, good pulsation signal of the crural arteries with ankle brachial index around 0.8. We now have clinical evidence for arterial insufficiency. We prescribed a double antiplate therapy and vasculative drugs. Of course, the occupational therapy is important, and we make a follow-up of Doppler sonograph at the first, 4th, and 12th month, and CT angio at the 6th month. Next slide will show the CT angio at the 6 months. The picture on the left, you see the CT angio reconstruction of the superior stents. There's no, we see the main blood flow through the reconstruction and without data for endoleaks. I think the reconstruction fit well of the size of the vessel. This is axial slides of the CT angio reconstruction. We see the pseudoaneurysm, the distal aneurysm, the proximal one. We see only the blood flow through the reconstruction. Conclusions. Complicated popliteal artery aneurysms are a relative rare pathology with a high risk of limb loss. Endovascular treatment of the popliteal aneurysm remain one of the major challenges facing to endovascular surgery. EPR using dual rare modification of superior stents with high density of the mesh without loss of flexibility is a promising method that could be a solution of this problem. Thank you for your attention.
Thank you. Thank you very much. Dr. Atanasov. It's in fact interesting strategy. It's not the straightforward one. It's in fact the homemade creation of a flow diverter. Yeah, and it's in fact slowing the flow into the aneurysm and finally thrombosing. So it's a very, very good idea. And yeah, with Supera, there are big number of cases published. There is no big trial, but there are small series showing promising results. So it's a good choice. Definitely, it's a good choice. The other choice in this situation, because this is the more or less straight part of the popliteal artery, it's absolutely acceptable. We know very well that just behind the knee, it's because of the flexion of the leg and the artery, the results are not so good. But in this location, it's a very good choice. So congratulations. What is your personal experience?
Yeah, the popliteal aneurysm are a headache. So I had a lot of trouble with popliteal aneurysm, especially if you are in the P2, P3 segment. So these aneurysms are really tough to treat. I go especially for this one, endovascularly, of course, but then you have to think of graft stents like Viaban or something like that. If you improvise techniques, it won't work in that areas. You end up with fractures of the stent and with restenosis and with a lot of bad complications. So at that part, I think surgery is not a bad option at that part, especially in the P2, P3 segment. But as our presenter has said, if the aneurysm is more proximal, yes, that can be a solution. But if you are in the P2, P3 segment, I think surgically it's a better option.
Yeah. For the situation in Bulgaria, it's a very good option with Supera, but we have some limitations because the biggest Supera is 7.5. If you have bigger vessels, it cannot be done. And the other important thing is to put one size Supera, one in the other. So 6.5 point.
6.5 point.
Yes, in 6.5 point.
I see Igor has something to comment. So, Igor.
Thank you for the presentation. Nice case. Did you consider to remove this hematoma afterwards because it's so huge? It can make problem to patient of walking and functionalities, etc.
Yeah, thank you for the question. After a procedure, we don't have problem with the hematoma. There is no liquefaction, and there was not necessary to remove it. Just follow up after 6 months, 8 months. That was not a problem with it.
Last question. I saw that the patient has the same pathology on the other side.
50.
Do you plan to do the same?
Yes,
okay.
this November. Okay.
So I had some experiences. I improvised with the B graft, balloon expandable, and then I put a self-expandable stent inside the B graft. So it get not constricted, but in the midterm it didn't work also. So you have to have dedicated devices for there. And but Supera, I think in the P2, P3 lesion within popliteal aneurysm, and it is sometimes very difficult to open the device, the self-expandable device, because you have a lot of tension.
Tortuosity.
Yeah, because of the tortuosity. I had also cases I couldn't open the stent. I pulled, and I had a complication with the proximal part in my hand, so I had to do other maneuvers to solve the complication. So
we had similar. We can publish a series.
Yeah. So the self-expandable stent that is easy expanding in that area is the Y-band. But I had one case I couldn't even manage to open the Y-band. So it got stuck. You get the proximal part. It stays. It was awful. So the distal part is very difficult. So.
Okay.
Any surgeon in here, so he can comment on the surgical results?
90% of the audience are surgeons, so
so we need some consultation then at that part. So the surgeons said to me that this is very easy for them to fix. Is it? The popliteal aneurysm? Yeah. So, okay.
With the proper planning, you can do a venous bypass. So it's
Okay, but you are not doing a bypass. You are just open and repairing it, is it? Okay.
Then you, according to me, of course, you don't need to open the aneurysm. If it compresses the graft, then you need to remove it.
Yeah.
Okay, we are probably done with this case. Thank you very much. Very interesting and very good discussion. Thank you. And I remember we have skipped Dr. Vauchev's presentation, who is going to comment, or Dr. Bizdas. Okay, let's go. Thank you for coming once again, and congratulations for very good cases. Thank you.
Thank you, thank you. Okay. So, thank you very much for the kind invitation. Congrats again for the excellent meeting and the topics. So, my topic today is how to cross infrapopliteal CTOs in CLI patients, all you need to know. And we go through a number of slides and cases that we have collected together with Lorenzo Patrone from UK, where we want to show you all the different techniques and aspects of this let's say, of these procedures. So here are my conflicts of interest, and when we are talking about chronic total occlusion, we have to think on what is behind this. And if we look in a macroscopic picture, you will see this is what we are treating. That means if you want to treat it adequately, that means you need to be aggressive with the vessel. Otherwise, any other treatment will not last for a long time. And if you see on a histological way, you will see that we have a lot of calcification. This is the balloon inside that needs to open this vessel. And this is the reason why you see that we are starting to be more and more aggressive with the infrapopliteal arteries. Another important issue that we have learned during the last years is how we analyze the CTO. And we analyze the CTO based on two important things. First, on the structure of the CTO, and we mean the proximal and the distal cap. And on the second thing is about the so-called hibernating lumen. That means between the proximal and the distal cap of the CTO, there is always a channel to go with your wire through. So what we have learned, and we have seen nicely in the live case that we have done in the SFA, we are now checking the proximal and the distal cap based on the structure, if they are concave or convex, and by this way we can decide if we have this kind of proximal and distal cap, we can go directly through a transfemoral approach in order to be to stay intraluminal. If we have this kind, then you may need to go just from a transpedal approach. And if you have a mixed, then you may need to have a rendezvous technique from above and below. On the other hand, I said we are talking about hibernating lumen of the CTO, and you can see how it looks like. There is always a small channel. There are always thrombus inside the CTOs. You cannot see anything, but it doesn't mean that there is nothing there. That's the reason why the most important thing is to penetrate the proximal or the distal cap. Through this way, Dr. Mustafa and Dr. Fadi Zab, they have developed the so-called CTOP classification. They have 4 types of CTOs. In the type 1, you can go directly through a transfemoral approach. In the type 2, you have the problem that when you're reaching the distal cap, you may go subintimally. So in that case, you may need a rendezvous technique. In the type 3, this is the most challenging one, where you can go directly subintimally. So you need techniques like CART, reverse CART, and re-entry catheters. I will show you some of these cases. And in the type 4, you go subintimally, but in the majority of the cases, you can do everything through the so-called TAMI procedure. That means transpedal. So what we recommend in those cases, if you have type 1, go for a traditional CFA access. If you have type 2, go for a dual access. Type 3, the same. Type 4 is just for a pedal access. You don't need either need to puncture the common femoral artery. This is a classical transpedal approach in the posterior tibial artery. Use the hockey device for your ultrasound because it is more, let's say, comfortable to to work with, and then try to puncture in this area above and below the ankle, because if you're going above this, especially for the fibular artery, you may not able to control the bleeding, and we have seen some cases of compartment syndrome after opening all these vessels. This is we're using ultrasound for the puncture. Here is how you're puncturing. You're trying to go at 12 o'clock, and then you can see very nicely how the wire is getting inside. Another technique that we're using is that we are going with the needle very closely to the dorsal pedal artery. We are injecting contrast agent, and on that time we are carefully puncturing the dorsal pedal artery. You see the contrast agent coming out, and then you know that you are inside and you can do whatever you want. This is the appropriate equipment. You need a needle, you need an O18 wire, V18, command 18, and you need, if it's possible, a support catheter. This is a CXI O18 support catheter. Don't try to use O14 wires. They will not have this possibility that you want for this kind of interventions. This is a classical case where you see a closed posterior, anterior, and fibular artery. The idea is to recanalize the fibular artery, and here is the puncture. The wire is getting above, and then you have a rendezvous with the other wire. You see the CXI catheter is always supporting this. Due to the fluid dynamics, because there is a shear stress always in the distal tip, or in the majority of the cases, the distal tip is more smooth. You can go, let's say, you can go simpler through the distal tip compared to the proximal tip. And here you can see the rendezvous technique, balloon angioplasty, and after the balloon angioplasty, you can have a very nice result where you can see a nice fibular artery. It is patent, and here where there was no blood, there is a lot of blood, and everything is coming from the fibular artery. That's led to, of course, let's say there is the second stage. The second stage is to treat this kind of cases. This is the case with occlusion. After treating this, we have done a very good wound debridement. We are trying to remove the whole infection from there, and then there is no reason to keep this tooth. We have done a metatarsal amputation. We have let's say, cleaned the heel, and we did a nice skin transplantation. And after you see how it looks like in 1 month, look how it looked like at that time. Everyone wanted to really amputate this limb, and at the moment, at 2 years, we have a really excellent result. The limb is saved. So now, of course, we have to think about difficulties and challenges, that the world is not so simple always. And in that cases, we have techniques like the card technique. You're opening with a balloon the subintimal space from below, and you're trying to penetrate it with a wire from above. The reverse card technique is quite the opposite. And then if you are not able to do it card or reverse card, you can do the parallel balloons. That means you are inflating both balloons at the level of their rendezvous, and at that time, more or less, you are cutting the membrane, and you are trying to insert the wire from above or from below. And the fourth technique is to use a re-entry catheter. That means you are using a balloon from below, and then you are coming from above with a re-entry catheter. You are really penetrating the balloon, and by this way, you can connect the two lumen. Let's see some of those cases. Here is a case where you can see a dorsal pedal artery that it is occluded. We tried to go from above. There is a loop. We stayed subintimally. There was no way to get intraluminal. Again, here you see subintimal course. We puncture retrogradely, and in that case, we try to get inside. Again, we had to do the parallel balloons technique, and by this way you can see that we were able to advance the wire, and then after balloon angioplasty we had a very nice result. Always good perfusion means a good treatment. Even in this case we could keep the first two despite this osteomyelitis that he had. Here is the use of the Outback re-entry system. As I said, you are going from above, very challenging case, this one, and we went from below. We were not able to penetrate the distal cap of the occlusion, and here is how it looks like. Here is the re-entry catheter. The re-entry catheter has here the L. The L means where the needle is coming outside. This is the balloon catheter, and in that case, you see we are really getting inside the balloon. That means the wire is inside the balloon. Then we're deflating, the balloon is catching the wire, and then we are just deflating and removing back, and by this way we have the connection. Afterwards, we have opened it, and we have done a very nice and aggressive angioplasty with very nice result, and this is the final results with complete healing of the foot. Pierce technique, I really love the Japanese guys that they thought about it. What is this? It is the case where you cannot really advance your balloon catheter. You have advanced the wire, but you cannot advance the balloon catheter due to the severe calcification. This is the case here. You see severe calcification of the distal part of the anterior tibial artery. We went with the wire up to that level, but here we couldn't further. Here you can see the wire is getting into the dorsal pedal artery. We are really happy with the result here, but we cannot advance the balloon. In that case, you're taking a needle, you are just puncturing the skin, and you are trying to really destroy the vessel. That means you are trying to destroy more or less the calcification. This causes a fragmentation of the calcium and makes more easily to get inside. You see, we can further advance a little bit. Now again, at very distal, you can see here that we are trying again to destroy the vessel a little bit. We can further advance, and at the end, we had a very nice result. Here is the final result. The dorsal pedal artery is now patent, and you can see that this makes the difference again, where we can save again a limb from amputation. Very important thing is also to understand the perfusion. In my opinion, this is the future in CLI treatment. It's not only the recanalization, and here you can see a case where everybody says this leg should be amputated. However, it was the only leg that the patient had, and we had to do anything to save this limb. And what we have done an angiography. Actually, someone could say everything is fine here. Why should you amputate it, and why doesn't heal this? But you can see that there is a peroneal artery that it is still occluded here and goes up to the posterior tibial artery. So this vessel is really important to recanalize, and we are doing in Athens and the so-called spectroscopy in order to see the temperature at the level of the forefoot. And when we have reopened this vessel, so this was the reopening of this vessel, you can see the big difference in the perfusion at the level of the forefoot. And this is led to a nice healing of this foot. We did a nice metatarsal amputation. We performed a skin transplantation, and this is a result already at 6 months. So VAS technique, the last, let's say, barrier, when we have a no option CLI, we don't have nothing. There is the lymph flow device, in my opinion, is too expensive for what we can do there. So we are starting using the VAS technique. The VAS technique, you are getting a snare into the artery from above, a snare into the vein from below. You're putting them parallel. You're trying to go with the needle through the two snares, and then you're checking that you are inside. You have just punctured the skin at that level, and then you are inserting an 014 floppy soft wire, and what you're doing, you're just pulling back the snare from the artery, you're just pulling back the snare from the vein, and by this way you have your arteriovenous anastomosis. Then what you're doing is just using a cardiological balloon to perform the first angioplasty at that level. You're using a covered stent, and then is the whole thing with the covered stents up to the ankle. And you have an excellent result. This is the case here where we had no option to treat this case. We have done a metatarsal amputation, but at the end, we could save this limb. So I would like to perform my synopsis. The TAMI procedure, that means the transpedal access, and the CTOP classification changed completely the success rate of recanalization of BTK CTOs. Technical success rates is, according to the evidence, around 97% if you're using transpedal access. The recanalization of BTK CTOs requires a learning curve and appropriate equipment, and the AV reversal seems to be an effective strategy in no-option CLI patients. However, in my opinion, CLI treatment belongs to dedicated CLI centers and teams. Thank you again for your invitation.
Okay, thank you. Thank you, Theo. Dr. Volchev, can we have your presentation now?
Dear colleagues, to be honest, I really hope that in the second live case, we will need to use the re-entry device so I could prove my point, but Professor Business was flawless, so he ruined it for me. But however, we know at least the last 10 years, we do endo first for all kinds of chronic total occlusions in the in the aortic or femoropopliteal segments, and the success rate has increased dramatically due to the use of the new devices and techniques. Of course, we can argue about this, but maybe the best way to recanalize a vessel is to go intraluminal, but this is rarely possible, and sometimes we have to do a subintimal recanalization. The industry has flooded us with a lot of different crossing devices, and whenever we're planning to cross a CTO, we should plan whether to go antegrade or retrograde, and this is highly dependent on the plaque morphology, as Professor Business has already shown. So, of course, we have crossing devices, we have re-entry devices, and what's new is the percutaneous bypass technique. Although the re-entry devices have been around for about 20 years, there is still little information about their efficacy. So I'll show you a couple of randomized trials which showed that when the endpoint is technical efficacy, we see 100%. So it was useful in all the cases that was used, compared to 42% when manual re-entry was attempted. And what is more important, that in the first group, the mean procedural time was 36 minutes compared to 55 in the second group, and this is also true for the mean fluoroscopy time, which is 29 against 39 minutes. This is a systematic review, and here the endpoints are complication and technical success, and device accuracy, which is defined the distance between the point of true vessel reconstitution and the eventual re-entry. The success rate of the outback catheter was about 93%. Only 7 cases failed due to heavy calcification, but this is true for all re-entry devices. No major and only 17 minor complications. What about the aortoiliac segment? This time, the endpoint of this research was long-term outcomes after intervention, and you can see there's practically no difference whether when we use a re-entry device or we do manual re-entry, virtually no difference. The last one is a systematic review of 30 studies and more than 1,000 lesions, which shows that re-entry device was used in roughly 20% of the cases, and the procedural success rate was close to 90%, as cited earlier. The complication rate is really low. It's rated here from 0 to 10%, although in our experience it's closer to 0. The only real complication might be a vessel puncture, but usually it heals by itself. And the primary patency rates are absolutely comparable. There are many re-entry devices on the market today, but maybe one of the most widely used are the Pioneer catheter, the Outback, and the newly developed Go-Back catheter. The Pioneer catheter is really sophisticated and very accurate because it has an ISEVS platform. It has a side port where the nitinol needle is entering the true vessel, but by using the ISEVS, we can very easily point the needle towards the true lumen and make the re-entry very accurately. It was the first FDA-approved device. It has ISEVS integrated system. It's very accurate, that's true. And as with most re-entry devices, it's relatively stiff, so it's difficult to track up and over the bifurcation, especially in cases where we have very calcified aorta and very difficult angles. And the other main disadvantage is that you need a capital investment in buying this ISEVS platform. The Outback catheter is much more familiar with. It has fenestration about 12 millimeters from the tip, which practically means that every time we want to re-enter, we have to do some small dissection in order to puncture the reconstitution artery. It's again difficult to track up and over the tight bifurcation. Severe calcium is again disadvantage, and it makes the penetration much more difficult. What we were lucky enough to get our hands on in the last year is this go-back catheter, which in my view has several advantages. It can be used as a guiding catheter and support catheter, and in cases where we see that the guiding wire is going outside of the lumen, when we show the needle a little bit and point it toward the right direction, we can continue with the intraluminal recanalization. So it's a very stiff catheter, so it follows the guiding wire everywhere. The other advantage, in my view, is that the needle is going straight from the top of the catheter, so in theory, you can puncture the distal cap very precisely without causing further dissection, because most of the time our concern is not to prolong unnecessarily the distal dissection zone, because we save it for eventual bypass in case the endovascular procedure fails. So this is very important for us. Furthermore, it's a very low profile. So it uses both 014 and 018 guide wire system. It has several applications. For example, I believe Dr. Nikolov has mentioned that one of the applications is to puncture this relatively easy looking cap, but sometimes it takes a lot of effort to puncture, the use of several CTO guide wires and so on. But by using the device and only showing the needle for half a centimeter, you can puncture the cap, and with the hydrophilic wire, you can easily continue with the procedure. You see here we have a flush occlusion of the SFA, and although a lot of effort is put to go back into the true lumen, it seems rather difficult. So by using the entry device, a lot of time can be saved, because otherwise we have to go retrograde or perform any of the techniques that we saw in the previous presentation. That can save a lot of time and radiation exposure. And you can see here the distal cap is, it gives us the information that antegrade re-entry would be extremely difficult, so we should go retrograde. But in case we decide to use a re-entry device, we again can save a lot of effort and a lot of time. Here again, when we see the distal SFA or the proximal popliteal artery, very diseased, a lot of calcium, a lot of plaques. So again, going back into the true lumen seems rather impossible, or at least very difficult. By using re-entry device, it makes the procedure much, much easier. So we all know that re-entry into the true lumen is the most challenging part of performing CTO recanalization. Re-entry device allows us for limitation of dissection, which, as I mentioned, is very important to re-enter as soon as possible. And although it adds to the cost of the procedure, it saves a lot of time, operational time, and which is more important, radiational exposure. Thank you.
Any questions from the audience? Next session, yeah, okay. Okay, if we have no questions, I propose to finish with this session and to invite, we invite the panelists from the other session.
Hello. Good afternoon. Okay, I think we are moving up from peripherals to aortic interventions. And I have a pleasure to invite first speaker, Professor Klaus Matthias, for his presentation, EVAR versus PVAR.
Yeah, thank you very much. So I will try to be fast because we are already delayed by 20 minutes. And so access, yes, we have these two methods, as you know. Originally, it was always surgically, but then we developed this percutaneous technique, and I will go into some of the details. Before you start with that, naturally, you have to know not only size and location of the aneurysm and the distance to the neighboring arteries, especially the renal arteries, but you must include in your CTA also the femoral area in this case, because you want to use these artery as access vessel, and so you have to know how does it look like. Yes, when we look at the mortality, yes, open surgical repair is in the range of 4 to 5%. EVAR is much lower, below 2%. And you see, yes, when it has ruptured, even then, EVAR is a little bit better than open repair. So today, we can say EVAR is a preferred treatment method for abdominal aortic aneurysms. So open versus percutaneous means, yes, you have to prepare the artery, and at the end also you have to close by a suture the access side of the femoral artery. The other one is you puncture it. Sometimes it's helpful, as you have already seen, also to use ultrasound to hit the anterior wall and not only somewhere, but in the middle of the anterior wall, it's best. We have, in the meanwhile, several closure devices, and that allowed us to use these percutaneous access. I prefer, yes, often two systems, which I turn the next one by 45 degrees, so I have 4 needles coming out. And we have the advantage that over the years, yes, the endografts were becoming smaller and smaller. So we started with 24 French, and now we have systems down to 14 and 16. So that is very helpful. And at the end of the procedure, yes, you see the puncture sites, and the patient is feeling well, and it's very uncomplicated. It was first done in 1999. Today, more than half of them are done percutaneously. The advantages are clear. No general anesthesia, no intensive care unit afterwards, shorter hospital stay, more economic. There are limitations, as with every method. So when it's heavily calcified, common femoral artery, then you have to look very carefully if it's not better to go with a surgical technique. Because you have not only to puncture, but you have then to introduce through this calcified wall also a fairly thick catheter. And it's possible also that the closure device will fail. Luckily, most calcifications are on the rear wall, but you can also have circular calcifications, and that is limiting the PVAR technique. So we have our evaluation included 314 patients with EVAR versus PVAR. We excluded patients who already had an aortic procedure beforehand. The risk factors are listed here. Typical factors, yes, you know that these people are smokers and are hypertensive and have also an impaired lipid metabolism. Significant difference was, yes, we had much more hypertensive patients in the group of PVAR. And you see here the complications, vascular complications, yes, PVAR more than EVAR. Wound infection the same. Closure failure, we had one case where we had then to occlude it with surgical means. Intervention time was shorter, as you see, on the mean than with open. You can expect that because you have to prepare the artery and then you have to do a suture at the end. The difference is statistically significant in favor of PIVAR, but also radiation exposure was less with PIVAR. Also that is statistically significant. Hospital stay also was influenced, so you had much less time the patient in the hospital, so that's also saving some money. That's also statistically significant difference. So I conclude, PIVAR depends on the experience of the interventionalist, but that's true for all interventions. PIVAR is superior concerning intervention time, radiation exposure, and hospital stay, at least in our group. And it is essential, yes, that you check by ultrasound and CT the condition of the excess vessel. Thank you very much.
Thank you very much. Any comments from the audience? Any questions? While we're waiting for someone, how come that you have two infections in the percutaneous? Do you have any explanation
Yes,
for that?
it's not easy to explain it, yes, but it happened. I have no real convincing answer for that. Yes, I must invent something then.
Yeah.
No. So that it happened. The complications, yes, I showed it's not a high percentage, it's a low percentage, but it happens, yes, and that can be either you have not properly occluded it and you have the impression, oh, everything is very well, but later on when you do the patient feels some pain or you do some ultrasound examination, then you see, oh, there is a little bit of bulging there and perhaps a small pseudoaneurysm and so on. So that can happen there.
Professor Bousquet, do you perform fevers on the percutaneous or?
Percutaneous, but I'm going to tell you more during my presentation.
Because yes, the next presentation
This was
with
my
a very
interest.
similar subject. Yes?
We are very good friends anyway.
Yes, Jack is wonderful. I like to drink a glass of red wine with him.
Yeah, this was actually my introduction to the next speaker, Professor Bousquet, with the topic fever versus fever.
Thank you, Mr. Moderator. It's again a pleasure to be with you today to speak of something. So, fever are part of the new technology to treat the juxtavisceral and thoracoabdominal aneurysm. It's a real step forward in the endovascular aortic technique, but it's a very precise procedure which needs experience and collaboration. I would like to thank again and again Dr. Petrov. He's a courageous man. We know him internationally, and he is bringing to Sofia the best technologies that you can have in your country, because he knows a very large number of people and learn from them. And we learn from him. Congratulations and thanks, Ivo, for your kind invitation. Just a remember of my society that I was pioneer of with Dr. Buckley on the left side of the screen, Dr. Dietrich on the right side. They both died too early for me, and your servitor in the middle with the same glasses. So the chimney endovascular aortic repair, acronym SHIVA, is something that you can see on the diagram. Two stent grafts introduced by the axillary approach or brachial approach coming down and joining a graft coming from down, from femoral, to treat juxta-renal and two short necks in the new technology of EVAR. It's a sort of breakthrough. If you can look carefully on your left part of the screen, you can see gutters. In French, gouttière. It's usually used for the rain on the roof, but here it could be a problem. Let us go on. So, antiguade approach from the top to treat the renal. So you need to be two practitioners, one at the head, one at the foot, and with a good collaboration between both of them. And you join you at the renal level. It's a combined procedure. It takes more time than usual. You need a very good radiologic system. You can do that on a simple, very simple artisanal C-arm. You need to be in a hybrid room if possible, if you need to cut down, for instance, in the humeral or in the brachial artery. This is what I just said on this diagram. It's still a complex procedure. You have more complex, but this one is complex. Don't start, if you are a beginner, you start with a proctor and don't start alone in such a procedure. The problem of gutters, it's a way to have an endoleak, type 1, so it's a problem. And this gutter here, gutter on the right side, are open space that can lead to an endoleak. So what's the treatment for that? Nothing really. It's only optimal graft sizing strategy. You have to look exceptionally well to your selection of graft. If not, you try to be helped by your cell rep. Dr. Armando Lobato from Sao Paulo, some people are friends with him. I think, Klaus, you know him well. I know him well. They have very bad time with the epidemic in the country, so his meeting has been cancelled during 2 years in a row. But he was inventor of this kind of sandwich technique. This is the second name. It's not only a cheminée, could be like a sandwich. Sandwich are good for the break. They are good also for some patients, especially if you treat and want to save an iliac internal artery. And this person, this surgeon, I don't know who exactly, maybe you know him close, he went to the extreme expression of the cheminée technique. Look, a very long thoraco-abdominal aneurysm, and he put 3 stents, 3 grafts in the system, aortic system, with 2 cheminée in the renal. I think it's an extreme expression, so don't do that immediately if you start your program. Let us see the evolution of stent grafting. This is the branch aortic graft. This is a complex procedure too, open only to selection of center and excellence, center of excellence with experienced surgeon. First fenestrated graft attempt was made by Roy Greenberg and unfortunately died also early of cancer, pancreas cancer, in Cleveland, US, with the Cook Group. This is the emergence of the technique going potentially high during the last few years, exponentially high. So you need a dedicated planning software. It's a complex procedure to put in place, very complex procedure to put in place. If you miss your sizing, you miss the operation and you miss your patient. So the standard fenestrated graft have a variety of length made of composite graft, big or small fenestration, sometimes a scallop, including one or two arteries. The early London experience was very useful for all of us, especially brought by Dr. Thompson, Matt Thompson, who is now involved in the commercial system of some graft, but he was a very good private and public surgeon in London, St. George's. And the mortality was immediately not too high. 30-day mortality between 2, 3, and 10, depending on the way the study was conducted. And compared to the open aortic repair, there is an advantage for sure, as you can see on this slide. The problem of this technique, in my opinion, this is the renal failure. The renal failure could come from increase of amount in the contrast media, could lead to dialysis, or breakage, or misfitting of a renal endograft in the fenestration. So renal is a weak point of this technique. So the initial commentaries were a safe alternative, not an alternative, but more follow-up needed. Classification by the best team, and always to be organized in a team. So many other publications have been made here. Dr. Hollon, formerly in Lille, north of France, now is practicing in Paris, Hôpital Marie-Lannelongue, near the center, near my hospital, Val d'Or, by the way. And they did at the beginning a study of the French centers, public. So you see, says 16 French academic centers, more than 100 patients. The target vessel, superior mesenteric artery, renal artery, for a total of 400. And some problem. A distal implantation of constant and occluding the renal branches, bad implantation, failed catheterization of tight renal arterial stenosis, which is a problem, and failed catheterization of celiac trunk. So, even if there is a good patency, some problem can happen. You need to be very technical. And it's a long procedure, sometimes 1, 2, 3, 4, 5, 6 hours. With a lead apron, it's long and you have to be strong. Early result, you see some dialysis patient and some failure. So it's not panacea. Follow-up, some mortality, 12, but other causes. And you see an honest, anyway, follow-up. So survival rate is acceptable. and also you can see anatomical change in the size of the aneurysm called shrinkage. So it's still a productive technology, efficient and safe, I should say. The conclusion of this initial study was you do only high-risk patient. You need a real learning curve, should be reproducible. There is no homogeneity of the literature, so could be improved. And should we do that for short neck? We will discuss later of that. So some example, some images to let you know the difficulty and the technicity of the technique. This is a type 4. Look to the business. There is a lot of things to do. You can't do that by yourself. You need to be helped with one other doctor at the top of the table and 1 or 2 assistants and 1 or 2 nurses. And you have to put 100, 150 or 200 cc of contrast media. You have to be followed by your anesthesiologist, and rehydration for the patient, absolutely necessary. So this is the result of the branch. So in the CUT study, if you order a graft made for your patient, tailored for your patient, sometimes you have to wait 1 or 2 months to be delivered. So be careful when it's an emergency case, you will be able to work with the surgeon directly with that endovascular procedure. This is the result, nice result on the system, but long procedure. This is the experience and the table, as we see. Hollande did a good work and is a very good surgeon in Paris, practicing well in that sort of patient. But remember one fundamental thing, the spinal cord ischemia. So they do a drainage with new system to be under good pressure. You have to keep a good pressure, blood pressure, to avoid paraparesis, palsy, or sometimes more, and sometimes sequela. This is the problem of the procedure, so you have to choose a very good selection case. Hollande still working on it. The mortality of, you see, sometimes higher than expected, especially few years after the beginning. So it's an innovative technique in progression, still in progression. There is competition with the surgery. Joseph Coselli, maybe some people have heard of his name, is a successor of Dr. DeBacchi or Joe Coselli in Houston Methodist. They are very used to the surgical technique. We need some follow-up in order to broaden the indication. Highly specialized center, as I told you in the beginning, with a collaborative team, and you have to look to the price. And if your medical system, national medical system, can reimburse this graft, which in France are about 20,000 euro or 30,000 euro. Is this the same in Germany, Klaus? Yes. Okay. I thank you for your attention.
So congratulations for this lecture. Comments, questions from the audience?
Yes, we are very happy that we have this technique naturally. Yes, but the intervention time, it's with a simple EVAR. I have done my fastest in 45 minutes. from the beginning of
Eva.
When
And
you
how
look
long
at,
do you do
at
for
fever,
this?
then you have easily 2.5 to 4 hours.
It's what I told. I agree with you.
And you have up to 1 hour of fluoroscopy. So that is also a high radiation dose, not only for the patient, but also because there's scattered radiation, so also all the interventionalists. So I would not like to do every day a fever, yes, and even with good protection, there's still something going through.
In the floor, who is doing this technique? Tell me. Nobody yet.
Yes.
So what is your impression regarding the renal zone and the weakness of the branching, weakness of maybe misposition? I think this is a problem. And the time long, the time, this movement, can they be acceptable in the time? Close.
Yes, we accept it because the alternative is an open surgery with also some complications because that are not healthy people, they have a lot of comorbidity. Yes, and so you have to make a decision, yes, individually, I think, yes.
Do you select your sizing by yourself or with the help of the company?
We give the CT data on a disk to the company and then we get it.
Because if you consider a company, and by the way, thank you for the company to organize this sort of meeting in support of EVO. The company have the experience of 1,000 cases because they serve all the country, and we have the experience of 20 cases during 1 or 2 years. So you have to feel confident with your company, but choose the best. And I think this kind of technique are only devoted to one. It's only Cook, I think. Do they have no other?
Yes, there are also others, yes, but Cook is perhaps leading, I think, at the moment
leader.
at least. Yes.
But I don't want to make any marketing for them. And do you admit that it's a long period of waiting before getting the graft?
Normally we wait 1 to 2 weeks.
What you say to your patient? You have to wait or?
Yes, we inform him. Naturally, we discuss that with the patient, the options of treatment, and then we say, yes, we can do it with access via arteries, but without opening your abdomen.
Tell me, if there is an emergency, what you do?
But when it's an emergency case, yes, you can only do open surgery is one option, or the other chimney technique. You can try that. Yes, you bring in a catheter with a large balloon and you block the flow.
Sorry for interruption, but we are
we are in the
front of time. And
I have a last question. It's very important. What is your impression on Shibnik technique? 30 seconds, please. Shibnik technique.
Yes,
what do you
I
think?
would prefer the fenestrated technique, yes, but when it's not possible, chimney is
inevitable.
Yes, it's an option.
Thank you. I'm sorry.
So let's switch now to the live case of City Clinic, and Professor Petrov and Dr. Stankov are already on board. Ivo, did you hear us? Okay, can you present the case and tell us at what stage you are?
Yes, please. Okay.
Dr. Janevska is there.
Dr. Janevska is with you in the hall, in the Congress hall. So she will present the case. Please, Dr. Janevska, tell us what we are going to treat today.
Okay. The patient is male,
at 63 years old with clinical presentation with pelvic and femoral claudication, both sides at 50 meters. Comorbidities, coronary artery diseases after myocardial infarction and primary percutant coronary interventions with Draken-Lutin stent of LAD and in the second step recanalization of right coronary artery, diabetes type 2, arterial hypertension and dyslipidemia. Risk factors of atherosclerosis is male, age, smoker and genetic predisposition. Arterial ultrasound and ankle brachial index. Abdominal aorta is with distal thrombosis and significant stenosis of superior mesenteric artery and thrombosis iliac artery on both sides and collateral flow distal from common femoral artery. Ankle brachial index in right side is 0.45, in the left one is 0.4. This is a collateral flow with color Doppler of common femoral artery, left and right. Here is a significant stenosis of superior mesenteric artery, and here is distal thrombosis from the CT angiography. The therapeutic options is vascular surgery with aortobifemoral bypass, total endovascular revascularization with stent implantation, and maximal medication treatment plus walking exercise. And our choice is total endovascular treatment with right brachial approach and both femoral approach. Now let's start the live case.
Okay,
Thank you.
Also we have presentation about the case. So can you show us what we have done till now and
Yes, we are going
at
to,
what stage you are?
Yeah, you probably saw the CT. It's
Yes.
the so-called Heilerisch. Just distally to the renal arteries and quite a long occlusion. So we can show you step by step what we have done to this moment. So to be deductive, let's say, we have in fact took a picture of both mammary arteries in order to show you the possibilities of having collateral circulation to the distal iliac and common femoral arteries. Like shown here, we have used, performed, in fact, like Dr. Janevska mentioned, both femoral and brachial artery approach, so totally endovascular approach. So we are going to, I will show you, so this was the angio of the right mammary, and this is the late phase of the right internal mammary that we have used the roadmap of the late phase in order to puncture the right femoral, common femoral, because there was no pulsation at all. There was a small surprise, so this is the puncture under the late phase roadmap. Okay. So when we entered the left subclavian artery, the surprise was that was a critical stenosis just at the ostium of the subclavian artery. But nevertheless, it's very interesting. You are going to see the lima. The lima is filled by the vertebral artery. So there is a
full
now you are going to see that there is a competitive flow into the left internal vertebra that is filling the subclavian and the mammarian. So this is the left mammary artery, and when we are going down, we are going to see the filling through the epigastric arteries going to the left common femoral artery that was used again as a roadmap in order to puncture the left femoral. This is our usual approach, to use at least one brachial and one femoral approach. In this case, we decided to have one brachial and two femoral approaches in order to have the possibility to put, let's say, big stents in both iliac arteries in case we are successful to recanalize the occlusion, the Leriche. What is your comment? Something different from what you are doing?
No, you start well. I just want to know the distance between the lower renal artery and the beginning of the thrombosis. How many centimeters you have of normal neck?
We can measure very, very exact. We can do a very exact measurement. You know, the biggest problem, you probably know from the trials, that after endovascular recanalization of Leriche syndrome, the advice is to put stent grafts and to make reconstruction with two kissing grafts within the aortic stent graft. So at least at the aortic level, we plan in case we successfully recanalize the occlusion, to put a stent graft just below the renal arteries. We have done this maneuver several times with a free flow endograft, endurant aortic endograft, just below the renal arteries, but definitely after good predilation, good preparation of the aorta. So this is the plan.
Did you reopen the right side yet or not?
Okay, I will show you the step-by-step approach. In fact, from the right side, the wire from below went aside, so into false lumen dissection. And from above, with a microcatheter from the brachial artery and the brachial guiding sheath, we went, I will show you now. So this is the occlusion, you see, immediately after the renals. And you see, probably, you see the 90 centimeters long
It is actually less
shuttle
than 1
sheath.
centimeter below the left renal artery.
Yeah, in fact, less than one, probably 5 millimeters.
Half centimeter.
Yeah, okay, yes. So, and we succeeded to cross, I mentioned that from below, there was a trend to go in fact, false lumen. Like in this situation, you see the looped wire aside, so it's into the false lumen. But fortunately, from above, you see now the 018 wire. Dr. Stankov succeeded to cross the lesion all the way down to the femoral and the SFA. And in order to have true and true, so to have double access from the brachial and the femoral with one wire, the true and true maneuver, in fact, we have used a snare. We have used a snare. With the snare, we have externalized the wire. And after making snaring the wire and the sheath, you see the markers of the sheath. So we externalized the wire and the Trailblazer microcatheter. And through the lumen of the Trailblazer, we went up. And on such a way, we have, in fact, a good 0.35 access from the femoral very distally into the proximal thoracic aorta. This is on the left side. Externalization.
Thank you, Dr. Stankov.
Yeah, Dr. Stankov is the master.
Oh, yeah,
and okay, this is the removal of the wire from the sheath, and again the sheath back. This is the balloon predilation on the left side. Okay.
A very long balloon.
Very long balloon, absolutely
30
by
centimeters or maybe more.
Yeah, it's 200 millimeter, 6 by 200, and it's over 0.14, very long shaft, 180, in order to have enough distance, enough length to go from the brachial to the ear. Okay, we had similar experience on the right side. From below, we went into the dissection. And, okay, this is the distal cup. You see the same loop going probably in the same Faust lumen. And this was telling us, because the wires were going into the same Faust lumen, more than logic, probably they could be reached on a certain place. And even more, by the microcatheter over the wire, we saw there is a flow. So obviously, in case there is a flow, more than obvious, there is communication in some place. And we succeeded to cross from above with 0.18 this communication. And again, we snared the 0.18 wire. And now we have a very good approach from above. And also approach from below. And this is the predilation in a moment we are going to see, the predilation. So probably you can see live the balloon inflation on the right side.
That is the same balloon, or what is the size?
No, it's another one. It's another one. We are planning now to make a kissing balloon inflation. And okay, and after that, we are prepared to make IVUS with the high definition assist IVUS catheter.
Ivo, I have a question. You are doing
Both sides. So now we are proceeding with the contralateral.
Hi, Ivo. You are doing great so far. I have a question. You are very, very close to the renal arteries. Do you think about protecting them somehow? Because there is, I think there would be a lot of thrombotic material there. So you easily cross the lesions with the wire to the both femoral arteries from above. And I think there is some kind of thrombotic material. And do you have any cautious approach during the ballooning? Is there any measure you are taking?
No, not now. Not now, in fact. We saw the picture of the CT. There was no dramatic thrombus containment. But we are ready to do that because we are going to have bilateral femoral access, and probably we can, from above, we can put some guiding catheter or
vent technique maybe.
Or make the so-called vent technique during the implantation of the endurant. We have some experience with the vent technique that is used with the Nelix device.
Which device?
Nelix. Nelix device, it's kissing endografts for AAA. So it's they don't agree to use the term vent technique, but it's similar. It's like chimney, but not with stent graft, but with bare stents.
Okay. So comments from the panelists?
I have no.
I'm listening to your proposals.
Something different in the strategy?
No, we follow him. He's doing the right thing. I feel confident with Ivo.
Okay, so we can proceed
so
now
you
with
have
the...
a complete approval from the whole panel.
You can go on.
Should we go for the next presentation from...
You can go, yeah.
Yeah.
And we are going to
yes,
update
and
you.
We will switch back after the next presentation.
Great.
So,
It's
Dr. Končar?
it's my presentation, not a satellite symposium. Okay.
or we will proceed with the...
We have connection with Amsterdam, okay.
Okay.
With Kake.
So the next is the Satellite Symposium of Philips, and it will be about EVAR treatment of in hybrid operating room.
She's not here.
Kake, do we hear you? It's Igor Končar and the panelists in the back meeting.
Yes, I hear you. Thank you for the invitation. I'm here.
Welcome to our meeting, although online.
Hey, Kaki, how are you? This is Jacques.
Hi,
You look
I'm
good.
How are you?
We miss you.
Thank you. I miss you too all.
For which
I'm glad that I
reason
could do hybrids here.
For which reason did you didn't come?
Well, I think travel restrictions and last minute a little bit, some regulations. So.
Thank you.
So thank you for your invitation. I'm happy to be here, and today I'm invited to speak about EVAR treatment in hybrid operation room. And check, these are my disclosures. So this is an Amsterdam team, a lot of vascular surgeons and intervention radiologists in our hybrid room. We have 2 on each location, and super proud of it that we can work with it. So a hybrid room, how does it look like? We're using Philips Azurion 2.1. You can see it's actually a very optimal operation room, optimal use of the operation space specifically. So you can see our team here. You have a lot of space and you have big screens to look at and to perform complex endovascular repair. So today I will talk about how we perform complex endovascular aortic surgery in our hospital, from procedure planning, procedure and final check, all using the Philips Azurion platform. And these are some things that you can use: advanced vessel analysis. We'll talk a bit later about it, instead of that you can use with the same, like Trimencio or a Terra Recon. So the Azurion platform has a lot of new options right now, like AVA and Flex Vision. There's an advanced vessel analysis, which I showed you, like Trimencio and Terra Recon. You have a vessel navigator, smart CT, and marker tools. That means that you can actually mark your landing zone positions, but also quick measurement how large the vessel diameter is. And if you want to recall it, the position, you can also recall your previous angiography position. We have ultrasound integration, and we wear all those aware badges, so you know how much radiation you catch. But today I will focus on the vessel navigator and also the AVA on screen and a smart CT. First, I want to present to you a few cases that we did with this Azurion platform. And one of my thing that's very important is to have a good visualization. Like if you want to have a precise landing to spare lumbar or spinal arteries. And one patient, a female patient, was 80 years with a medical history of COPD Cold 2 and a previous hernia operation and thoracic aortic aneurysm of 60 millimeters. I've drawn it here a bit. Had a lot of spinal arteries actually. So I wanted to, when I placed the endograph, I want to spare the spinal arteries at the top side, because I was already covering 3 pairs of them already. So I have been playing a bit with the landing zone. So the landing zone was actually quite, the ceiling zone was quite narrow, only 11 millimeters. So I decided actually to spare the proximal lumbar arteries, place 2 conformable C-tags above the celiac trunk, which was also a little bit conic. And I was thinking, okay, 11 millimeters proximal seal is a bit minimum, but I will place some endo anchors, and just only I wanted to spare them because I don't know if I wanted. They was the only one that were left actually, and really large to spare the patient from a spinal ischemia. So first we planned the procedure with advanced vessel analysis, and it's a very intuitive workflow. So there this is my technical physician. Actually, we do every planning together. And there's an automatic segmentation, and here is the spinal arteries that I wanted to spare. And you can automatically segment them. And there is a central luminal line that you recognize from earlier other programs that have that too. And there's an automatic diameter that you can, that they will give you. Like we know that's about 34 millimeters. So I can think about 30% of oversizing and place the right size of endografts in it. The nice thing is that it's integrated with Azurion platform. So when you have performed these measurements, you can easily recall it back into the surgery room. So this is the procedure first. Again, this is the vessel navigator. We fuse these images with the previous CT scan, and there's an automatic segmentation and planning and check again before starting the procedure. And here again is my technical physician. So in 3D rendering, we can see again these spinal arteries automatically segmented, and I store the angles for the view. Then here you see easy movement of the C-arm. And now I'm fusing the images for the vessel navigator on a 2D registration on the pelvic bone. There are some suggested angles that you can use, and you just then it actually almost all of them goes automatically, except for this, you have to fuse it by hand. Then there's an auto fade option to see if you have a good vessel navigator alignment. Here's the ultrasound integration, the puncture of the femoral artery. And then here at the right side, you can see the vessel navigator with the CT image. And at the left side, you can see the live guidance. Here's again the dose aware, the blood pressure, the vital parameters of the patient, and at the left corner, the AVA, so where I did my measurements before. So here I'm introducing the endograft. I know it was some elongation and also a little bit narrow. So I performed first a PTA, you can see it here, tried it again, but it was just too hard. So I converted to an open access by direct puncture of the iliac artery. It was very quick, just 10 minutes. And then I just punctured the iliac artery and introduced the sheet again and the endograft. So here the dry seal goes up. And again at the left side, the live guidance, and at the right side, vessel navigator. So the landing zones are marked with green and with blue rings. And you can see it's a little bit off the alignment, so I had to adjust it after the angiography. And then I use on the iPad the marker for the landing zone above the celiac trunk, 1 centimeter above, so a second line. And I know this is my landing zone, so I deploy now the CTAC. And I have to, of course, place another second one. So we check again on the AVA, the previous measurement. It was still the same. And so we decided, of course, to do a second angio to see if we can see these lumbar arteries that we wanted to spare. By the first introduction of the CTAC device without deployment. So now the angiography is coming in. And after the angiography, I place another marker for my landing. It actually was the same one as my vessel navigator, the predicted one. So that is a very good prediction. And then I deploy my second endograft. So the CTAC has a 50% deployment and then a full 100%. Then ballooning of the sealing zones. And after that, the final DSA, no endo leak, all was good, but I would just remind you the 11 millimeter sealing zone is very narrow. So I zoomed in, a digital zoom without increasing the X-ray dose, and I placed the anchors. And after that, the patient was done. So the second case is another difficult case where a female patient of 70 years had in 2017 a BVAR procedure, full branch, because of a thoracoabdominal aortic aneurysm of 69 millimeters. And now she has a type 3 endoleak, a disconnection of the SMA stent graft. So you here see the large endoleak on the CT scan. Again, the planning with my technical physician, I can show you here, this is the new photorealistic volume rendering. So you have a lot of different colors that presents the different tissue. And here you see the disconnection of the graft with the SMA graft, the graft in the SMA. So that the plan is to reline it with a Viabam BX from Femoro access and maybe with a steerable sheet. So again, this is the branch and this is the stent graft that had to be in the branch, but it was disconnected, causing a type 3 endoleak. And the nice thing with the AVA is that it finds a central luminal line even when it's disconnected, the graft. So you choose, okay, I want to have the SMA, and then you press yes, and there is an automatic central luminal line drawn by the computer, drawn here on the CT scan and on stretched view as well, but also on the 3D view. And the suggested length for overlapping is minimal 46 to 65 millimeters. So that's why we chose definitely a 59 VBX, 8 millimeters. So again, you can recall the EVE planning to the hybrid room. And here is the procedure. So again, we fuse the images with a 2D registration. I find that really nice, but you can also use a 3D registration, of course, on the pelvic bone. And then after that, you see that the auto fade option, it's a really good alignment. And then we can start the procedure. So the live guidance is now ready. Here, ultrasound, again on my full screen for guidance to puncture and recalling the AVA on the table side, the planning. So this is an intervention radiologist working together with me. And we changed the segmentation side. That's also nice because it could be a lot of things that you see to an outer line line only. So then you can easily see the X-ray projected on the vessel navigator. So here's a steerable sheet into the branch. And now we just advance the Terumo wire to the SMA from the branch. This was actually quite easy. And after that, I exchanged this Terumo guide wire to a stiffer wire, a short tip unplots wire. And of course, after that, we recall again the AVA measurements, check again, okay, 59 millimeters, that's what we're gonna choose. And after placement of the Viabam BX, we ballooned it, deployment of the endograft, the VBX. You can see it here. And we performed the final DSA to check if we had no complications and a good realignment. And that was the case. So note again the dose aware at the left side, the middle, the AVA, and then the vital parameters. We performed the CBCT dual acquisition to check the procedure outcome. So that's a CT scan on the table. This was with 15 seconds delay, but I recommend actually 7 seconds delay for the venous phase. So there's an arterial and a venous phase that you can perform. It's a bit different than on a real CT scan. And you can view that on the table side, and we didn't see any endoleaks anymore. Very happy and content with our procedure. This is my other colleague. So very content with that. And this is the venous phase, also no type 2 endoleak was seen. So after that, the final check, like I said, could be on the table side, but there are a lot of advantages with the AVA measurements. There is a fully automatic segmentation even with disconnections of endografts, you can plan it everywhere, and it's integrated then in your operation room with the Azurian platform. What is also nice is the smart CT afterwards. So here's a smart CT that we performed after the procedure. And you can check for the alignment of these grafts. So there's no kinking. And this is directly after your procedure available. So if there's anything wrong, you can do the procedure again while the patient is on your operation table. So I try to do that after every complex EVAR repair with branches or with fever to check if there's a good realignment and no kinking of the endografts. So you have an arterial phase and a venous phase to check for endoleaks. And we were actually quite happy with the procedure that we did not see any endoleaks anymore. But what is also nice is you can replace the contrast into red, so you can see it even better, like blood, and on another view as well. So you have the coronary view too. Yeah. Then this is just another example where you can use the smart CT for as well, is to have it as your vessel navigator. So it's not a vessel navigator, but you use the smart CT as your navigator. And you can use it also to measure directly on your operation room what kind of lengths, what kind of diameters do you need from your CT scan that you made on your operation room. So here again, you have stretch vessels, diameter automatically available while you're doing the procedure. And this CT scan was also made during the procedure itself. So how can we use this platform? I think for specific branch cases, sometimes I perform these branch cases in two different approaches. Like first approach to finish the case in a different stadium because I want to temporize the case and to prevent spinal ischemia. So sometimes when I do that, I see that one branch is occluded actually. So our policy is to perform a CTA before realignment again from the branches. But now I can do the CTA also on the operation room itself, and no earlier CTA is necessary. You can also use a smart CT to identify endoleaks, which you cannot see with a 2D angiography, or use, like I said, a CT as a roadmap to treat the endoleaks or realign the branch. And for control of the procedure of complex vascular procedures, like I showed before in this case, and then you can limit the CTA follow-up of the patient. So a short summary, the AVA platform is very intuitive. You can integrate it from planning all the way up to surgery, but even for the follow-up of the patient. The planning is totally integrated in the Azurian platform. You have a very good visualization with CBCT dual from the smart CT as well. And what I like is to use the dose aware so I can know, okay, how much radiation am I catching during the procedure? So it helps not only us a bit as doctors and vascular surgeons at the table side, but also people in the room can also use the dose aware. It helps in the clinical decision making. And I think if you see it better, you can reduce complications as well. And easily extract also like videos for this educations too. So it's also not necessary to perform a previous CTA if you have small procedures that you want to plan directly on the hybrid room. So better visualization, accurate planning, navigation, confirmation, all these things will help in better clinical decision making, and reducement in contrast and radiation can enhance staff and patient safety. It's very easy to use. We can focus on the procedure and the patient. And all this will help in the reduction of complications, I believe. So thank you for hearing me out today. So are there any questions? I'm open for discussion.
I have a question, Kaki.
Yes.
This is Jacques Busquet. Congratulations for very good talk. I enjoy your talk.
Thank
we
you.
all know that Philips is a company from Netherlands.
Yeah.
So did you have a treatment of favor to have this nice imaging? Or is it possible for a simple customer like me to have the same technology at home?
Yes, you can have the same technology for you as well, because Azurion platform is now available throughout the whole world, I think. And it even is advanced now with the flex arm. So I think we have our C arm now on the ceiling, but when you have a smaller operation room, you can also have to use the flex arm, and it's even better. Then you can rotate around the head of the patient as well with your C arm. So I think it's a really nice working environment.
Do you have a range of price, global price for a common customer?
Well, I'm not selling these things, so I don't know the prices yet, but I'm sure you can contact your local Philips representative for it.
Yeah, I would like to ask Kaki something. It looks really promising, and it looks like all of you in the room know what are you doing. Is it complex, this education of the whole personnel in the team, not only one person, but how much time do you need to educate everyone to be familiar with this technology?
Well, it's actually quite intuitive. So, so I have a technical assistant actually technical physician. Actually, he's very into all these tools. So he trained also a lot of other doctors, and he helps us on the operation room. But I think after 2 or 3 procedures, you're actually quite familiar with it. And I see my nurses and the intervention radiology is also very easy to use everything. So I don't think it's a very hard, steep learning curve. It's very easy. Yeah.
Yeah, thank you.
Yes, well, I'm doing angios now for more than 50 years. So when I started, that was film-based with an AOT film changer. So when I look at these 5 decades, what came out, then I ask you now, can you predict when we are not necessary anymore and a robot is doing all that, because artificial intelligence is growing very fast. So I can imagine when you have all this information delivered by the angio suite, and you have a good robotic man there, then we are not necessary anymore.
You want to eliminate the doctors?
We are always necessary, I think. So don't underestimate, but it's only to help, to reduce complications, and it's only to help us, because I indeed
yes,
also
I
have
understood that. So it's a little bit of a joke in my question, but but when I see how fast all these things develop, yes, and when I see we have the Magellan system, which is a robotic system, we have here now more and more fusion of all the imaging techniques we use. So the next question naturally is, yes, when it is done completely by a robot.
I think not fast, because I do a lot of research also in artificial intelligence, and what I see is that you cannot not yet trust the system 100%. There's always an input of the doctor, so the system have to learn from us, of course. But then again, you really need to check of the doctors. So, but maybe in 100 years, maybe it's different.
No, I think it's faster.
Not 100 years. Not in the next 5 years.
Okay, any questions from the audience?
I would like to add something. You have a brilliant team. You are a brilliant doctor. We learn a lot from you, and I like your talk, and hope to see you in real soon.
Because we all like also a charming lady, naturally.
I cannot hear the question. What was the question?
No
question.
Comment.
Okay.
It was more a comment, but we leave you, Kaki, to enjoy your Sunday afternoon in Amsterdam. And we are going further with our program, I propose.
Thank you very much.
Yes, okay.
Thank you.
So,
Thank you, Kake, very much.
Have a good day there. Bye.
So can you switch for 2 minutes to the cath lab? Yes, just to see
the results.
where they
Before the
are.
break.
Yes, probably. And then we have 10 minutes coffee break.
Покритата част 70.
Free
Ivo?
Yes, yes, yes. Listening to you.
Okay, can you show us what you have done? And because we stopped after kissing balloon dilatation of the aorta and
Yes.
common iliac. So
Okay.
where you are?
We've done. Probably you can see now the last subtracted image. In fact, you see that still we made also ISEVS, and residual stenosis after kissing balloon was very, very tight. In fact, it's very well seen also on the angio. We made also kissing balloon with two 10-millimeter balloons, and we have used the 40-millimeter length of the two balloons to measure the distance between the renals and the bifurcation, like Jack asked me. So you can observe that, okay, the bifurcation is more or less at the distal marker. So we have 80-millimeter distance between the renal and the bifurcation. And we are planning now, we are prepared because we have placed on the left side the 12 French sheet and the Wunderquist wire. So we are ready, we are prepared now.
12 French sheets from left or from the right?
From the left.
From the
we
left,
put the 12 French sheets from the left, and we are ready to make a sheetless implantation of the endurant. That is the covered part of the endurant is 70 millimeters. So we can expect the distal part of the endurant to finish more or less 1 centimeter above the anatomical bifurcation. And after putting the endurant stent graft, we are going to perform a better balloon dilation, but already under the protection of the stent graft, so without the risk of debris embolization distally.
Yes,
you see,
important.
The endurant is coming, and we are more or less on site. We are going to check now.
What is the diameter of endurant?
The diameter of the endurant is 25. That is not bad.
It's a big diameter.
If it's possible to say something, Dr. Nicole, I think you have problem with the right renal artery now.
Yes, we need more information how the orifice of the renals is, because we have the impression it's a little bit underperfused, yes. Also on the right side, I see it's delayed, the contrast. Medium flow.
Yeah,
So
on the right side there is...
It's possible that at the end you need also to stent the orifices of the renal.
Most probably, yes, absolutely right. In fact, we are planning to do that, but in fact the right renal artery is quite above. So the left renal artery is the lower one. It's almost 1 centimeter below the right. So I can remove a little the sheet, the arm sheet, in order to show you the situation with the renals. Okay, yeah. Okay, so...
The left looks like pinched in the...
It was visible on the previous image.
Absolutely. Probably the best way would be to put a guiding catheter into the arm sheet and to prepare to stent the left
Yes.
The left renal. Yeah, to make the vent. Okay,
Yes.
let's go. The endurance is on good side, and we are going to proceed now with 5 French Jenkins right guiding sheath in order to selectively go into the pinched left renal artery. And I will ask my colleagues to go back one projection. David, назад.
Ivo, because we are, should we have to observe the case or?
Yeah, maybe we can wait that you canalize renal. I can have a talk in this time.
Yes, okay, I agree, totally agree.
Because we have 10 minutes.
10 minutes of coffee
10
break.
minutes coffee break and then
Okay.
we will continue.
Coffee break.
So,
Okay,
Ivo, we will
great.
leave you for 10 minutes, then you will show us the result and then we will continue with the program.
See you later.
Okay, 10 minutes. So, we are now in continuation with our afternoon and the last session for today and for the Congress. And now we are in connection with the cath lab of City Clinic. Ivo, do you hear us?
We hear you very well.
Okay, so we see that you made a kissing stent implantation now. Can you explain?
Yes.
Because we left you after endurant implantation.
Yeah, in fact, it's very crucial to emphasize, go back, to emphasize that in fact we implanted a stent, the critical osteorenal stenosis.
Yes.
And we have used the stent implanted into the renal artery by two reasons. Of course, to make correction of the atherosclerotic critical stenosis of the renal, and also to position the proximal part of the endurant just at the level of the renal artery, and even touching a little the renal artery. So this is the so-called vent technique. And within the endurant, we implanted simultaneously. Next one. Okay.
What was the size of stent in the renal artery?
Great. There are two stents, 12 by 80. In the renal is 5 by 19 dynamic renal. So it's by purpose. By purpose, I mentioned the name of the stent because it's the dedicated one, dynamic renal with a good radial force, and it has the force to invaginate a little the tip of the graft of the endurance. So to keep the renal artery open with small protrusion, about 3-4 millimeter protrusion within the aorta. And this is the simultaneous implantation of the two self-expandable 19-0 stents into the proximal iliac arteries with a very good overlapping, at least 1.5 centimeters within the stent graft, within the endurance. And now we are going to prolong the two 19-0 stents from the proximal to the distal iliac artery, in fact, just after the hypogastric bifurcation. And that's it. And after putting the two 10-millimeter stents, we are going to be ready completion probably angiogram after making the post dilation with two 10-millimeter balloons.
Yes. Okay. So we will come back to you after the next presentation of Dr. Konchar about how to set up an EVAR team. Yes.
Okay, great.
So the floor is yours.
Thank you very much. Thank you for the invitation. It's great to be back to back. And I congratulate Ivo and his team for organizing such a nice meeting in these difficult circumstances. My topic cannot be supported by any scientific literature. It is more like my point of view from experience of my clinic and what I see traveling around the Balkans. Some Balkan scenario considers mostly developing countries, turbulent history, especially at the end of the 20th century, when most of the healthcare system was devastating. After that, there was a slight growth of private practice. Healthcare infrastructure is mostly old-fashioned. We have a problem of immigration of medical staff and slow implementation of new technologies. Why do we have slow implementation of new technologies? Well, some of the countries have independent agencies for medical devices, which make procedure rather slow and expensive. Most of the countries are a small market, not so interesting for companies. Hospitals are low volume. There is sometimes conservative medical staff. There is competition between specialties and low budget. First two cannot be changed. They are here what they are. But let's see the other four. how that low-volume hospitals can become high-volume hospitals. First of all, of course, the improved organization of all hospitals, but also with the specialization of the hospital or department for certain pathology. For example, the hospital that specializes for aortic repair can become high-volume hospital because everyone will send patients to them. Of course, they have to implement screening program and early detection program to increase the number of patients, and of course to have available medical staff that can provide such a service. Conservative medical staff is not a Balkan problem, it's everywhere around the world, and of course it is difficult to find a balance between putting on the table new technology and taking care of the patient safety, long-term results, and the budget, of course. However, there has to be a space for young blood, because I think it's my opinion that intergenerational agreement and discussion can lead to best solutions and best decisions. Competition between specialists is also a worldwide issue. Who would do first, who would do independently, who would do what the others don't do. And of course, this is normal. This is competition for patients, skills, and procedure. If competition is positive, if stimulates, then it's good. But it is not if the competition is preventing others to do something. Low budget is something that is probably most biggest obstacle. We as medical doctors should take care of the patient, and their health and budget should be on our mind, but not on as a first sight. If you want to start an EVAR program, of course, you have to first address to hospital administration and discuss education of your staff, equipment, materials. Of course, discuss the position of EVAR in the DRG of your hospital. Then you have to assess National Health Financing Organization to see with them costs and savings. And usually this discussion starts with the cost of the stent grafts. This is the first obstacle, and sometimes physicians think that they are losing if they just hear what is the cost of the stent graft. But this shouldn't be the case, because in this discussion there are some arguments like cost of the transfusion and availability of transfusion for open repair, number of physicians who can do open repair, who can do endovascular, complications and mortality, especially treatment of high-risk patients who are not treatable by open repair. This procedure means a life to them. And of course, ICU and hospital stay. So don't forget this argument when you discuss with your national financing organization. Of course, it's very nice to have a national program which is cost-effective, where you can plan endovascular center, you can plan selection of patients and indication for endovascular repair, but also it's very good if you have registry data where you can present your results and you can assess them, improve them. And we have our vascular national register 2 years ago in Serbia. My clinic deals with aortic repair since 1965, and in the beginning of the 21st century, there was an increase in open annual number of patients. This was because of the central vascular care, active outpatient clinic, promotion among referrals, and productive team. In that moment, when we came to 300 patients per year by open repair, there was a need to include endovascular repair because we had a lot of high-risk patients and we needed this therapy in our armamentarium. So we addressed our national funding for EVAR and we got some money for that. These are the numbers for the first 7 years when we tried to build our endovascular team. During the time we started with proctors. These are the first proctors that came to our clinic and we are thankful to them to help us to initiate the program. Then we send our physicians and other medical staff for fellowships in other high-volume European centers to be educated and come back with a new knowledge. We acquired very early sizing and planning. I think this is crucial for endovascular aortic repair, that you have sizing and planning in your hands, because this is your eyes and your ears in this procedure. And you can then earn a lot of other skills easier. Finally, we got vascular surgeon, interventional radiologists, surgical radiological examiners, image technician, anesthesiologists, and transfusiologists who were in the team for endovascular aortic repair. And in the following 7 years, we increased our number because we gained a lot more budget from our national fund organization, and we are now performing EVAR twice a week, more or less. Of course, our open repair also was growing, and we are at the level of 80 to 20% between open and EVAR, which is reasonable for a developing country, also having in mind long-term results and cost and anatomical feasibility at the end of the patients for EVAR. Let's see how are the ISEVS guidelines looking on this topic. First of all, one of the recommendations says that centers performing aortic surgery are recommending to enter cases in a validated prospective registry. Then it is recommended that centers or networks of collaborating centers treat patients with AAA only if they can offer both open and endovascular surgery at all times, 24/7, 365 days per year. There is a recommendation that AAA repair should only be considered in centers with a minimum yearly caseload of 30 repairs, and those who have less than 20% should not treat patients with AAA. Finally, there is a recommendation that an established protocol for the management of aortic emergency should be available. Just a few slides about our thoracic experience. We have our program for open AAA repair since 2000, and we treat about 20 patients per year by open repair. Still, the number of patients treated by endovascular is different from the abdominal part. We treat 80% with endo and 20% with open repair. Open repair is indicated in young patients, those with connective tissue disorders, and those with, let's say, bad anatomy for endovascular repair. Since we have experience in open surgery, our hybrid procedures are frequently performed, and we have about 130 different debranching procedures performed in the last 10 years. So, in conclusion, Balkan region has its own specificity in terms of introducing modern technology, and medical doctors and humans, of course, have common qualities and weaknesses. And, colleagues, adaptation is one of the crucial elements of the survival, and if you want to make a team, you need education, volume, budget, and equipment, and years of performing it. Thank you very much.
Thank you, Igor. It was really great presentation. I think very useful.
Thank you.
For countries like ours. So, comments, questions? Maybe, actually, you started how many years ago?
We started in 2007.
That was 14 years ago.
14 years, yes.
Yes. That note for competition was very useful, I think. That it should be positive, not negative.
Yes, yes. We have to collaborate, we have to do together, we have to learn from each other, and I think this is the only solution for our patients because they are the only reason we are there.
Yes.
Yes.
So, thank you.
Thank you very much.
And we will continue, yes, with
yes.
The lecture of...
I have the impression that I'm still working on the patient, so...
do you have a connection with the room? Just to see where they are. Or maybe it's better to continue the lecture and then we will see... With the lecture, yes.
Okay.
Okay.
So here it is, yes. Dear colleagues, abdominal aortic stenosis, a disease of smoking women. You will see. Yes, men suffer more often from aortoiliac disease. We just have a case. And women suffer rather from isolated aortic stenosis or even occlusion, often underdiagnosed. And both genders are normally, with this disease, also smokers. Yes, surgery of aortoiliac lesions, yes, a 5-year patency rate is fairly good, with 90% in that range. Complication rate is about 10%, mortality is 3 to 4%. And you see how it looks like, yes. Here you see one of these complications, that is, yes, a hernia. Incidence is 11%. I think it will increase when we operate on the very obese people. Complication rate, recurrence rate, as you see. And the other post-surgical complication is adhesions, as you see it in this picture. You know that some have also problems then with their bowel. So open versus endovascular, yes, when you have pulseless arteries due to the tight stenosis of the aorta, then it's sometimes helpful to use an ultrasound-guided needle to puncture the femoral artery, but it's not always necessary. Yes, what is when we pass these stenosis of the aorta and do a ballooning simply? That has the disadvantage of elastic recoil, risk of embolization. It's not effective in calcification, and you can even rupture the aorta. When we use uncovered stents, that prevents elastic recoil, but it does not prevent embolization. That can still happen. And you have no solution when you rupture the aorta. Therefore, an endograft is much a better choice, because when you have a severe aortic disease, there often also some lumbar arteries are already gone. And therefore, you prevent embolization, and these are balloon expandable stent grafts. So you see what is the advantage? Yes, you isolate the plaque material with your device. You see how it is. We like to work with the Bentley beak graft, but you have also to be familiar with that, because when you balloon it, it is shortening. So you have to know how to place it to cover the lesion. Yes, renal retention. That is a patient, female patient, 61 years old. He has renal retention, and you see on the slide of the right side, yes, there's a drainage in both renal, from the pelvis down to the bladder. And you see these eccentric calcified stenosis. And then, yes, you need a good measurement to make a good choice also of these infrarenal stenosis, yes, to have a good choice of the beak graft and also the balloon. And you see here now we are in place, and we do the implantation of the beak graft, and the stenosis is removed. Leriche syndrome in that patient, yes, with severely calcified infrarenal aorta. Iliac arteries are slim due to the stenosis. There's also disease of the internal iliacs. Yes, and you see when we place our beak graft, yes, we have now a normal diameter, much better filling of the iliac arteries, and you see also now a better contrasting of the internal iliac arteries. And here again a case, yes, you see a 70-year-old lady with these stenosis between the renal arteries and the bifurcation, and after ballooning, it's gone. Also with a Bentley beak graft. That is a 50-year-old lady, that's again smoker, also implantation of a beak graft, normal diameter. That can be a problem when the stenosis is very close to the bifurcation, because when you balloon it there, you will remove the stenosis, but you can also rupture, because part of it will be in the common iliac artery, and when you pull that out to 20 millimeters or more, then you can rupture the common iliac artery. Therefore, in these cases, I use a different technique. Yes, I place at the right level the graft, but I don't open it completely. I only open it so far that is fixed in the stenosis, and then I deflate the balloon, bring it a little bit up, so the balloon is not going into the common iliac artery anymore, and then I can balloon it completely. You see it here, yes, the balloon is, you see the narrowing there, the stenosis, and then afterwards, in that manner, we could then remove the stenosis completely with a good position also of the Bentley graft. So the results, follow-up of nearly 2 years here on a mean. And you see, yes, we had 76% women and 24% men. So there's a dominant of the female gender. Youngest patient, as you have seen, 47 years, so fairly young for such a disease. Yeah, when we look at that, technical success rate was very high, 100%. We were able to remove all the stenosis, and we had no rupture, mortality, recurrent stenosis. The advantage of these Bentley devices that even when you rupture it, it is sealed by the endograft. Yeah, so I can summarize the results. 3/4 of our patients are female. All patients were smoker. Treatment with a stiff and strong endograft delivers good long-term results. We have no recurrency up to now, up to 4 years. Thank you very much.
So, thank you, Dr. Matthias. Questions, comments? What is the length of the big graft which you use? I mean, because usually it's
yes, when
50...
it's 40 and you balloon it up, it shortens. So.
Yes.
Therefore, you have to place it very exactly. It's not suited for long lesions. Yeah, you have seen these are all short lesions about 1 to 2 centimeters in length. Otherwise, you need 2 Bentleys overlapping. Yes. That's also, or you use something else. Yes, we have also other devices. You see just in the case, which is a live case here, that then you can also use. And yes.
Because my usual strategy in Bentley is to use 0.5 to 1 centimeter above and below, just because I'm always afraid of this foreshortening of the Bentley stent. Yes. And okay.
What's the rate of the patient that stop smoking after this procedure? Do you know?
Yeah, that is a very good question. But as you know, that is difficult even when you can convince them. I always tell them I was also a smoker. And I stopped it successfully. At that, I was 12 years old, and I smoked behind a bush, because otherwise you would have got a clap. Yes. But as you know, these some of the patients really achieve it, but it's a small number. Some only have a time lap where they do not smoke, and then they
start again.
Have recurrent disease because they have no complaints anymore, so I can go on smoking.
Thank you.
Okay, so thank you. And Ivo, да видим докъде са.
А тук можем ли да снимем?
Ivo, you're online. Do you hear me?
Дилатацията на реналата е много важна. Това не е вента, който никой не го знае.
We hear you, yes.
Okay.
Okay. Unfortunately, the movie, the film, is too big, and there was problem during the imaging transferring. So mainly I have to retell you.
Yes.
So without having the possibility to show you, but I will show you now on the live screen. You see the endurance.
Yes.
We have implanted 2 stents 12 millimeter within the endurance, kissing, 2 10 millimeter stent as a prolongation of the 12 millimeter stent, and 2 8 millimeter stents. And now we are going to make a subtraction, and hopefully for final, even we don't know what is the situation because we didn't make a registration of anything, let's say officially. Ne diše ruski. Not very good.
This is injection from where?
This injection from above. From above. So there is probably the probability.
But I think that probably you're somewhere selectively in.
Maybe catheter is in,
Yes, just go higher and inject.
There is an option, the catheter. No, probably we are
It
going
is
to prolong.
edge dissection probably.
Yeah, we are going to prolong the endurance with a non-covered stent.
Probably you have to also check ACT and your anticoagulation.
Yes, this is a very good.
Just check the heparin, ACT, and because now you have to switch to some chimney technique for the saving of the renal arteries. If you implant some disc above.
Yeah, it's. I think it will be fine.
Okay.
24 има.
24 wall stent на 70 имаме.
Давай.
Давай 24 на 70 wall stent.
So you will implant a regular stent?
Yeah, we are going to implant a regular wall stent.
Okay.
24.
Maybe we can continue with the program and we will go back after you implant the stent.
Okay, we'll go for the next presentation.
Can you switch on my slides? So it's relatively easy because Dr. Matthias actually present part of the information which I plan to demonstrate about the Leriche syndrome. It was endovascular treatment. It was described for the first time in 1923 from René Leriche as the continuous total occlusion of the infrarenal aorta and iliac arteries. Depending on the length of occlusion, there are 3 types of occlusion. According to the task 2, we have several types of distribution of stenosis, and classical Leriche syndrome is practically classified as type D stenosis, but there are several Leriche syndrome equivalents which can occur. The standard treatment for the syndrome is vascular surgery with bypass grafting with the switch between the different vascular beds. And the first large meta-analysis comparing results from the endovascular as an alternative of surgical approach demonstrated that endovascular and surgical could be compared. There are 16 studies meta-analyses with about 1,000, this is 940 patients, which demonstrated that the surgical and endovascular treatment are practically equivalent in regarding the technical success, and the primary patency rate at 1 year was practically equivalent. The outcomes of endovascular treatment in the CTOs of intrarenal aorta was compared in these relatively small studies, but you should keep in mind that the largest study up to now of endovascular treatment encompasses 179 patients. So in this study, the primary and secondary patency rates up to 5 years was around 60 to 80%, and the conclusions were that the midterm patency of endovascular treatment of aortic CTOs was favorable, and technical success, however, should be improved, because in this study there was 20% of cases were unsuccessfully treated. When the endovascular and surgical treatments are compared, there is no significant difference in mortality, with low complications rate in endovascular group, and there is also low cost of endovascular treatment when we consider the 1-year follow-up of the patients. And these are the conclusions of this study, and one of the most important point is that probably there is independent association between low complication rates, shorter length of stay, and low inpatient costs with endovascular treatment. Regarding type of treatment, there's still some controversy regarding implantation of self-expandable or balloon expandable stents. Regarding comparison between stent and balloon, there is a definite advantage of stent implantation. So now this is a must, and stenting is the absolute must for the treatment of this patients. When we compare stenting with the balloon expandable and self-expandable stents, balloon expandable stent demonstrated a better patency at 5 years. And regarding durability of balloon expandable covered stent and bare metal stents, it was demonstrated in Kobe study that in type B lesions, aortoiliac lesions, there was no significant difference between treatments, but there was a significant advantage of implantation of covered stent in type C and D aortoiliac occlusive disease. And after COBEST, actually, we know now that actually the graft stents demonstrate better patency. However, it should be kept in mind that this did not translate in the better rates of major amputation. We connected our databases with City Clinic and Alexandrovska, and these are our results of 54 patients, 34 from Alexandrovska and 24 from City Clinic. That were patients up to the end of 2019, and it is in reverse what was already said, that in our population 70% of the patients were actually male, 17% of patients with diabetes. Regarding patency, these are the survival rates. Actually, at 5 years, there was a 24% mortality. Death or major amputation were equal between groups with unilateral or bilateral recanalization, and there were no significant difference. It was interesting that the patient who returned for the secondary procedures has a better survival than the patient who were recanalized in one stage. However, that did not transfer into the significant result, despite that the numbers were lower. And I will show you two cases from our institution. The first one was a 52-year-old male with coronary artery disease, arterial hypertension, dyslipidemia, and severe smoker. He had pain in both legs with a very short distance for his leg, for his age. Actually, his wife came to me and asked me for exam, and this is the result after the diagnostic angio. He has an occlusion of the intrarenal aorta with also up to the levels of just above bifurcation of the iliac arteries. So we have three accesses, one from the above and two from the femoral. And after recanalization and two-stent implantation, that was the final result. The patient has also coronary artery disease on the right, and we did not treat it on the first session. This patient, however, he returned back after 5 months with returning pain, and there was a restenosis on both stents in the iliac arteries. So we made an additional ballooning on this patient, and that was the final result. And at that stage, there was a progress in his stenosis on the right coronary. After that, he stopped smoking, and up to now, he's doing well. That was maybe 3 years ago. The second patient was a 68-year-old male with cardiac dysfunction and severe dyspnea who has claudication, the short distance, and the patient had also chest pain at rest. That was the coronary angiography, and he had occluded circumflex artery, right coronary artery, LAD. The patient actually was offered cardiac surgery, but he refused, and during the diagnostic for secondary access for recanalization of the right coronary artery, that was the finding of occlusion of the infrarenal aorta. He was removed from the table, discussed, and then 1 week later we again put the patient on table, just checked for the collateral circulation. Then a sheet was placed from the above, also 3 axes from the right and the left femoral approach. There was very difficult to define the puncture site, so we used ISEVS for guiding, and after crossing the occlusion of the aorta with a wire, the wire was externalized from the above. Then we made over this wire again ISEVS examination just to be sure about the size of the aorta, balloon predilatation, and then we switch to the left just to recanalize the left iliac. It was quite difficult to find the very ostium of left iliac artery. So by ISEVS guidance again and snaring snare placement from the left, we crossed the snare with a stato wire. It was externalized, and that was the final result for this case. So in conclusion, the cardiovascular treatment of aortoiliac obstructive disease like Levy syndrome is a good treatment option in experienced hands. The stent implantation with the probably covered stent is obligatory. ISEVS could be useful for guiding procedure. and close regular surveillance of this patient is also obligatory. Thank you.
Thank you, very nice presentation. Thank you. Any comments or questions from the audience? Professor Matthias, any comments from your side?
Yes, there were more complicated cases naturally, because you have seen that the aortoiliac artery disease, and I showed you because I wanted to put out that it's a female disease, predominantly female disease, short aortic stenotic lesion. So that's different. That is extensive disease, and these patients always have also somewhere else something. You have shown the coronaries. I have seen also that the vertebral artery was narrowed on the left side, so that is a generalized atherosclerotic process. So, and the life expectancy, even when you succeed and have such nice images as you have shown, such good results, the life expectancy is not really reduced with these patients.
Actually, for this diffusely diseased patient, this survival is quite good for this. Even surprisingly for us.
But they are obviously on a good medical treatment and everything.
Medical treatment.
Actually, there are two controversial things here. I want to emphasize two things. One is treatment of claudicants, and the other thing is performing such an extensive procedures. In my opinion, these kind of extensive procedures should be done only by highly experts. You didn't bold it. I think in your presentation you have bolded because this is really brand new procedure in our field in endovascular surgery, and I think it's very extensive. We have to take care to do it really successfully. And this is why I think treating claudicants should be really carefully selected.
Yes.
Because every complication is really different than treating...
We see that with this life case, how complicated it can be.
This is why I emphasize this.
Exactly.
Yes.
This is a very good example which we have.
So let's go to Ivo to see.
Ivo.
Yes.
Ivo.
I'm listening to you.
So what we see that you implanted the wall stent above the endurant, and what next?
Exactly, and this improved the things. We saw a small extravasation on the level of the left iliac artery. Go back. Go back. Okay. Play.
Yeah.
So, do you see there is a extravasation on the level of the left iliac artery, and because of that, next we
How is the
implanted
blood
this.
pressure?
It's 125.
Excellent.
And this is the stent graft implantation, Bentley 8 by 57. Next. And this is after the Bentley implantation, so there is no any more extravasation.
Excellent.
Is it true that we don't see the right renal artery?
Yeah, you are right. The right renal artery is not very well seen, so probably we are going to stop on the iliac and aortic level, and we are going to try to recanalize the right renal artery.
Yes, and the left, practically the result in stent of the left renal is, let's say, not perfect.
Good. It's acceptable, I would say. So you see that...
maybe a wire and balloon will be useful there, especially in this case with the occlusion of the right renal.
Yes, exactly.
Just at least one wire for safety, just
absolutely right.
To keep it open, and finally you can make a ballooning just for sure.
Yeah. Okay.
Okay, so Ivo, now it's your time for lecture, but I see that obviously it is impossible for you to give this lecture now. We will postpone it for the end. And now I would like to ask Professor Nikolov just to give him lecture about the Dr. Nikolov. Okay.
David Andriusiosem.
dear colleagues. My talk is about the hybrid treatment of the thoracoabdominal aneurysms. You know well the Crawford classification of the thoracoabdominal aneurysms. For more than 5 decades, the open repair is the gold standard of treatment. It is quite big trauma for the patient and challenging for the surgeon. Even in very high volume and experienced centers, the mortality rate is still between 6 and 16%. And also the morbidity is not negligible. It is mainly related to ischemia causing paraplegia or paraparesis, renal failure necessitating dialysis, stroke, intestinal ischemia, and despite all the adjuncts which are incorporated today to reduce the complications like left heart bypass, deep hypothermic arrest, selective visceral perfusion, distal aortic perfusion, cerebrospinal fluid drainage, these complications are still very important. So that's why the alternatives are sought. And after the introduction of endovascular therapy, for example, for the descending thoracic aorta, this replaced more or less the open surgery. This is not the same for the thoracoabdominal because here we have to deal with the visceral branches which have to be left perfused and cannot be covered by a simple tube graft. So to deal with this problem, there are several options. Total endovascular repair could be done with fenestrated or branched grafts. It is performed in selected centers with much lower morbidity and mortality, but there are still anatomic restrictions. The devices are most of the times custom-made, and there is time is needed for manufacturing. Important issue is the cost and the reinterventions with this procedure. The other possible solution is chimney, periscope, or sandwich techniques, well presented by Dr. Busquet. It is more accessible for emergency situations. It's a good option, but it's technically demanding, and the gutter leaks and endo leaks are also a problem. So here comes the concept of hybrid repair, which combines open visceral debranching, which is done with bypass from the iliacs or distal abdominal aorta, healthy vessel, and after that combined with simple TEVAR. That's in this way it is avoided the aortic cross clamping, the thoracotomy, also the single lung ventilation, the prolonged ischemia, and it can be done in 1 or 2 steps. But anyway, it was not. It was thought that it could have better outcome than open repair because it's a little bit less invasive, but in fact the results are very similar to open repair, and this is probably because these patients are the patients who are offered hybrid repair are more diseased, older, and refused for total open repair. I will demonstrate a clinical case of ours. This is a 47-year-old man with postprandial abdominal pain and progressive weight loss for 1 year. And for the last 6 months, he lost about 15 kilos. He has also arterial hypertension and ankylosing spondylitis bacterial disease. On the CT, you can see a Crawford type 5 thoracoabdominal aneurysm ending just at the level of the renal arteries. and there is also occluded celiac trunk and superior mesenteric artery. So, what are the treatment options? Open repair probably is a good solution because it's a young patient, but it is not very popular and applicable in our country. Especially this was the case which had to be done during the COVID pandemic, the third wave. We had very limited access to ICU and so on. So for sure this patient needs SMA revascularization, which could be done endovascularly as a step for any type of endovascular procedure. But I think this is quite dangerous because there is no stump of the SMA and it is arising from the aneurysm. I think the better option is aortomesenteric bypass. We decided, as we had to do an aortomesenteric bypass for relief of the symptoms, to perform also renal bypass. And this is in fact the first step of the visceral debranching. We did it with midline laparotomy with bifurcated 40/7 Dacron graft from the infrarenal aorta to both renal arteries, and additional 7 mm graft to the SMA. The patient had an eventful recovery with no renal insufficiency and no postprandial pain after the operation. A month later, we did the second step with local anesthesia and small femoral access. We implanted telescopically from down to up 3 endurant grafts, 2 iliac extension and 1 aortic cuff proximally. And you can see the good patency of the 3 grafts on the second image. This is the final result with patent grafts and well-isolated aneurysm. So, the results of hybrid repair summarized in a meta-analysis from 2020 shows results very, very similar to the open repair with almost the same or near complications. As I said, this is probably because these are patients which are refused in most of the times for any other treatment. So, what are the indications? Unsuitable for open repair. All the patients, comorbidities, mainly pulmonary disease, heart failure, previous operations. Also unfit for total endovascular repair, like unfavorable anatomy, small access, tortuosity, shaggy aortic arch, occluded visceral arteries, in situations of urgency. And there are also local factors, like in our case, like inability to settle patient in ICU, and also endografts availability, which is a very important issue in our country. I mean the modern grafts, the fenestrated grafts. In conclusion, open surgery of thoracoabdominal aneurysm remains the gold standard for patients with tolerable risk. The hybrid repair provides alternative option for high-risk patients. It's also offered to more fragile patients carrying significant morbidity and mortality. Despite the improvements of the branched and fenestrated grafts, hybrid approach might continue to have a role in the hostile anatomy or when these new grafts are not available. Thank you for your attention.
Thank you, Dr. Nicola. Many questions.
Thank you.
Actually, what I wanted to comment is that it is true that probably high-risk patients are selected for hybrid, but it is not only that, I think. As you showed in the table, there is high risk of spinal cord ischemia, which is not caused by high risk of patient, it is caused by nature of the procedure we are performing. We are not revascularizing actually spinal cord at all. And I think this is one of the main problems with hybrid. And they're not so easy to be done. I mean, I congratulate you for your case, but this revascularization of visceral arteries are difficult procedures.
How many patients you have with this? How many patients you have?
This is the first one.
This is the first one. Yeah. Okay.
Why did you use? Sorry for one more question. Why did you use this combination of stent grafts and not a regular thoracic graft?
Well, one of the things is that there was a discrepancy in the diameter. It was only 20, less than 20 distal infrarenal aorta, and about 30 the proximal. I didn't want to have
big oversizing.
Big oversizing. And the other thing is that endurance grafts are fully reimbursed.
Okay.
Okay. So another comment.
Should we go back then to
yes.
REM?
Let's.
Thank you, Dr.
Let's go back to the cath lab. Because our two remaining lecturers are in the cath lab. Ivo. Okay. You see that they wired. There is even balloon there.
Okay.
Ivo, do you
yes,
hear us?
Yeah, we hear you. We are. You saw we succeeded to cross the struts.
Yes.
And but unfortunately, the wire is aside of the stent, and now we are going to leave. We are going to leave this wire there in order to stabilize the system, and we are going to cross within the stent with a second wire. I mean the renal stent. And most probably we are going to limit ourselves with opening the left renal artery very well, because the contrast is a significant amount. And that's it.
How much is the contrast?
Yeah, it's 300 milliliters.
And what is the GFR of the patient?
It's normal.
Normal.
Normal. So it's absolutely normal, and it's under hydration.
Because
but nevertheless,
you have you crushed the ostium of the renal stent now, and you have to recross.
Yeah, most probably we are going to recross from the ostium to the middle part, and we are going to implant another one.
Yes, this is another option.
Yeah,
if it's not
absolutely.
possible, yes, if it's not possible to recross the stent, is just to crush the older one, the previous one, and to restore the patency.
Exactly, absolutely right.
What kind of wire is that?
It's a whisper.
You're still behind the stent struts, I think.
So we decided already. We are going to cross.
Okay.
And we are going to put a second stent ostial.
Okay.
Yeah, definitely. Okay, good. Дайте ми 3 на 15.
Maybe some longer balloon will be good option, because
in order to make the
you have to crush also the stent, so
yes,
15
you're right.
could be a little bit shorter.
Great point, absolutely, great point.
We will stay with you, because actually you and Zoran are the last lecturers, so...
in fact, my idea is to postpone these 2 lectures, to cancel. It's useless, I think.
Okay, we will cancel it, and if you agree, we can stay with you, or to close the session, how you prefer?
It's up to you. Probably follow me to cross the stent.
Yes, I think that it will be good just to see How you will manage this? It will be also practical, I think, for the colleagues, because
because we learn most from complications,
yes.
not from our successes.
Well, this is real life. I mean, this is real life.
Yeah, you're right.
It cannot be everything to go perfect. When everything go perfect, we are great. But this is the point where the real life comes, and we have to manage this. Any suggestions from the audience?
Is patient fit for any surgical revascularizations, maybe of the right kidney?
I see that they crushed the stent.
Сега ще видим. Сигурно се не плаче. Сигурно се ремонт, защото нищо отива там.
This is a non-compliant or compliant balloon?
This is a semi-compliant balloon.
Semi-compliant, okay.
And it seems the artery is huge.
Yes. But we have to keep in mind that not always it could be on the posterior wall, and sometimes it looks that the stent is staying the same, but it is actually ellipsoid, and crushing is on the AP projection. So this is what we see at the moment. Does not mean that the stent is not crushed.
I'm going to open now the struts in the ostium with a 5 millimeter non-compliant balloon.
Yes.
And after that, we are going to put a short, probably 6 millimeter stent at the ostium. And that's
Why don't you try a little bit longer stent, because it will be easier to position it just to escape this flow movement, because very short stent could slip easily.
The shortest that we have is 19, so it will be perfect, I think.
19 is okay.
Yeah.
And how you decide to manage the occlusion of the right renal artery?
Good question. I'm listening to your proposals.
Maybe if you try with ultimate Bros wire, because it is hydrophilic, and you can try to open it. Another option is just to be sure about this renal artery. They have, as far as I heard, they have ISEVS on the table. So you can use ISEVS just to check this renal artery, because the wires and the stent are, they stay quite bizarre. And maybe you should escape the wedging of the catheter into the ostium, just not, if there is a dissection, not to prolong the dissection inside the artery just behind the stent, because the powerful injection could actually extend the dissection distally. Just
in
be
fact,
careful.
the right Jacquins now is kept within the sheath.
Yeah.
So it's quite far away.
Yes.
Никол, моля те, не диши за малко.
Oh, great.
Dish it. Not bad.
Not bad, yes.
Yes, okay. We are going to proceed with stenting. It's very well seen that the stent is pinched, let's say, in the
Yes,
beginning.
maybe you should you should implant 2 stents, one distal and one proximal, because there is the dissection on the edge, and just to be sure that everything is covered.
Yeah, absolutely right. Okay, let's start.
Maybe Ivo, we will leave you just to work quietly, just not to bother you, because it is quite a complicated situation. And the case will be available later on the site, so everybody you can make a summary finally and to show the result. So thank you. Thank you so much.
Thank you, Ivo.
Thank you, Ivo. And I would like to thank you everybody for the patience and for the endurance to stay up to the end of the Congress. And we'll wait you next year again. Thank you so much for supporting us all the time.
Thank you. Bye-bye.